Hello, I am Dr. Shashank Bed and welcome to part 1 of the live series by Medico. So there will be 2 sessions, that is 2 days, and I will be trying to discuss all the important points of all the chapters in surgery. So let us begin with transplantation. Now, tissue transplanted from one individual to another is called as what? So let us look at the types of graft. This is an important topic and it is frequently asked in your exams. So you can have a homograft or an allograft. A homograft or an allograft is between the same species. So as you can see, there is the word homo. So it is the same species. Then you have something called a heterograft or a xenograft. A heterograft means between different species because the word hetero means different and xeno means foreign. So a xenograft can be of two types. It can either be a concordant xenograft or it can be a discordant xenograft. A concordant xenograft is one which is between closely related species. So humans were thought to be evolved from monkeys. So that is why we are related more closely genetically to the old world monkeys. So old world monkeys come into the category of concordant xenograft. Old world monkeys and apes. So the advantage with concordant xenograft is that there is no chance of hyperacute rejection, zoonotic disease or retroviral transmission. Next, we have something called discordant xenograft. A discordant xenograft is one which is between distant related or divergent species. So since humans are thought to have evolved from old world monkeys, so the new world monkeys will come under discordant xenograft. That is one thing. Other thing is, so humans are mammals. So the other mammals are all come under discordant xenograft. For example, pigs. So pigs are usually preferred. Supposing if a patient wants to undergo a transplantation and you have to use a xenograft, a pig is always the preferred organ because of its organ size as well as its availability. The problem with a discordant xenograft is it has a high risk of hyperacute rejection. So the hyperacute rejection is very high in a discordant xenograft. Then you have something called an autograft. So like you have autologous blood transfusion where prior to a surgery, a patient can donate their own blood, which can be used if necessary. So similarly, you have something called an autograft. So you would have seen during your internship that whenever there is a patient with a non-healing wound or a chronic diabetic foot in the wards, and it is taking a lot of time to heal. So in such cases, whenever the wound is appropriate, we can actually take a split thickness skin graft from the same patient and then use that graft for wound healing. So that is called an autograft. Auto means same, so it is a same individual. So an example of this is split thickness skin graft. Now what is an isograft? Iso, the word means the same, right? So there are some people who have a genetically identical twin. So these people, supposing if you donate an organ from one twin to the other, it is called isograft. Now an isograft, since they are genetically identical, therefore it means that they have the highest chance of success. But the most commonly used graft is an allograft. So for example, the most commonly used renal transplant or even maybe kidney transplant, renal or liver, whatever it is, the most commonly used transplant, the type of transplant is an allograft, obviously for common sense reasons. Okay, next, this is a very important topic of Maastricht classification. So now, if you look at the types of organ donors, you have living donors and you have dead donors. So living donor is, for example, say when a parent or a relative or a sibling or a friend, they decide to donate their organ to a person. So the person who's donating the organ lives after the donation and the person who gets the organ gets a new life. So that is a living organ transplantation. So that is one kind. The other kind is a dead organ transplantation. So you have living and you have dead. Now among the dead, there are two types. You have donation after circulatory death and you have donation after brain death. So this Maastricht classification, it refers to people who have undergone donation after circulatory death. Now to understand this Maastricht classification, so let us look at this table which is from Bailey and Love. Now do not use any mnemonics. This is a very simple classification and you look at it logically from the point of view, supposing say if you were a junior doctor in the casualty, how would you approach this? So two things bear in mind. You're a junior doctor in the casualty, and your only motto at that moment is to procure the organs of that patient for transplantation. So this will help you remember the various categories. So what is category 1? Category 1 is, so there's a patient who has come to hospital, he's in a serious state and he's dead on arrival. Maybe he died at home, maybe he died in the ambulance, maybe he died just while entering the hospital, whatever. When you have examined him, the patient is dead. So it is dead on arrival at hospital, that is category 1. So forget these two columns of, forget this column of type of DCD. I will discuss this with you later. So dead on arrival is category 1 and he has died, to simplify it, let us not complicate it by saying whether he died at home, ambulance or whatever. So he has died in the emergency department. Now category 2. Category 2 is the patient has come to casualty, he has come to the emergency department, he is in a serious state and you try to, while you're resuscitating him, the patient undergoes a cardiac arrest. So the patient undergoes a cardiac arrest and you are not able to resuscitate him successfully. So that is type 2. So here again the patient dies in the emergency department. What is type 3? Category 3 is, so the patient comes to the casualty, you have done a wonderful resuscitation. After resuscitation, you have shifted the patient to the ICU. All right. But even though you've done a wonderful resuscitation, you know that the moment the support is withdrawn from that patient will die. So there is anticipated, you are anticipating that the patient will die once support is withdrawn. So anticipated cardiac arrest is called category 3. Then what is category 4? So you know that when you're resuscitating a patient, you cannot take your own sweet time to resuscitate. You have to resuscitate the patient within less than 10 minutes because after 10 minutes, there can be permanent brain damage. So supposing the patient comes to casualty, the patient is in a serious condition, you resuscitate the patient, but then you take half an hour to resuscitate the patient. So by that time, because of brain ischemia, because of cerebral ischemia, the patient is brain dead. Now, if that patient dies, it is called category 4. So it is cardiac arrest in brain dead donor. This means, I'll repeat, this means the patient has come to casualty, you have done resuscitation, but you have taken longer than the normal time to resuscitate. So supposing, say, you've taken half an hour. So the patient is alive, but the patient is brain dead. So you shift that patient to ICU, right? So when this patient dies, he dies in the ICU. So that is category 4. Then what is category 5? Category 5 is this patient comes to casualty, you did a good resuscitation, you have sent the patient to ICU, and you start giving a treat to your colleagues saying that or your seniors saying that this is your first successful resuscitation. But while you are in the middle of your treat, you get a call from the ICU that this patient has died. So that is an unexpected cardiac arrest. And this patient dies in the ICU. So we've looked at the categories. Now let us look at the type of DCD, that is the type of donation after circulatory death. Now this type of DCD is purely seen from the transplant team's point of view. This means that, so now when a patient dies, supposing the timing of the patient's death is under the control of the transplant organ team, then it becomes a controlled death because then they know how much time the patient is going to be dead for, and that is called the ischemia time. So, the moment from the patient's death, to organ retrieval, this is called warm ischemia. So the patient has died and you're going to retrieve the organ. That is called warm ischemia, while the organ is still within the patient's body, within the donor's body. Now, once you retrieve the organ, so once you have, so organ retrieval to transplantation, that is called cold ischemia. So this cold ischemia time is basically where you're keeping the organ outside the body, right? So now let us look at whether it is controlled or uncontrolled. So it is called controlled when it is in the control of the transplant organs team. Now, supposing when the patient comes, he's dead on arrival, it is obviously uncontrolled. Why is it uncontrolled? Because you are not mentally prepared for this transplantation. You have to counsel the relatives and a lot of procedures. So it is an uncontrolled type. It is an uncontrolled type. Supposing if it is unsuccessful resuscitation after cardiac arrest, that too is uncontrolled, because you're not anticipating it, right? The patient has come to casualty and you're trying to resuscitate. At that moment, the patient dies. So that is also uncontrolled. Now, controlled is obviously when, so you would have noticed by now that uncontrolled deaths are happening in the emergency department, right? On the other hand, if the patient dies in the ICU, that will be a controlled death with one exception. I'll come to it. So, supposing if there is anticipated cardiac death, so you know that once you withdraw support, the patient is going to die, that is again a controlled death. So, why is it controlled? Since you know that the patient will die after you withdraw support, you can utilize that time to counsel the patient's relatives and ask them for an organ donation. So, that gives you time, right? That is a controlled death. Now, supposing, say, you've done an unsuccessful resuscitation, the patient is brain dead, but the patient is alive. That too is a controlled death, because there too you have time to counsel the patient's relatives for an organ transplantation. So, category 3 and category 4 are controlled DCD. Now, type 5, here the patient dies in the ICU, but doesn't matter if the patient is dying in ICU, it is still an uncontrolled type. Why? Because this was the type where you've given a treat to your colleagues, right? So in this type, you don't think that the patient is going to die. Since you're not mentally prepared about the patient dying, that is why it is called an uncontrolled type. Okay, moving on. So what is the commonest indication for liver transplantation in infants? Now the answer to this is biliary atresia. So let us look at some of the indications of liver transplantation. Now, the indications of liver transplantation fall into 4 groups. So first, you have chronic liver disease. So for example, you are alcoholics. Second, you have acute liver failure. For example, paracetamol poisoning. Third, you have metabolic liver disease. So any genetically based metabolic and any metabolic inborn error of metabolism will fall under this category. Then primary hepatic malignancy. For example, the patient has HCC or hepatoblastoma. So these are the 4 groups of liver transplantation. As in, these 4 patients will require liver transplantation. Now, the most common indication for liver transplantation is decompensated chronic liver disease. So these are the patients who have cirrhosis. They have cirrhosis for quite some time. And so initially what happens is every organ has a functional reserve, right? So initially the liver is trying to compensate for the disease and it is still working normally. But there is a time when when the functional reserve is not able to catch up with the disease. That is when it is called decompensated. So the most common indication for liver transplantation is decompensated chronic liver disease. Now in adults, what are the most common causes? So you have alcoholic liver disease, obviously. The number of people who drink alcohol will be more than the people who take paracetamol, or people who have HCC, or people who have an inborn error of metabolism. So the most common cause is alcoholic liver disease. Next, you have non-alcoholic fatty liver disease. Then you have chronic viral hepatitis. So hepatitis B and hepatitis C. So in countries where there is a low prevalence of hepatitis B, for example, in countries where there is a high vaccination rate, so in these countries, the proportion of patients receiving a transplantation because of hepatitis B will be lower, right? Than countries which do not have a high prevalence of vaccination. Next, we have autoimmune liver diseases. So for example, primary biliary cirrhosis, primary sclerosing cholangitis, autoimmune hepatitis, and chronic metabolic liver diseases. Chronic metabolic liver disease, for example, Wilson's disease. So you would have noticed by now that this acute liver failure, although it is obviously one of the groups of liver transplantation, it is not among the common types, right? Now, the specific frequencies of these etiologies depend on geographical variations. This is what I discussed. So in the last 2 decades, hepatitis related chronic liver disease, for example, hepatitis B and hepatitis C, it was the most common indication for liver transplantation in the last 2 decades. But with universal vaccination for hepatitis B and newer treatment options for hepatitis C, and with increasing obesity in affluent countries, non-alcoholic fatty liver disease is projected to become the most common indication for liver transplant in the future. So, supposing if you get a question in the exam, which is projected to be the most common indication for liver transplantation in future, in that question your answer should be non-alcoholic fatty liver disease. But supposing if you're asked a question which is the most common indication, so notice the difference in words. Most common indication will be decompensated chronic liver disease, and projected to be the most common indication for liver transplant will be non-alcoholic fatty liver disease. Now this is in adults. In children, the most common indication is a biliary atresia. Okay, so let us look at the indications of kidney transplantation. Now, the most common indication for kidney transplantation is end-stage renal disease. Just like in liver, you had decompensated chronic liver disease, here you have an end-stage renal disease. Now, what are the leading causes of end-stage renal disease? First, you have diabetes. The percentage of people with diabetes is increasing every day. So that is the most common cause. Second, you have hypertension. Third, you have chronic glomerulonephritis due to other reasons. So let us look at this box. So in this session, I have tried to put as many boxes and as many tables from Bailey and Love, because this is where the questions come from. So the most common causes of end-stage renal disease in overall, it is chronic. The first is diabetic nephropathy. This is first. The other causes are chronic glomerulonephritis, hypertension, renal vascular disease, polycystic kidney disease, chronic pyelonephritis, or obstructive uropathy. Okay, moving on. So let us move on to the topic of trauma. So let us discuss some of the commonly asked questions from trauma. So what is triage? Now, triage is basically, so whenever there is a disaster, for example, an earthquake or a flood, or there's a mass casualty, maybe there is a accident between 2 buses and both buses were full of people. So in such a scenario, you need to separate the people based on the medical need, right? So that separation of people, of patients based on the medical need is called triage. And you have, there are 4 categories of triage. Right, again, this box is from Bailey and Love. So your first category, that is your first priority, is the color red. So these patients, they require immediate need. That means if you do not give them immediate care, they will die. So what is the clinical status? It is these patients are critical, but they are likely to survive if the treatment is given early. So for example, if the patient has severe facial trauma, or maybe tension pneumothorax, or profuse external bleeding, hemothorax, flail chest, major intra-abdominal bleed, extradural hematomas. So you would have noticed that all the examples which are given here are the patients with ongoing bleeding or severe bleeding, or these patients, for example, hemothorax and pneumothorax are the conditions where the patient will not be able to breathe if this continues. So why is facial trauma included in this? No, because supposing if the patient is bleeding, say in the nose or in the oral cavity, he might aspirate that blood. Or secondly, because of say maybe a nasal fracture or something, the patient might have difficulty in breathing. So breathing and bleeding, these are usually the categories the examples which come under category 1. Next, second category is yellow. So yellow means these people require urgent need. So these patients are critical, but they are likely to survive if the treatment is given within hours. So for example, if the patient has a compound fracture, a degloving injury, a ruptured abdominal viscus, pelvic fracture, or a spinal injury. Next, third is green. Third is green. So this is non-urgent. So these patients are stable, they are likely to survive even if treatment is delayed for hours to days. Okay. And examples of this is simple fractures, sprains, or minor lacerations. Now, how do you remember what is category 3? So you would remember during your night duties, during your internship, there are some irritating patients who come in the night for simple problems. So those are the idiots who come under category 3. So they come at you are wondering why is this guy coming. So supposing he has twisted his ankle and he comes to casualty immediately. You are thinking in your head, why is he coming at 2 a.m. for this? Couldn't he have come in the morning for this? So this is the category which is type 3. So these patients are stable. I mean, I'm not saying that the patients do not have a problem. The patients have a problem. But here are the issues between survival and death. So these are the patients who are likely to survive even if the treatment is delayed for hours or even days. So supposing if a patient has a simple fracture or a sprain, he might have a deformity if you delay treatment for 4 or 5 days, but he will still live, right? And in triage, our priority is always between life and death. Okay, then what is this last category? Now the last category sounds cruel, but such is life. So this is the color black. So these are unsalvageable. So these patients are not breathing, they are pulseless. See, earlier the book said black is dead, but black basically, it means they are dead or they are so severely injured that they are not going to help even if you give them medical care, right? So they are not breathing, they are pulseless. So for example, there is severe brain damage, very extensive burns, major disruptions or loss of chest or abdominal wall structures. Right, so these are the 4 categories of triage. Now moving on, let us look at some of the trauma scores. So the question is, trauma and injury severity score, that is TRIS, it includes what? So let us look at some of the scores of trauma. First and foremost, let us look at Glasgow Coma Scale. Now a Glasgow Coma Scale it's very, very important from an exam point of view, and you can expect a question to come. So this is election time, so easy to remember. There's a lot of talk in the news about EVMs. So this is how you write the I'm sorry, there's a technical issue. Why is this not coming? So okay, I'll discuss it without the pencil. So now there are 3 categories. There are a Glasgow Coma Scale is of, so there is E, V and M, where E stands for eyes opening, V is for verbal and M is for motor. Now, what do you mean by eyes opening? So you will notice from looking at the table that the higher the score, the better the patient is. The lower the score, the worse the patient is. So now imagine that your friend is sleeping. Okay, an easy way to remember Glasgow Coma Scale. Imagine your friend is sleeping in the room, his eyes are not open. So that is 1. Now, supposing you're trying to wake him up, he is not waking up easily. So what you decide to do is you decide to do a sternal rub, or you give a painful stimulus. You might tap on the glabella. So if he reacts to painful stimulus, that is type 2. Supposing you shout his name, wake up, and he wakes up, then that is patient waking up to verbal command. That is Glasgow Coma Scale 3. Supposing the patient, you enter the room and the patient wakes up on his own, that is number 4. So 4 is spontaneously, 3 is okay. For Glasgow Coma Scale, it is better if you remember it from less to high. So you remember it this way: does not open, to painful stimulus, verbal command, and spontaneously. Okay. Next, let us look at verbal. So the score of EVM is always 4, 5, 6. The total score is 15, right? And you have 3 components, E, V and M. The minimum score, so do not open, it was 1. So the minimum score is always 3. Maximum score is always 15. You can never have a patient who has a Glasgow Coma Scale of say 1. Okay. So but supposing, say, when you look at verbal, supposing, say, the patient is intubated and not able to assess what the patient will be speaking, in that scenario, you have to write a score. So maybe E3, VT, and M6. Sorry, E4. E can be 3, 4. This is the maximum is 4. So E4, VT, M6. VT means you're not able to assess the patient. The patient is intubated. So earlier when Glasgow Coma scale came, they would give the sum addition. So they would tell the score is say 10 on 15. But in such a patient who's intubated, if you give a score of 10 on 15, it gives a different meaning, right? You will think that the patient has a severe injury. So what we do in Glasgow Coma scale is we always split the score and give. We always give it say E. We split it. We mention E score, V score, and M score separately. So now in an intubated patient, it is T. The patient is making no sounds, it is 1. If the patient is making sounds only, then it is 2. If the patient is speaking inappropriately or words only, then it is 3. For example, so sounds only means he's saying ba 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 ma 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 like a small baby talking. That is sounds only. Inappropriate or words only is supposing you ask the patient what is your name, he starts abusing your mother. So that is inappropriate or words only. This is type, the score is 3. What is confused? So you go to ask the patient, how are you feeling? Do you have any problems? And the patient tells you, I want dinner as fast as possible, or I want a burger as fast as possible. That is confused. And normally is 5. Let us look at motor. So no motor response is 1. Extension is 2. Abnormal flexion is 3. Withdrawal is 4. Localizing to pain is 5. Obeying commands is 6. So now let us look at it logically. So when you go to examine a patient, if the patient does not respond at all, it is 1. Now supposing supposing the patient is sleeping and you're trying to you shake the patient to wake up. The patient extends the arm. That is 2. Supposing he flexes but not completely, slightly he flexes. That is 3. If he withdraws from the stimuli, that is 4. Supposing you ask the patient where does it pain and the patient is able to point out, then that is 5. If the patient is able to obey commands, then that is 6. So now what is the importance of this Glasgow Coma scale? So the severity of head injury can be gauged by the total GCS. So in a patient who has minor head injury, in such patient the GCS will be 15 with no loss of consciousness. In a mild head injury, GCS is 14 or 15 with loss of consciousness. Moderate head injury is 9 to 13. Severe head injury is GCS 3 to 8. So usually if the score is 8 or less, it is an indication for intubation. Now what is GCSP? GCSP is calculated by subtracting the pupil reactivity score from the GCS. So if supposing say the GCS is say 11, from this if you subtract the pupil reactivity score, then that will give you the GCSP. So what is this pupil reactive score? It represents the number of non-reactive pupils. So we have 2 pupils. Both pupils are not reactive, it is 0. So here the score would be 11. If one pupil is reacting, it would be 10. If both pupils are reacting, it would be 9. So you would have noticed by now that the lower the GCSP score, the better. Okay, now let us look at revised trauma score. So revised trauma score, it combines the GCS, systolic blood pressure, and respiratory rate. So the mnemonic that I've always used for revised trauma score is GRB. Okay, so where G is for Glasgow Coma scale, R is for respiratory rate, and B is for the systolic blood pressure. In all these scores, it is always a systolic blood pressure which is important, more important than the diastolic blood pressure. Then you have something called a TRIS, that is the question which was of this question, trauma and injury severity score, TRIS. So TRIS will combines the injury severity score plus revised trauma score plus age plus mechanism of injury. So mechanism of injury, whether it is blunt or penetrating. So depending on that, you will get the trauma, the TRIS. Next, you have something called a mangled extremity severity score. This mangled extremity severity score is used when you want to decide whether to amputate a limb or not. This is an easy score to remember. You remember the mnemonic ELISA, where E stands for energy that caused the injury, whether it was a high injury or a low injury. So for example, if a patient falls from the stairs, it is a low injury. But if a patient is hit by a moving vehicle, it is a high injury. So E is for injury, LI is for limb ischemia, S is for shock, and A is for age. So moving ahead, what is the investigation of choice for blunt trauma abdomen in an unstable patient? So the investigation that you need to do in a trauma patient is a frequently asked question. So imagine, so now understand this, when a patient comes to casualty, your ultimate goal is to save the patient, right? Whether you are able to save the patient after an investigation or before an investigation is secondary, but your goal is to save the patient's life. So now supposing if a patient comes who is unstable, right? Now during your internship, you would have seen that there is no investigation which is happening in the casualty. All investigations happen in the radiology department, right? So you have to shift the patient. Now the patient is already unstable. You have to write a requisition. You have to shift the patient to radiology. After you shift the patient to radiology, you have to call the radiology PG and tell that please come and do a CT scan. The PG is happily enjoying somewhere else. Radiologist, if you're a topper, you'll obviously enjoy, right? So anyways, jokes apart, so you have to shift the patient to radiology. You have to write a requisition. The radiologist has to get everything ready. The technician will then do the CT scan that has to be interpreted. This takes a lot of time. So you obviously cannot do a proper investigation in an unstable patient because the patient will die by then. So if a patient comes to you in casualty and the patient is unstable, you need to decide what to do. So surgeons have come up with a scan called a FAST scan, right? FAST scan stands for Focused Abdominal Sonography for Trauma. So a focused abdominal sonography for trauma or a FAST scan, this is a technique. So even though it is an ultrasound scan, it is done in the casualty itself. A FAST scan is done by the surgeon and not by a radiologist. So all surgeons should know how to do a FAST scan. So it is a technique whereby ultrasound or sonography imaging is used to assess the torso. What do you mean by torso? The thorax and the abdomen for the presence of free fluid in the abdominal cavity. So the only goal of FAST scan is to see whether there is a free fluid in either the thorax or in the abdominal cavity. As a surgeon, I do not want to know whether there is a gallstone or not, whether there is the liver is cirrhotic or not. That is not my goal. Whether the liver is homogeneous or heterogeneous, that is not my goal. Whether there is a tumor in the liver, that is not my goal. My only goal as a trauma surgeon would be to assess whether there is free fluid in either the thorax or the pelvic cavity, because based on that, I can then decide what to do, what my next treatment goal would be. So when a patient comes to you who is unstable, okay, supposing say the question is the patient is hemodynamically unstable, the patient comes to casualty, what do you do? Now, the answer is FAST in this question. But supposing, say, there was one more option. So there is a fifth option which says exploratory laparotomy. And the question is something like the patient comes to you with a pulse of 120, the systolic blood pressure could not be measured. So this patient is obviously hemodynamically stable. This patient is obviously in shock. So for such a patient, there is no need to do a FAST scan. You can shift the patient to OT directly. Here in this question, since they have not given the option of exploratory laparotomy, the answer is a FAST scan. So a FAST scan is a technique where ultrasound imaging is used to assess the torso for the presence of free fluid in either the thorax, in the abdominal cavity. Now, supposing if you combine the thorax along with the FAST, so thorax plus abdomen. Now, abdomen is a FAST scan. Supposing if you add the thorax to it, then it becomes an extended FAST scan or an E-FAST. So like I said, no attempt is made to determine the nature or extent of the specific injury. So E-FAST is usually a rapid reproducible. Reproducible means what? You do it or I do it or some other surgeon does it, we'll get the same results. It is rapid, reproducible, it is portable. Why is it portable? Because that is why you're doing it in the casualty itself. It is a non-invasive bedside test and can be performed at the same time as resuscitation. So when the patient comes to casualty, there is maybe the nursing staff is putting an IV line. They're putting an IV cannula. You might be putting a Foley's catheter. You might be attaching up the BP cuff or the pulse oximeter. While that is being done, you are going to be doing an EFAST scan. So an EFAST scan is accurate at detecting more than 100 ml of free blood. All right. So supposing say the blood is say 80 ml or 70 ml, 50 ml, it might be difficult. But if it is more than 100 ml, then EFAST is considered to be accurate. But the problem with EFAST is it is operator dependent. So you would have noticed that some radiologists, even though they are toppers, some of them give very sane reports, some of them give insane reports. So for example, you send a patient for a scan, any CT scan, USG, whatever, not a CT scan, I mean, you send the patient for a USG scan, a normal USG scan, not the fast scan. You might have 2 or 3 radiologists giving 2 or 3 different reports, right? That means it is operator dependent. The more skilled the radiologist is, the better report you will get. But that is not the case with CT scan. In CT scan, what happens is, you get the technician does the CT scan, you get the plate, everybody looks at the plate, and then you can give the report. So it is not operator dependent. Why is USG operator dependent? Because the radiologist has to place the probe, right? They have to place the probe and then see what problem the patient has and report it. So because they have to place a probe, and while placing the probe, they can look at the image in the screen. That is why it is operator dependent. So the problem is it is operator dependent. So a surgery PG during his MS has difficulty in learning surgery only. You have to teach him how to operate a USG also. So he may not be as good as a radiologist, obviously, right? So it is operator dependent. And supposing say the patient is very obese, or if the patient has bowel is full of gas, then it is unreliable. So let us look at this image, which will simplify what a fast scan is. So in a fast scan, what are you doing? Your idea, when you look at the right upper quadrant, right upper quadrant is the hepatorenal pouch. So that is where the liver is. So if there is any bleeding from the liver, it accumulates in the right upper quadrant. Then if it is in the left upper quadrant, that is the site of the spleen. So this is your, so these two, one is right upper quadrant, 2 is left upper quadrant, 3 is pelvis. So if there is any blood accumulating in the pelvis, or if there is blood in the pericardium, then it is a fast scan. Supposing if you add both the lungs to this, if you add both the pleural cavities to this, then it becomes an EFAST scan. Okay. Now a 27-year-old patient presented with a left-sided abdominal pain 6 hours after RTA. So if he is presenting to you with abdominal pain 6 hours after RTA and he is hemodynamically stable, all right, and the patient is fast positive, that means there is some amount of bleeding in the left upper quadrant. Over here there is some bleeding, right? But even though there is bleeding, the patient is hemodynamically stable. So CT scan showed grade 3 splenic injury with contrast blush. Now what do these terms mean? And how will you manage this patient? So firstly, if the patient is hemodynamically stable, there is no indication for doing a laparotomy. There is no need to operate the patient. So straight away, 2 options are ruled out. Splenectomy is ruled out. Splenography is ruled out. So you are left with 2 options. Splenic artery embolization or conservative management. Which is the answer between these 2? So now supposing say, in this question they had not mentioned this, supposing in this question they had not mentioned this contrast blush. Okay, so it would just be that the patient has presented with abdominal pain 6 hours after RTA. He is hemodynamically stable, fast positive, CT scan shows grade 3 splenic injury. If that was the question, your answer would have been conservative management. But here they have specifically mentioned contrast blush. So what is this contrast blush? So before that, whenever you say that there is contrast blush, the answer will be splenic artery embolization, because contrast blush, it means that there is some ongoing bleed which is happening, or there might be a pseudoaneurysm formation. So what does this blush mean? So when you do an angiography, supposing say this is the blood vessel, right? So what do you mean by blushing? So supposing say, the girl or the boy who comes and speaks to you for the first time, your cheeks are fully red, right? So that is called blushing. Now, you don't have a specific one point which is red, the entire area becomes red. So similarly in angiography, so this is the blood vessel, and you can imagine that there is some amount of dye which is leaking in a diffuse area. That is called a contrast blush. That is always an indication for splenic artery embolization. So let us look at the grades of splenic injury. So grade 1 is a hematoma. It is subcapsular and it is less than 10% of the surface area. So in grade 1, it is only hematoma. From grade 2, laceration starts. So laceration which is less than 1 centimeter depth, or hematoma which is 10 to 15% surface area and less than 5 centimeter in diameter. You have to memorize this table. There is no shortcut as far as this table is concerned. Grade 3 is there is a laceration 1 to 3 centimeter parenchymal depth. So this was 1. This is 1 to 3. Grade 4 is more than 3. This is the laceration. Hematoma, grade 1 was less than 10%. This is 10 to 50%. This is more than 50%. Okay. Grade 4 is you have a laceration more than 3 centimeter, or the laceration involves segmental or hilar vessels which produces major devascularization. This means that the bleeding is such that part of the spleen is no longer getting a blood supply. And that part is more than 25%. Grade 5 is a completely shattered spleen, or a spleen which is devasculated by a hilar injury. This means, say supposing this is the spleen, all right, and this is the hilum which carries the blood vessel. So this is the artery, this is the vein. Okay. Now, supposing there is a hilar injury and this becomes injured. So the spleen is separated from its vascular supply, or if the spleen is shattered, then that would be called a grade 5 injury. Now, even though the option says splenectomy and splenography, technically doing a splenography is extremely difficult. A splenography is very, very difficult, and most surgeons, they prefer to do a splenectomy rather than doing a splenography for various reasons. One reason is, so in a trauma case, the patient has already been bleeding. So in a trauma case, there is something called damage control. It is in the question later on. I will discuss it in detail there. But your main idea in a trauma patient is to save life or limb, right? So if you start, because the patient's physiological reserves do not permit you to do an extensive surgery, and doing a splenography will take time. So rather than that, you do a splenectomy. Okay, so the presence of a contrast blush on CECT, it represents active hemorrhage or a false aneurysm of intraparenchymal branches of the splenic artery. Why you have to do an embolization is because these false aneurysms may gradually enlarge and rupture. So this area that I mentioned to you, it's like a balloon. This area, it might enlarge and suddenly burst. So this is an indication for angiography and embolization in stable patients. So instead of doing a splenectomy, you do if the facilities are available, if the patient can afford it, you do an invasive radiological technique and you embolize that. Now, vigorous resuscitation, it remains the key to management of blunt trauma. All right. Supposing if the patient comes to you in casualty, he is hemodynamically unstable, and you shift the patient to OT. You have to shift the patient to OT, but during the process of the patient coming to the casualty and you taking the patient to the OT, you have to give appropriate fluids. So that resuscitation is always the key to management of blunt trauma. So splenectomy should be performed for severe grades of injury where control of bleeding takes precedence over measures to salvage the spleen. So in an emergency, your idea is to save life or to save limb. Save life, save limb. All right. So your idea is not to save the spleen. Your idea is to save the patient. That is why you might need to do a splenectomy. Now, splenic angiography with embolization of actively bleeding vessels may obviate the need for splenectomy. All right. That means, so since you have controlled bleeding, it means you need not have to do a splenectomy. But still, if the patient is hemodynamically unstable, you always have to consider doing a laparotomy. So that should not delay a laparotomy in an unstable patient. Next, let us look at something called, so what is Pringle's maneuver and what is it used in? So let us look at a diagram. So in this diagram, you can see the liver over here, you can see the gallbladder, all right, and you can see the stomach, pyloric antrum, this is a duodenum. So C loop of duodenum is beneath this, all right. And here you have something called the hepatoduodenal ligament. This hepatoduodenal ligament is where the blood supply of the liver is entering the liver. This contains the hepatic artery, it contains the portal vein. It also contains the hepatic veins. Now, whenever there is trauma to the liver bleeds a lot. So whenever your surgeons who are operating on the liver, even if you're doing a lap cholecystectomy and you accidentally injure the liver bleeds a lot. The liver is a highly vascular organ and it bleeds easily. So whenever the patient has a liver injury which is such that it is bleeding profusely and you need to buy time to either think. So when you see that much amount of blood in the operating table, you get scared, right? So when you need some time to stop bleeding so that you can think, you can regather yourself, you need to do a maneuver which will save the life of the patient then and there. So for that, there is something called a Pringle maneuver. So in Pringle maneuver, what happens is you clamp those structures in the hepatoduodenal ligament. So once you can clamp it either using a vascular clamp, an instrument, so you can even use your fingers temporarily till the clamp is available. So once you occlude the structures in the hepatoduodenal ligament, bleeding stops. That maneuver is called a Pringle's maneuver. That maneuver is called a Pringle's maneuver. So it is used in liver trauma. Now, once when I was doing, in my initial stages of my career, when I was learning a lap cholecystectomy, I had to convert a case from lap to open, right? So when I converted the case, since I was hesitant, my incision was small. So in a lap chole, you place 4 ports. You place an umbilical port, place an epigastric port, you place 1 port in the mid-clavicular line, you place one in the mid-clavicular line, one in the anterior axillary line. So when you open this case, you have to make an incision from the epigastric to the mid-clavicular port. So the first time that I converted the case, my incision was small. So by then I had to call my seniors, and when my boss came, the first thing that he told me was, your incision should have been bigger. The incision should be big enough so that your hand can go in and you can perform the Pringle's maneuver if necessary. So Pringle's maneuver is clamping of the hepatoduodenal ligament by an atraumatic clamp across the foramen of Winslow to temporarily stop complete vascular inflow to the liver. So it contains the hepatic artery, the portal vein, and the common bile duct. Okay, so it was initially described by Pringle for controlling bleeding due to traumatic liver injury, but it is commonly used during elective hepatic resections. This was why my boss had scolded me to increase the size of the incision. Okay. Now, what is this damage control surgery that I just discussed? Now, the essential components of damage control surgery are all except. So they are asking what are the essential components. All right, this key word here is essential. So the essential components of a damage control surgery is always to save life and to save limb. There are 2 things which are important in the same order. First idea is to save life. Second is to save limb. Okay. So initial laparotomy, yes, it is an essential component because only by doing a laparotomy you can save a patient's life. ICU resuscitation, yes, because a patient who is where you're thinking of doing damage control surgery, such a patient would have bled a lot, such a patient might be in shock. He would have exhausted his physiological reserves. So the key is a successful resuscitation. Definitive reconstruction, no. So like I told you in the spleen question, your idea is to save the life and not to save the spleen. So there is no no role of doing a definitive reconstruction, because see, when you're operating on a patient, supposing say a patient has come to casualty with shock, right? You cannot do a 10-hour surgery. You have to go in, come out as fast as possible. All right. If you spend 10 hours, the patient will not be able to tolerate that 10 hours of anesthesia and the surgery, because the surgery itself is also a trauma, right? So already the patient has had a trauma, and on top of that, if you want to do a 10-hour surgery, it is not possible. So arterial embolization or clamping, yes, this is an essential component, because this will also help in stopping bleeding. So damage control surgery, it aims to break the vicious cycle of hypothermia, tissue hypoxia, coagulopathy, and acidosis before definitive repair. So these three components of acidosis, coagulopathy, and hypothermia, these three together are known as the triad of death. So if these are present in a patient, then the patient is likely to die. So in a damage control surgery, your aim is to break this vicious cycle of these components before you do a later definitive repair. So later you can do the definitive repair. So DCS aims to save life and save limb. Definitive reconstruction is done, but it is done in the end, and it is not an essential component. So this is a very important line. Anatomy is restored when the physiology is optimized. So once you optimize the physiology of the patient, then you think of looking at the anatomy of the patient. So what are the principles? And the principles in sequence are: you do a short operation which aims to control hemorrhage and to limit contamination. Say, for example, the patient has had a bowel injury, or maybe a biliary injury. You do a short operation to limit contamination. All right. After that, once you do the short operation, then you have to do an ongoing correction of deranged physiology. So what do? You will try to remove the patient from the triad of death. So you take care of the acidosis, hypothermia, perfusion, and organ function on intensive care. That means you shift the patient to ICU. If the patient requires it, you might have to dialyze the patient. You might have to intubate the patient. You might have to put the patient on inotropes. Whatever it is, you do that resuscitation in the ICU. Once the patient is stable, so it has been a few days, then you will do a definitive surgical repair. So when you do a definitive surgical repair, there is no fixed time, whether it is 2 days or 4 days or 5 days or 7 days, depends from individual to individual. But that definitive surgical repair, it will be done in the end. So if you come back at this question, when you come back to this question, definitive reconstruction is a part of DCS, but it is not an essential component. All right. So in MCQs, you usually tend to get confused, or you tend to go wrong because of 1 or 2 words. In this question, the word essential is important. So damage control surgery is typically divided into several phases. Now, in the previous editions of Bailey and Love, there was a bit of confusion between that there is 3 or 5 stages, but in the new edition, they've clearly mentioned 4 stages. So now let us discuss what those 4 stages are. So phase 1. So for any surgery, they will tell you, or for any intervention for that matter, you have to do good patient selection. So there are some treatments where you require good patient selection. So that means maybe a certain drug or a certain surgery or a certain treatment is very good, but it has to be, you have to select your patient properly. All right. Supposing if you do not select your patient properly, the drug or the treatment might be good, but it will still fail because you've not selected the patient properly. So phase 1 is always patient selection. So how do you select the patient? You recognize the injury severity. You can use the help of all those trauma scores and the need for damage control principles. That means you decide, looking at the patient, whether this patient requires a definitive surgery or a damage control surgery. All right. So features of phase 1 will therefore include rapid sequence induction of anesthesia and intubation. So he might have to be intubated in the casualty itself. Early rewarming and prompt movement to the operating theatre. So you do all this fast and then you go to the OT. Then you call the boss. Surgeons are always the boss. So the anesthetist does the work first, does the preliminary groundwork, and then calls the boss. Boss, please come and operate. So phase 2 is an immediate laparotomy. Your idea is rapid control of bleeding and contamination, abdominal packing, and temporary wound closure. So what does this mean? Rapid control of bleeding means, for example, in the liver, you might have to do a Pringle's maneuver. You might have to do a perihepatic packing. Your idea is to control the bleeding as soon as possible. Supposing, say, there is contamination. This means, let us say that there is a bowel injury. There is a lot of stool in the abdomen, or the contents of the bowel have leaked. So in that scenario, you feel that there is no point in repairing the bowel. Repairing the bowel is a definitive surgery. So what do? You create a stoma. Because supposing if you were to, supposing say if you were to repair the bowel definitively, then what would happen? Then first of all, the patient may not be able, the patient might be in such a stage that he may not be able to, the anastomosis would not take properly. Fine, that is one thing. Second thing, he might not be able to tolerate that long procedure. So temporary wound closure means, you might, supposing say you do a laparotomy, you might have to place a Bogota bag. Bogota bag means what? You have not approximated the abdomen, but you've left it open, you've kept a bag outside. All right. So after you do a phase 2 or a heroic surgery, then you shift the patient to the ICU. You again give the patient back to the anesthetists. So the boss does only the important work. The boss gives the groundwork and the later work again to the anesthetist. So the patient is moved to the ICU for ongoing resuscitation with normalization of biochemical and physiological parameters. So just for joke, I'm trying to put the anesthetist down. Phase 4, again, when the anesthetist or the ICU people, they have optimized the patient properly, that is when you will take the patient back to the OT to re-explore. You will do something called a second look laparotomy. In that second look laparotomy, you might do a definitive repair. So for example, you might have to do a bowel repair. You might have to do a definitive liver repair. All right. So depending on the injury, multiple procedures on multiple occasions may be required. But even at this stage, the non-essential procedures may be truncated. That means they have to be shortened or delayed if the physiology deteriorates. So these are the 4 phases of damage control surgery. Phase 1 is patient selection. Phase 2 is a laparotomy. Phase 3 is in the ICU, again resuscitation. Phase 4 is a second look laparotomy. So 2 and 4 is where the surgeon is involved. 1 and 2 is where, 1 and 3 is where the anesthetists are involved. So we shall take a technical break here for a few minutes, and then we'll resume our session. So in the previous session, I got a comment by a student asking whether the answer should be explorative laparotomy or not. So supposing in the options they have, if so here what I've mentioned, what I did was, I said if they've given 5 options, where if one of the options is explorative laparotomy, then the answer will always be explorative laparotomy in an unstable patient. Here, since the patient, the option is only fast, the answer is fast. But in the question, whenever there is the term unstable patient mentioned and you have 2 options, fast or an explorative laparotomy, your answer will always be explorative laparotomy. The reason is, even if you do a fast and you see that the patient is hemodynamically unstable, you're already anticipating that there will be some bleeding in the thorax, in the abdomen, or if it is an e-fast, in the thorax. So you will want to do a laparotomy if there is bleeding, right? So if it is unstable, your answer should always be exploratory laparotomy. Okay, so moving ahead. Okay. Now a patient after an RTA comes presents with respiratory distress, hypotension, and dilated bulging neck veins. Okay. On examination, the breath sounds are absent and there is a contralateral tracheal shift is found. So what would be the first line of management? So let us assess this question. He comes to the casualty with a respiratory distress. That means there is some lung injury or some pleural injury. There is hypotension. That means because of the lung injury, there is also a vascular injury. There is some amount of bleeding. That is, there is some amount of hemothorax. And there is dilated bulging neck veins. This means that the pressure in the thoracic cavity is so high that because of back pressure, these neck veins, they become dilated, right? And that means venous return is not able to happen from the head and neck to the heart because the thoracic pressure is high. In such a scenario, it means that the pressure in the thorax is high. So now there are 2 things in this. If there is hypotension, that means there is some amount of blood. Also, there is respiratory distress. Whenever there is respiratory distress, if this is mentioned in the exam, your answer will always be a pneumothorax. In this case, it is a hemopneumothorax. You have to differentiate this from a cardiac tamponade. In a cardiac tamponade, you will get a similar picture, but you will never ever get respiratory distress in cardiac tamponade as far as an MCQ is concerned. So the moment the term respiratory distress is mentioned, it means they're giving you a clue as to which organ is involved. Fine. So on examination, there are absent breath sounds. So even if this was not mentioned in this question, supposing this question was separate and they did not mention breath sounds, they just told you about respiratory distress. Even then, your answer would still be the lungs are involved. So there is absent breath sounds and there is contralateral tracheal shift is found. That means on one side there is accumulation of air and blood to such an extent that it is pushing the trachea to the other side. So what would be the first line of management? Now, in the earlier editions of Bailey and Love, that is to say the conventional teaching was, when a patient comes to the casualty, what do you do in such a case? In an emergency. So the answer would always be, you insert a wide bore needle in the second intercostal space. So why do you insert in the second intercostal space? Because the second intercostal space is higher up, right? So your idea is, so if there's respiratory distress, your idea is to evacuate the air as fast as possible. Your idea is to evacuate the air as fast as possible. So if you insert a wide bore needle, it acts like a pressure cooker valve and all the air comes out. Now, supposing, say if there were to be only hemothorax, the patient can, if there's ongoing bleeding happens, but if you put a wide bore needle, will the blood come out? Yes, the blood does not clot in a hemothorax because there is continuous movement over there between the lung is trying to expand and contract, right? So because of that, the blood does not contract. So conventional teaching was, in such a patient, you always insert a wide bore needle in the second intercostal space, all right? So conventional teaching was, you do rapid insertion of a large bore cannula into the second intercostal space in the mid-clavicular line of the affected side. So in this question, so there is, you have bronchia, trachea, all right. So supposing if say there is collection of blood over here on the right side, then this trachea on the left will shift further, correct? Now, so if there is shift to the contralateral side, that means this, supposing there is shift to the left, that means the right is involved. So you have to insert a wide bore cannula in the on the right side. Now, after you insert a wide bore cannula, then you will put a ICD. I think while talking, I told right left too much. Let me just clarify this. So this is your trachea, this is the bronchi. Now, supposing there is bleeding over here, then what will happen? This trachea, it tends to get shifted, right? So if there is shift to left, that means the pathology is on the right. If there is shift to right, that means the pathology is on the left. So once you determine the affected side, you place a large bore cannula. And once you place a large bore cannula, you allow some of the air to escape, and then you put a chest tube. So if there is respiratory distress, that means there is a pneumothorax, and it is a tension pneumothorax. Because of the tension pneumothorax, you're going to get dilated bulging neck veins, you're going to get contralateral tracheal shift. So why is there absent breath sounds? Because the air and the blood which is accumulated is so much that it has collapsed the lung on that side. So now this was mentioned in the earlier editions of Bailey and Love. In the present edition of Bailey and Love, in the new edition, they have not mentioned this concept of inserting a wide bore cannula. So if this question were to come in your exam today, when you give your NEET after a few days, your answer will always be an ICD insertion. So for such patients, you have to do a decompression. That is, you try to evacuate the contents. You place an ICD in the triangle of safety. All right. You place a ICD in the triangle of safety. This triangle of safety is bordered by the latissimus dorsi, by the pectoralis major, and a line which is at the level of the nipples. All right. So you place an ICD over there, and when you place an ICD, that pleural cavity, it gets decompressed because the blood and the air can come out. Now, supposing this patient has come to you the patient is in distress, there is no ICD available, then what do you do? So what they are saying is, supposing if the patient is in extremis means the patient might die if you do not give any intervention. So what do you do? In the new edition of Bailey and Love, it says that you do a finger thoracostomy at the same location. So this concept of inserting a wide bore cannula was only in the earlier editions. If this question comes to you in the exam, I don't think the examiner will give you the option of wide bore cannula. So your answer will either be putting an ICD in that site, or you do a finger thoracostomy. This means that where you're going to put your ICD, you make an incision so big that you can put your finger inside. So because of that, it creates an opening in the pleural membranes, and the contents can come out. Okay. Now moving on. A 40-year-old male is brought to the emergency room with a stab injury to the chest. On examination, the patient is found to be hemodynamically stable. So stab injury to the chest, hemodynamically stable. Neck veins are engorged and the heart sounds are muffled. So the reason I put these two questions together is just to give you an idea. So here also, see, the neck veins being engorged is not a clue of whether it is a lung injury or a heart injury. In the previous question, see, they have specifically told you, one moment. In the previous question, they have specifically told you absent breath sounds. This means the lungs are involved. In this question, they have told you that the heart sounds are muffled. That means the heart is involved. All right. The neck veins being engorged is not a criteria whether it is a tension pneumothorax or a cardiac tamponade. So in this patient, he has come with a stab injury to the chest. He is hemodynamically stable. The neck veins are engorged and the heart sounds are muffled. So what does this mean? This means that there is some amount of there is cardiac tamponade. So the following statements are true for this patient except. So what should you do? Cardiac tamponade is likely to be present. This is true. Immediate emergency room thoracotomy should be done. No, this is false. This is false. What are the other options? An echocardiogram should be done to confirm the pericardial blood. Yes, it can be done. So now you will be wondering, there is collection of blood in the heart. How can they say echo? Because for an echo, you have to shift the patient again to the echo room. But look at the question. They say that the patient is hemodynamically stable. So you have time. So if the patient is hemodynamically stable, you can shift the patient to the echo room and you will get an echo done. The entry wound should be sealed with an occlusive dressing. This is also true. Now, the answer is immediate emergency room thoracotomy. So now you need to know two things. One is you can do an emergency room thoracotomy. This is done only in emergency cases. Here, since they have specifically told you in the question that the patient is hemodynamically stable, there is no role for doing an immediate emergency room thoracotomy. So the words of the question are very, very important. So since the patient is hemodynamically stable, you will not be doing an immediate emergency room thoracotomy. You will get an echo done. You will know the exact nature of injury. You will take the patient to OT. In the OT, under controlled conditions, you will be doing a thoracotomy. If you do a thoracotomy in the emergency room, that is in the casualties, all of you have done your internship, you know how well a casualty is equipped, right? So, sorry. So if the patient is hemodynamically stable, there is no role for doing there is no need to be a hero in the casualty. You shift the patient for an echo, know the definite injury, and then you do a thoracotomy in the OT. So let us discuss this question further. So all patients with penetrating injury anywhere near the heart, plus they are shock, they must be considered to have a cardiac injury until proven otherwise. So a patient has come to you with a penetrating. So there is a knife over here. All right, there is a knife over here, and the patient is in shock. So your brain will automatically think that there is a cardiac injury, right? So until you prove that it is not a cardiac injury, it is a cardiac injury. So how do you prove it? When you start examining, you notice that when you do an X-ray, there is tracheal shift, there is absent breath sound, then that means it is a lung injury. Okay, so classically a patient with a cardiac tamponade, they present with something called a Beck's triad. So what is this Beck's triad? There is central venous pressure elevation which causes jugular venous, that is, there is dilatation of neck veins. Dilation of neck veins. There is hypotension with tachycardia, that is, the patient is in shock. There is muffled heart sounds. This muffled heart sound is key. This is giving you, see, central venous pressure elevation causing neck dilatation and hypotension with tachycardia can also be present in a hemothorax or a pneumothorax, all right? But muffled heart sounds, if it is present, that means it is a cardiac injury. So that is why muffled heart sounds is a component of Beck's triad. Now, in cases in which major bleeding from other sides has taken place, the neck veins may be flat. This means that if the patient has a stab injury in the chest, but he also has a stab injury in the lower limb, which is causing profuse bleeding, so that patient does not have enough blood for the neck veins to be dilated. Got it? So how do you investigate such a patient? You will do an EFA scan. This shows fluid in the pericardial sac. This is the fastest and the most reliable diagnostic tool. You will do a chest X-ray which will show an enlarged heart shadow. Now, what is a treatment? Now, pericardiocentesis has no role. Pericardiocentesis means doing a cardiac tap. Pericardiocentesis has no role in the management of cardiac tamponade secondary to penetrating myocardial injury. This is very, 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 very important. Look at the words carefully. If there is a penetrating myocardial injury, there is no role for doing a pericardiocentesis. You can do a pericardiocentesis if there is a blunt myocardial injury. All right. So, penetrating you will do no pericardiocentesis, but in a blunt injury, you can do it. I'm sorry. So now the correct immediate treatment of tamponade is operative. All right. With repair of heart in the operating theater if time allows, or otherwise in the emergency department. So why they're saying time allows is you shift the patient to the OT and you do the treatment of tamponade under controlled conditions. Now, supposing that is not possible, you do it in the emergency department. So now, supposing if you want to do if you want to operate on this patient, how do you approach the heart? That is, what kind of an incision do you use? So there are two things. You can either use a sub-xiphoid window. That means you place an incision below the xiphoid process. Or you can do an open surgery. If you do an open surgery, you can either do a sternotomy, that is, you place an incision in the middle on the sternum, or you can do a left anterolateral thoracotomy. So thoracotomy for the heart will obviously be done on the left side because the heart is on the left side. So this is the second option. Now, coming to the previous question, coming to the previous point as to why you will not do pericardiocentesis in a penetrating trauma. The answer is, supposing there is penetrating injury to the heart, there is usually a substantial blood clot in the pericardium. All right, that will prevent aspiration. So please look at the difference. A hemothorax very rarely clots. Never say never in medicine, but a hemothorax extremely rarely clots. It is as good as not clotting, fine. But if there is blood in the pericardium, then that can clot. Okay, a male was brought unconscious to the hospital with external injuries. CT brain showed no midline shift, but basal cisterns were compressed. Basal cisterns were compressed, and there is multiple small hemorrhages. What is your diagnosis? The answer is diffuse axonal injuries. Let us look at this diffuse axonal injury in slight detail. So a diffuse axonal injury, it is a form of primary brain injury which is seen in high energy accidents. Usually following a DAI, the patient becomes comatose and the prognosis is very poor. What are the causes? So as the name says, it is a diffuse axonal injury. So there is damage to the axons throughout the brain, and this damage is due to rotational acceleration and then deceleration. So rotational acceleration and deceleration. This usually causes diffuse axonal injury. So now what is the pathology of this patient? So the axons may be completely disrupted and they might retract. So supposing say this is a neuron, this is the axon, right? There is an injury over here. So what happens is this retracts and you might get an axon ball. So supposing if the term axon ball is mentioned to you in the MCQ, it is diffuse axonal injury. Along with that, you will get hemorrhagic foci where you will get it in the corpus callosum and in the dorsolateral rostral brainstem. So patient is comatose or impaired arousal. It is considered to be a severe form of concussion, often with irreversible consequences. This is important. This is why these patients have a poor prognosis. There is one differential diagnosis, which is that of a basilar thrombus. How do you investigate? So diffuse axonal injury is usually a post-mortem diagnosis. It is a pathological diagnosis, not a radiological diagnosis. However, when you do a CT scan or an MRI, you might get some clues which might point to a DAI. It will not be definitive, but they might give you clues as to it being a DAI. What are those clues? So there might be hemorrhagic foci in the corpus callosum and dorsolateral rostral brainstem. So these words are important: corpus callosum and dorsolateral rostral brainstem. Then there is a loss of gray and white matter differentiation. So these things are seen on a CT scan, but they are better appreciated in an MRI. Okay, so coming back to the question. So a male was brought unconscious to the hospital with external injuries. CT brain showed no midline shift, but basal cisterns were compressed. This is because of hemorrhage near the corpus callosum and dorsal rostral brainstem, and there is multiple small hemorrhages. So if you remember over here, where is that mentioned? See, hemorrhagic foci. So this hemorrhagic foci is nothing but this multiple small hemorrhages. So that is the clue for it being a diffuse axonal injury. Now supposing, say if the patient had a cerebral laceration, then there is a lot of bleeding happening, and that would cause a midline shift. Here the question says there is no midline shift. All right. If it is an infarct, then you would not get multiple small hemorrhages. So these two options are ruled out. So how do you treat a diffuse axonal injury? Now the goal of treatment is you want to stabilize the patient, you prevent further brain damage, you manage secondary complication that may arise. That if there is if there is an increased intracranial pressure following a DI, you will want to, or if there are convulsions happening, you will want to control that. So you control secondary complications. You will obviously intubate, you will ventilate the patient. How do you manage the intracranial pressure? You elevate the head end of the bed. So these measures of intracranial pressure management they stand true for all conditions which cause raised intracranial pressure, not just for DAI. So what are those simple measures? You elevate the head end of the bed. You can give mannitol, hypertonic saline, diuretics, sedatives, analgesics, muscle relaxants. If this is not enough, you might have to place an external ventricular drain which is inserted into the lateral ventricle. So what drugs do you give? You will give antiepileptics. So the drug of choice is phenytoin. Then earlier they would advise the routine use of corticosteroids. However, routine use is not recommended anymore. You give it only when it is specifically indicated. So no routine corticosteroids. What kind of nutrition will you give? You will give an enteral nutrition. Enteral nutrition means now the patient obviously cannot eat, right? So you insert a Ryle's tube and you feed the patient via the Ryle's tube. You might also have to give prokinetics, for example, metoclopramide, or you might even have to give erythromycin. Moving on. Mandible is commonly fractured at what site? So what part of the mandible is commonly fractured? So let us look at this diagram of mandible. So the mandible is most commonly fractured at the condyle. See, this is 30%. So this part of the mandible is usually is the most commonly fractured part. So at the neck of the condyle, this is the most commonly injured part of a fractured part of a mandible. Now, supposing a patient comes to you with a mandibular fracture, what is your how do you treat? So now the goal of treatment is, so see, when you are chewing, your mandible approximates with your maxilla, right? But when there is a mandibular fracture, there is some amount of dislocation. So this occlusion might not happen. So instead of occluding like this, it might be something like this or something like this or maybe like this, depending on what the fracture is. So the goal in every mandibular fracture is to have proper dental occlusion. Fine. So restoration of dental occlusion, it forms the foundation for fracture management. You do this by two things. First, you will do an intermaxillary fixation. Second, you will do fracture exposure and plating. So what is this intermaxillary fixation? So in OT, when the patient is intubated, you will manipulate the mandible such that it occludes properly with the maxilla. Once it does that, then what you will do is you will place some wires and you will fix the maxilla with the mandible. That is called intermaxillary fixation. So that means the mandible has to be repaired in that position only. Once you do an internal intermaxillary fixation, you will then look at the fracture site, and then you might have to do an external plating to repair the mandibular fracture. But before you do the fracture exposure and plating, you will always do an intermaxillary fixation. That is because the goal of a mandibular fracture is always to restore dental occlusion. Okay, so moving ahead, let us move on to vascular surgery. That is, let us move on to arteries. So intermittent claudication at the level of hip indicates what? So intermittent claudication at the level of hip indicates, so basically wherever there is an arterial block, the part which is below it suffers, right? So supposing, say, if there is claudication at the hip, this means that the blood clot or the pathology, I should not say blood clot, I should use the word pathology. That means the pathology is proximal to it. So is popliteal artery proximal to the hip? No. So this is not the answer. Is bilateral iliac artery proximal to it? Yes. So bilateral iliac artery, it is in the abdomen, right? It is obviously proximal to the hip. So this is the answer. Same way, common femoral is distal to it, superficial femoral is distal to it. So the answer is a bilateral iliac artery occlusion. So now let us look at this intermittent claudication in some amount of detail. So what is this intermittent claudication? So it occurs as a result of anaerobic muscle metabolism. So when there is enough oxygen given to the, when the cells get enough oxygen, then metabolism happens by Krebs cycle, right? But when there is less oxygen, maybe because of atherosclerosis or for whatever reason, then the muscle have to switch over to anaerobic metabolism. That means from Krebs cycle, the cells are now in glycolysis mode. So when there is glycolysis mode, there is an increased amount of lactic acid which is accumulating. Along with lactic acid, you are also getting something called substance P. This substance P accumulates, and this substance P, it is responsible for the pain. So now, what is this? What is the description of this claudication? So it is described as a debilitating cramp-like pain. All right. So debilitating means the patient has to take rest, and it is a cramp-like pain. It is felt in the muscle that is brought on by walking. This means to get claudication, patient has to walk for some time. You might get rest pain, but that is in the later stages. When the patient has claudication, it is brought on by walking. Why? Why is it brought on by walking? Because only when the patient starts walking will the energy and oxygen be utilized, and it is only then will the patient have to shift from Krebs cycle mode to glycolysis mode. So it is brought on by walking. It is not present on taking the first step. So patients who have osteoarthritis, they have pain on taking the first step. Second, it is relieved by rest in both the standing as well as sitting positions, usually within 5 minutes. This is because when you rest, either you rest by standing or sitting, doesn't matter. But when you rest, the muscles can again switch back from glycolysis to Krebs cycle mode. So if it is relieved by rest in both the standing and sitting positions, usually within 5 minutes. This is unlike nerve compression from a disc prolapse or osteoarthritis of spine or spinal stenosis, which are relieved only when resting in the sitting position. So if there is a disc prolapse or if there is osteoarthritis of spine or spinal stenosis, that will get relieved only in the sitting position. It will not get relieved by standing. Whereas if you stand, the muscle stop working. Since you're not walking, the muscle can then switch from glycolysis to Krebs cycle. Okay. Now the distance that a patient is able to walk without stopping is called a claudication distance and varies only slightly from day to day. This means, so some days, maybe initially the patient can walk for 5 kilometers or 4 kilometers. The distance gradually decreases. So when does this distance decrease? It decreases by increasing the work demands and hence the oxygen requirements of the muscles affected. Suppose if you start walking uphill, or if you walk fast, or if you're carrying a weight while walking, fine. That means the claudication distance will decrease because then the muscles have to do more work. Or by general health conditions which reduce the oxygen delivery capacity of the arterial system. For example, the patient has anemia or any other cardiorespiratory disease. Muscle groups affected by claudication is one anatomical level below the level of arterial disease. And the most common site of claudication is in the posterior cuff. This is because the most commonly affected artery is the superficial femoral artery. So, most common artery affected in peripheral vascular disease is superficial femoral artery. Therefore, the most common site of claudication is in the posterior cuff. Now, supposing if there is aorto iliac disease, it will cause buttock claudication because just below the iliac artery, see, if there is occlusion in the iliac arteries, you will not get foot pain. You will get pain one anatomical level below it. So below the iliac artery, you have the buttocks, right? And the thighs. So if there is gluteal claudication, along with there being sexual impotency, then it is called Leriche syndrome. So this is also an important topic. Leriche syndrome, basically it means there is buttock claudication along with sexual impotence. Now let us look at the grading of classification. Grading of classification is called the Boyd's grading. Grade 1 means the patient complains of pain. So it is campy, like pain is there, but what happens is when the patient continues to walk, the pain subsides. This is because as the patient continues to walk, there is increased muscle, since the muscles are demanding blood and nutrients, so there is increased muscle blood flow, and the substance P and the lactic acid which is accumulating, it dissipates away. So because of that, the pain, if the patient continues to walk, the pain decreases. Grade 2 is the pain continues and the patient can still walk with some effort. All right, that means in grade 1 the pain disappears. Grade 2 there is still pain, but the patient is able to walk. In grade 3 the pain is such that the patient cannot walk. He is compelled to take rest. Grade 4 is rest pain, pain on rest. This means according to Boyd's grading, even rest pain is considered to be a part of intermittent claudication. So what are the sites of block? Aortoiliac disease, you will get buttock, thigh and calf claudication. Lehret syndrome. Lehret syndrome just has two components. One is buttock and one is impotence. Thigh claudication is not a part of Lehret syndrome. If it is in the common femoral, thigh and calf, superficial femoral, calf, popliteal artery, calf, crural artery, calf. If it is in the anterior tibial artery, posterior tibial artery, then it will be in the foot. Okay, which of the following is not a hard sign of arterial injury? So what do you mean by a hard sign and what do you mean by a soft sign? A hard sign of arterial injury, basically it means that the patient requires immediate operative intervention. All right, so a hard sign, it means it is a clear and definitive indication that an artery has been damaged and it requires immediate intervention. So you need to know what these hard signs are. So there are two signs. One is hard and one is soft. So in questions which involve two things, right, there is no point in remembering both. If you remember one, you automatically know the other. So you just know what are the hard signs, and whatever is the odd one out in the question, that becomes the answer. So which of the following is not a hard sign? So hard signs are as follows. One is there is distal circulatory deficits or ischemia. There is absent or diminished pulses. There is a bruit. There is an expanding or pulsatile hematoma. There is arterial bleeding. So please note that they have mentioned the term expanding or pulsatile hematoma. This means just the presence of the word hematoma is not enough. Only if the hematoma is expanding or if it is pulsatile, it is a hard sign. So coming back to this question, the options: expanding or pulsatile hematoma, arterial bleeding, bruit. These are all part of a hard sign. Shock is not a hard sign. Okay. Next, what is a Fogarty's catheter and where is it used? A Fogarty's catheter is used for removal of embolus from blood vessels. So let us look at a picture of a Fogarty's catheter. So this is your this is the common femoral artery. All right, this is the common femoral artery. So they make an opening in the artery. This opening is called an arteriotomy. Tomy means opening. So via that opening, they are introducing this catheter. You can see this catheter being introduced. You can see this dark portion over here, right? This is the clot. So what they're doing is they are going to introduce the catheter. The tip of the catheter will be going distal to this blood clot. So you can see a balloon over here. Once it goes distal to this clot, you then inflate the balloon and you pull it out. So the clot can then come out. So in this diagram, you can see this is a clot. So both these things are clot. This and this both are clots. So this is a Fogarty catheter. Now let us know some other catheters. So what is a Swan-Ganz catheter? So this is let us look at the description before. So a Swan-Ganz catheter is nothing but a pulmonary artery catheter. A pulmonary artery catheter is present on the right side, so it is also called a right heart catheter. All right. This too is balloon tipped, like a Fogarty catheter. This is also a balloon tipped catheter. It is inserted into a pulmonary artery in a procedure which is known as pulmonary artery catheterization or right heart catheterization. So why do you need to insert a catheter in the pulmonary artery? Because you need to measure a few things, such as you need to know the overall function of the heart. Okay, this is particularly necessary in patients who have complications, maybe because of heart failure or heart attack or arrhythmias or pulmonary embolism. You need to monitor how the heart is functioning. So these patients will require a Swan-Ganz catheter. So it is also a good measure. So along with measuring the heart, the function of the heart, it can also tell you what is the pressure in the blood vessels. So whether the amount of fluids that you're giving the patient is enough or not enough, right? So it is also a good measure for those who need intravenous fluid therapy, for instance, post-heart surgery shock and severe burns. So when you look at this Swan-Ganz catheter, it is a very complicated looking catheter. So you can see that there is a balloon tip over here, right? This is a balloon tip. This is the pulmonary artery port. That means this yellow line thing, that is the catheter, that is the port. Okay. So this is what is present inside. What is present outside? Outside is quite a few things. You have a pulmonary artery lumen. You also have a right atrium lumen, or one which is to measure the central venous pressure. Okay, these things are not required for your level actually. You just look at these things are not required. I mean, these two things, the thermistor and the VIP lumen, this is not required for your level. You just try to look at the image, and so that if this image comes in the question, they will not ask you the function of the ports. They will just ask, most likely they will give you an image of this and you have to identify. So how do you identify it? It is a complicated looking thing, first of all, and you see a lot of ports of entry, right? Okay. So next, coming to a Foley's catheter. So Foley's catheter, all of you would have seen this during your internship. And so few important things for a Foley's catheter. One is, so when you insert a Foley's catheter, you can see a bulb over here. You can see a bulb, you can see actually this part contains the bulb. So this has to get inflated, right? So how do you, what is the fluid of choice to inflate this bulb? You always have to use distilled water. If you've been using normal saline or something else during your internship, that is a wrong practice. You always have to use distilled water. So you see this Foley's catheter. There is one portal over here and there is one more over here. So it is via this that urine comes out, and this is used to inflate the bulb. So once you inflate the bulb, it gets occluded. I mean, it stays within the urinary bladder. It does not come out. Okay. So moving ahead. Now the bulb is always inflated with distilled water. Then the outer diameter. So when you measure, when you talk about the distance, the diameter of the Foley's catheter, it is always in French or FR. This French or FR, it talks about the outer diameter. All right. And 3 French is equal to 1 centimeter. So as the number increases, the diameter of the Foley's catheter will increase. So there are a few colors which you need to remember. So you have the mnemonic is GORY. So GORY, where green is 14, orange is 16, red is 18, yellow is 20 French. All right. Now, along with this Foley's catheter, you also have to know the IV cannula. So in an IV cannula, the diameter is measured in gauge. Okay, and this gauge, it refers to the internal diameter. All right, that is the orifice through which the fluid will be given. So this is with difference to French. French was outer diameter, gauge is internal diameter. Also, in gauge, as the number increases, the diameter decreases. So as the number increases, the diameter decreases. So there are a few gauges which you need to know, and the color coding of this. So there is a mnemonic which I was taught by my seniors. It is a slightly vulgar mnemonic, but it has served me well so far. It is O God, Y God. One moment. So So it is O God, Y God, pink bra, yellow panties. So you imagine a girl wearing a pink bra and a yellow panties, and you're thinking, why is she wearing mismatched clothes? So O stands for orange, G is gray, W is white, then this is green, then you have pink, you have blue, yellow, and purple. All right. Now you would have noticed that there are two G's over here. So how do you remember which is gray, which is green? So it is alphabetical order, Gray, Gren. Similarly, there are two P's. One is Pi, one is purple. It is again in alphabetical order. And this is, so once you write the colors, it is 14, 16, 17, 18, 20, 22, 24, 26. So this is the size of the IV cannula. Now, few more important points. Supposing if you're working in medicine wards, or if you're working in the case of an elective surgical patient, then in those patients you will be using a pink cannula. All right. Supposing you're working in casualty in the surgery department and the patient comes to you with shock, those patients you will be giving, you have to give a wider bore cannula, right? So if you get this option in the exam where all these colors are mentioned, gray, white, green, if you get all these colors, the answer should be whichever is the lowest number. So if the answer is, or if orange is also mentioned, it should be, or answer should be orange, then gray, then white, then green. If the question is which is the most commonly used cannula in shock, then your answer is green. So most commonly used is green. Pink is used in non-shock cases. So for example, supposing say if there is a patient who is being admitted for an elective hernia surgery, then you will use pink. Okay, then blue is for B for bacha, B for blue. So for children, you will be using a blue color cannula, blue and lower, not pink. So B is for bacha, B is for blue. Then few more important things. So till 26G I have mentioned the size 27G. This is called a 2He needle. And this is used for spinal anesthesia. Then supposing if you want to do an FNAC, for an FNAC you will usually use between 22 to 24 gauge. So you can use 22 or 24 or even 23 if it is available. Okay, so let us move on. So what is Buerger's disease? Buerger's disease affects all except. So Buerger's disease is also called peripheral vascular disease or thromboangiitis obliterans, right? So even though it is called peripheral vascular disease, it affects not just the arteries, it affects the arteries, veins and the nerves. So the answer is lymphatics. Now what is this TAO? TAO, it is characterized by three things. One is there is chronic occlusive disease of small and medium sized arteries of the limb. So it is not a large artery. So supposing say if there is an occlusion in the aorta, it is not TAO, it is not Buerger's disease, because it is chronic occlusive disease of small and medium sized arteries of the limb. Second, there is thrombophlebitis of superficial or deep veins. So veins are also present, and there is Raynaud's syndrome. So usually only one or two of the three manifestations are present. That means to call it a Buerger's disease, any one of these three should be present. It need not be that all three are present. Fine. Along with that, you might get involvement of the neighboring nerves. And the thrombophlebitis of the superficial veins, it might be migratory. Okay. So, etiology of TAO. So, etiology is cigarette smoking. This is present in young males. So, how young? So, the people who decide your question paper, they've decided that the magic number is 40 years. So, supposing if the question comes to you as to what is the a question comes to you, a patient who is 35 years old and the patient has symptoms of peripheral vascular disease, what is the cause? And your options are TAO and atherosclerosis. You will choose your answer to be TAO. Anything less than 40, the answer is TAO. Anything more than 40, the answer is atherosclerosis. So, Although TAO occurs almost exclusively in young males, you can also get it in females. Even though female might smoke, in spite of her smoking, she is still less prone to get TAO, but you can even get it in females. So what is the etiology of this peripheral arterial disease? So one, there is population aging, there is diabetes, hypertension, obesity, smoking. So what is the pathology? Inflammatory changes in the walls of the arteries and veins, which leads to thrombosis. Now let us look at something called an ankle brachial pressure index. Okay. So which of the following statements is not true? And let us discuss this only. It will be easier. So when ABPI, an ankle brachial pressure index, as the name suggests, you measure the systolic blood pressure in the ankle and you measure it in the brachia, that is in the arm, and you take a ratio. So it is a ratio of systolic pressure. So all these questions, like I told you in the trauma scores, it is always the systolic blood pressure which is important. At the ankle, ratio of ankle to in the ipsilateral arm. So highest pressure, for example, so what are the blood vessels in the ankle? You can have dorsalis pedis, posterior tibial, anterior tibial, or peroneal artery. I'm sorry, you use only dorsalis pedis, posterior tibial, or peroneal artery. Among these three, you take the highest pressure and you measure the, it is a ratio of this pressure to the highest brachial systolic pressure. Now I'm sorry, the normal value is 0.9 to 14. Okay. Supposing say it is less than 0.9, this means that the patient has claudication. If it is less than 0.4, that means the patient has a chronic limb threatening ischemia. So this means for claudication, it should be 0.4 to 0.9, 0.4 to 0.8. Right, that means it is claudication. If it is less than 0.4, it is chronic limb threatening ischemia. Supposing if it is more than 1.4, sorry, typing mistake, it is 1.4. If it is more than 1.4, it means there is calcification or medial sclerosis of the vessels. So usually you might, in an old age patient, you might get an ABPI of more than 1.4. That is because in old age there is calcification which is happening. So these values are merely a guide, and normal values may be present with intermittent claudication. That means this is just a guide. It is not used for diagnosing. It is just giving you a rough idea. So sometimes retesting after exercise to the onset of pain can be useful because that is more accurate. So a drop in the resting ankle brachial pressure index of more than 20% after exercise means that the patient has flow limiting arterial disease. These values are all very important values and you have to memorize this. So coming back to the question, ankle brachial index of less than 0.5 indicates critical limb ischemia. This is true. Ankle brachial index changes during exercise and rest. True. More than 1 is normal. True. 0.9 to 1.4 is normal. Smoking is more specific for peripheral vascular disease than coronary disease. This is wrong. So smoking, what they are trying to ask is smoking more linked to heart attacks or peripheral vascular disease? So the answer is heart. So smoking is more specific for the heart and less specific for the peripheral vascular disease. Now, what is the commonest cause of AV fistula? And AV fistula is nothing but an arteriovenous fistula, right? The commonest cause is a congenital fistula. But during your internship, you would have seen that it is in patients who are undergoing dialysis, for them, a fistula is created because it facilitates hemodialysis. So even though you might have seen more cases of iatrogenic fistula, that is surgical creation of fistula, the commonest cause is always a congenital cause. This is more common. It's just that you're not seeing it because you are more in touch, you are more in contact with patients who are undergoing hemodialysis. So communication between an artery and a vein may be either a congenital malformation or a result of trauma. So it might be created surgically for dialysis. So supposing if you make a connection between an artery and a vein, it will have a structure, that is an anatomical as well as a physiological effect, obviously, right? See, the veins are capacitance vessels. So there, the idea of vein is to to collect, to store blood. So that is why they are capacitance vessels, whereas an artery is subjected to the high pressure of a heart, right? So it has to sustain the high pressure at which the heart is pumping blood. That is why there is a difference in the structure of the artery and the vein. So structural effect of arterial blood flow on the veins is characteristic. They become dilated, tortuous and thick walled. That is, they become arterialized. So let me explain. Supposing, say, this is an artery, all right, and this is a vein. In between over here, you have all the capillaries, etc. So you have blood flowing in this direction, going via capillaries and returning to the heart via the veins. Now supposing if you were to create a connection over here, right, this means the blood is going to come from the artery and at a high pressure it is going to go into the veins. So now the veins are subjected to the high pressure of the heart. So the veins, they become arterialized. So what does arterialized means they become dilated, they become tortuous and they become thick walled. These changes are happening so that the vein can adapt to the high pressure of the blood flow. Now the physiological effect, if the fistula is large, is an increase in cardiac output that may lead to cardiac failure. So what happens is, once there is a fistula, there is blood flowing from the artery to the vein. So more blood is going to enter the heart via venous return. So the heart has to pump more vigorously for blood flow. So when the heart is pumping more vigorously, you will get cardiac failure. Fine. Now, supposing if there is a superficial fistula, you might get a pulsatile swelling. That means, supposing, say, there is a fistula created over here, right, either congenital or arterial, and there is a swelling over here. So when you palpate the swelling, you might get pulsation. So when you palpate, what else do you get? You might get a thrill on palpation. This is because the blood is flowing. There's a connection, right? So as the blood is coming from the artery to the veins, you will get a thrill. And if you auscultate, you will get a machinery murmur. Dilated veins may be seen, and pressure on the artery proximal to the fistula reduces the swelling. So obviously, right, common sense. So let us move back to this. See, whatever problem is happening over here, because of the fistula. So blood is flowing over here, right? If you were to place pressure over here, that is proximal to the fistula, then blood supply to the vein will obviously decrease. So whatever pulsatile swelling, machinery murmur, bruit, whatever you get, that will decrease when you place pulsation proximal to the fistula. Next, what are the investigations? You will have to do a duplex scan or an angiography. Treatment is usually complex. You do embolization. This means this is the artery, this is the vein, this is the fistula. You want to place your emboli over here. So if you place an emboli over here, then there is no blood flow happening from the artery to the vein. Supposing if this is not possible, then you might have to do an excision surgery. Okay. And can you do something called a ligation of feeding artery? So what they are trying to say is, supposing if you ligate this artery, okay, then theoretically it sounds attractive because then there is no blood flow happening. So ligation of the artery, it usually fails, and the problem with ligating is, once you ligate it, then you will not have the option of embolization. So the option, the first, if options are given in the exam, the first option that you should choose is embolization. Second is excision surgery. Okay, next, moving on to the topic of deep vein thrombosis. So deep vein thrombosis is seen in all except one. So prolonged embolization, yes, it is seen. Subungual melanoma, no. Pregnancy, it is seen. Major surgical operation is seen. Now, see, prolonged immobilization, pregnancy and major surgical operation are the same. Same in the sense that in all three, there is, see, when the woman is, say, 8 months or 9 months pregnant, she cannot move about as she was moving about earlier, right? So she is immobilized. Similarly, after doing a major surgical operation, the patient is immobilized. So this immobilization, it promotes deep vein thrombosis. So let us look at a few points about this. So first, let us look at virtuous triad. Virtuous triad means what? There are three components. So one is contact of blood with an abnormal surface. So for example, there is an endothelial damage due to trauma, or maybe there is atherosclerosis, or there is some damage to the wall of the vessel. So the blood, it has to flow in a smooth surface, right? So when it is flowing in a smooth surface, it does not clot. But if it has an abnormal surface, it predisposes to clotting. So imagine that there is a container and it contains a fluid. So the problem can either be in the fluid, the way the fluid is moving, or in the container. So if there is damage in the blood wall, that means it is damage in the container, right? Second thing is the abnormal flow. Example, stasis. So when blood stays, it clots. Blood should always keep flowing. If there's abnormal blood, for example, if the patient is predisposed to a coagulopathy, then that is thrombophilia. So there is problem in either the container, in the way the fluid is present in the container, and in the fluid itself, right? So what are the risk factors for venous thromboembolism? So patient factors, age. As the age increases, the risk for DVT and embolism increases. Obesity, varicose veins, immobility, pregnancy, puerperium, high dose estrogen therapy, previous DVT or pulmonary embolism, thrombophilia, all these are predisposing factors. So along with these patient factors, you also have surgical procedures. We will look at this thrombophilia later. So any prolonged surgery. So for example, if you're doing a surgery which itself lasts for 8 hours or 10 hours, if you're doing a major oncological surgery, you might have to give a prophylactic intra-op itself, not just post-op. So there's a trauma or surgery, especially of pelvis, hip and lower limb, because then the patient is immobilized. There is malignancy, especially pelvic and abdominal metastatic, because in these conditions, that is in a pelvic malignancy or in an abdominal mets, there is a diminished venous return. So that predisposes to thrombus. There is heart failure, recent MI, paralysis of lower limbs, infection, inflammatory bowel disease, nephrotic syndrome, polycythemia, paraproteinuria, PNH, or lupus anticoagulant, Behçet's disease, homocystinemia. So you have to memorize this table. So these conditions will cause, they predispose to DVT. This is an often asked question in exam. Please memorize this table. So earlier I had told you there was a question with thrombophilia. So what is this thrombophilia? What are the states which predispose to DVT? So like I had told you, there is problem in the container, in the fluid, and the way the fluid is flowing. So what are the problems in the fluid? So these are the abnormalities of thrombosis and fibrinolysis. So it can be congenital or it can be acquired. Congenitally, you have deficiency of antithrombin 3, protein C or protein S. If there is anti-phospholipid antibody or lupus anticoagulant, then factor 5 laden gene defect or activated protein C resistance, dysfibrinogenemias. And this anti-phospholipid antibody or lupus it can either be congenital or it can be acquired. So it is same in these two places. Okay, which of the following is the best way of preventing development of DVT in post-op period? Now in a post-op period, which is the best way? Early ambulation, no. If the patient has undergone a surgery, how can you ambulate the patient properly? Physiotherapy, see, you can ambulate a patient after surgery, but then it depends on the patient also. Whether some patients may be able to ambulate, some patients may not be able to ambulate. So it is obviously not the best method. Physiotherapy, for same reason, it is not the best method. So prophylactic heparin is the best method. Low dose aspirin, no. So see, low dose aspirin is going to prevent clot in the arteries, but DVT is venous thrombosis. For veins, the drug of choice is heparin. So prophylactic heparin is the drug of choice in the post-operative period. So modified Wells score is a score which is used as a guide to prevent DVT. So how do you prevent DVT? You have mechanical methods along with the pharmacological methods. Mechanical methods means you use graduated elastic compression stocking. This is nothing but it's like a crepe bandage, or you wear a stockings which is say up till the knee or above the knee, And why is it called graduated? Because when you wear these stockings or a crepe bandit, the pressure is highest at the ankle, and as it comes distally, the pressure decreases. So this is also for venous return, right? If the pressure is higher distally and lower proximally, it facilitates venous return. You can also use external pneumatic compression. So in the previous years, the examiners are fond of this question. They give you a photo and they ask you to identify. So this is that photo. So if you have a patient where something is covering her lower limbs, right? It might look like this, it might look like something else. But basically when the lower limb is covered, it is an external pneumatic compression device. Very fancy name, but a very simple name. External because you are wrapping something. Pneumatic because they can inflate this compression and it is a device. So what are the pharmacological methods? It is more effective than mechanical methods, obviously. So you're going to use low molecular weight heparin. Given subcutaneously, it is a once daily dose. There's a lower risk of bleeding complications. But the problem with low molecular weight heparin, even though LMWH is the drug of choice, you cannot give LMWH in patients who have renal impairment. So in patients who have renal impairment, you will give low dose unfractionated heparin. You give heparin only, but the type of heparin changes. So please remember, this is an important point. If the patient does not have renal impairment, you will give LMWH. If the patient has renal impairment, you will give low dose unfractionated heparin. Now, supposing whenever a patient has a thrombus in the deep vein, it predisposes the patient to get an embolus. So how do you treat the embolus? So most of them can be treated by anticoagulation and observation. So supposing if the patient has severe right heart strain, see, all blood will return from peripheries to the right heart. From the right heart, it goes via pulmonary artery to the lungs. From the lungs, it comes to the heart, and then it goes via aorta to the rest of the body, right? So most patients with pulmonary embolism, so pulmonary embolism means what? It means the clot has gone from the deep veins to the heart, right side of the heart, and from right heart via the pulmonary artery, it has gone into the lungs, right? So most of the patients of pulmonary embolus can be treated anticoagulation and observation. But supposing if the patient has right heart strain, so what do you mean by right heart strain? You can see it on echo. And if the patient has shortness of breath, then you might have to use thrombolysis, or you might have to use a radiologically guided catheter embolectomy. So what does this mean? Thrombolysis means maybe you insert a catheter into the clot and you try to dissolve the clot. You try to lyse the clot rather. Or you can do a catheter embolectomy, just like a Fogarty's catheter. Okay, so this is about prevention. How about looking at, now let us look at the treatment of DVT. So treatment of DVT is the same thing. One is rapid anticoagulation with parenteral drugs, that is low molecular weight heparin, which is given subcutaneously. Then you will maintain anticoagulation with oral drugs. So once the patient is discharged, you have to give oral drugs. So you might have to give fondaparin or Equinus. Then you will also give IVC filters. IVC filters, basically it means you're placing a filter in the inferior vena cava, and these filters will, so even if there is embolus of the clot in the deep vein, it gets lodged in the filter. It does not go into the heart. Or you might have to do an endovascular surgery. So let us look at this rapid anticoagulation. What I mentioned, you use treatment dose of subcutaneous low molecular weight heparin. Or for prophylaxis, the dose is a prophylactic dose. Here it is a treatment dose. It's a repeat point. Supposing say the patient has a sensitivity towards heparinoids, then you might have to give fondaparinux or bivalirudin. How do you maintain anticoagulation? So patient has to be given oral anticoagulation for 3 months or longer, depending on patient to patient. So you can use some new drugs. For example, you can use rivaroxaban or apixaban. This rivaroxaban and apixaban, these are factor 10A inhibitors. So how do you remember this? So please note that in both these drugs, XA, it is mentioned. So this is nothing but 10A factors. Then you can also have direct thrombin inhibitors. So dabigatran, it says in the name itself, TR thrombin antagonist. Thrombin antagonist is dabigatran. You can also use, see, earlier in the past, they were using warfarin, right? But they realized that these new drugs are as effective as warfarin. Then IVC filters and endovascular surgery can also be used. Aim of endovascular surgery is to restore patency, to reduce the risk of chronic post-thrombotic syndrome. What procedures can you use? You can either remove the thrombus, you can lyse the thrombus, you can also use a stenting. Next, which of the following is not a complication of varicose veins? So let us look at the complication of varicose veins. So you can get thrombophlebitis of the superficial veins. You can get pigmentation. So this is usually in the lower part of the leg because of venous stasis. There is alteration of blood of hemoglobin. So hemosiderin is formed, and hemosiderin causes pigmentation. You can get eczema or chronic dermatitis. You can get an ankle flare, a venous ulcer, hemorrhage, periostitis, calcification, equinus deformity of foot. These are all complications of varicose veins. Along with this, you can also get something called a champagne leg. Okay, I've mentioned it here. Lipodermatosclerosis and champagne bottle leg. Now, there are two things which I have to tell you along with this. One is, what is this equinus deformity? So when the patient has a long-standing varicose vein, the patient starts walking on the toes. So when the patient starts walking on the toes, it looks like the patient is walking like a horse. That is why it is called an equinus deformity. Also, when the patient starts walking on the toes, the Achilles tendon gets shortened because that is not being used, that atrophies. That gets used and that gets shortened due to disuse, and that will give rise to such a deformity. Second thing is, what is this lipodermatosclerosis? So as the name itself suggests, there is sclerosis. So there is skin thickening and there is fibrosis. Along with that, there is pigmentation. This is because of increased venous pressure during ambulation. So the problem with lipodermatosclerosis is the patient can then progress to a venous ulcer. That is quite common. And the constriction from lipodermatosclerosis causes an inverted champagne bottle appearance of the leg. That means, so the calf muscle will appear thicker and lower down it appears thinner. Okay, so coming back to the question, which is not a complication of varicose veins. So DVT is not a complication of varicose vein. All right, DVT actually, it predisposes the patient to varicose veins. It is not a complication. So if the patient has DVT, the patient can get varicose veins, right? Now, there is one more thing which you need to know. Whenever you are contemplating a varicose vein surgery, you always have to rule out DVT. This is because in a patient who has DVT, since the deep veins are occluded, all the venous return from the lower limb are happening via the superficial veins, right? So supposing if you do a Trendelenburg procedure and you do a stripping of the great saphenous vein, there is no pathway for the blood to go to the heart. So DVT is a contraindication for varicose vein surgery. Now, what are these venous leg ulcers? So venous leg ulcers, I think I have a diagram. Yes. So venous leg ulcer, as you can see over here, this is the medial malleolus. This is the medial, let me use a different color. Okay, this is the medial malleolus, right? So any ulcer which happens in the gaiter region, that is, it is happening in the middle aspect of the leg, it is more likely to be a venous ulcer. Second thing is, so what is this gaiters region? Gaiters is basically one of those stockings or shoes that people would wear when they would go for hunting, right, to protect their lower limbs. So gaiter region is anywhere from the toe, just beyond the toes to the knees. That is called the gaiter region. So a venous ulcer is typically present in the gaiter region. Second thing is, it has a sloping edge. So it is located circumferentially around the lower leg from mid calf to just below the medial lateral malleoli. This is the region where many of the cockpit perforators join the posterior tibial vein. So what are the perforators? So supposing, say, this is the thigh, this is the knee, this is the ankle. So you remember the mnemonic death by chocolate. So D, B, C. D or DOD perforators are above the knee, B or Boyd is below the knee, and C or Cocket is near the ankle. So there are two ways of removing, either CBD, common bile duct, or death by chocolate. Anyways, so a venous ulcer is usually located in the near the medial malleolus, right? But if a question comes, in which region is the venous ulcer more common, and there's an option given called Gator's region, the answer should be Gator's region. So ulcers usually develop in response to minor trauma. Many patients notice some itching before the ulcers develop. This is because of mast cell decannulation. Venous ulcers are sometimes accompanied by varicose veins, where it is called a varicose ulcer. So earlier it was thought that a varicose vein is responsible for a venous ulcer. So the earlier editions of books would say that below every venous ulcer is a varicose vein, but that is no longer true. The most commonly accepted theory for a venous ulcer is ambulatory venous hypertension. Ambulatory venous hypertension. Okay, so these are usually vertically oval. They have a sloping edge. Floor contains granulation tissue with slough. Then you will see surrounding hemosidrosis or pigmentation. So coming back to this image, see, you can see over here, there is pigmentation over here, right? So this is the normal color of the skin. This is pigmentation over here. This is the venous ulcer. So the more chronic ulcers develop lipodermatosclerosis with associated fibrosis of the subcutaneous tissue. Then the LDS, it manifests as thickening, pigmentation, inflammation, and induration of the calf skin. Pigmentation comes from hemosiderin and melanin. Okay, moving on. A patient presented with pulsating varicose veins of the lower limb. What is the most probable diagnosis? The moment you hear the term pulsating varicose vein, your answer becomes Klippel-Trenaunay syndrome. These two terms go hand in hand. Pulsating varicose vein is nothing but a Klippel-Trenaunay syndrome. So what is this Klippel-Trenaunay syndrome? It is a combined anomaly of a cutaneous nevus, persistent vestigial veins with varicose veins, and soft tissue and bone hypertrophy. It is a mesodermal abnormality. It is not familial. This is an MCQ point. It is not familial. So segments of the deep veins are hypoplastic or aplastic, and they may be associated obstruction of the lymphatics. Now there is also something called a Parkes-Weber syndrome. In Parkes-Weber syndrome, you will get multiple arteriovenous fistula. Because of the fistula, you're going to get high output cardiac failure. Okay. Now, what is the treatment of Klippel-Trenaunay syndrome? You treat them conservatively with compression hosiery. But supposing if you want to take care of the nevus, you might do laser ablation of the nevus, stapling of the bones to avoid limb length discrepancy, and occasional removal of, let me show you a photo. Yes, I have a photo. So you can see over here, both these patients have Klippel-Trenaunay syndrome. And in both these patients, you can see that this limb is longer. Similarly, this limb is longer, right? So if you do bone stapling, then that prevents further limb lengthening. And you can also see a capillary nevus. So where is this capillary nevus? Let us search for the capillary nevus. So you can see a nevus over here, and you can see a nevus over here. So some patients might benefit from laser ablation of the nevus, stapling of the bones to avoid limb length discrepancy. And supposing there is a large superficial varicose vein, then you might have to remove it. So in this second diagram that we saw, see, you can see the vein is dilated. So this patient will benefit if you do stripping of that vein. Okay. So moving on to lymphatics. So what is grade 1 lymphedema? So lymphedema is graded by something called the Brunner's grade. So clinical classification of lymphedema is by Brunner's grading. And there are 4 grades. One is subclinical or latent. Then you have grade 1, grade 2, and grade 3. A subclinical or a latent grade is where there is excess interstitial fluid and histological abnormalities in the lymphatics and lymph nodes, but there is no clinically apparent lymphedema. So as the name suggests, it is subclinical, right? So there is no clinically apparent lymphedema, but there is some problem in the lymphatics along with there being excess interstitial fluid. Grade 1 is where edema appears, but this edema of grade 1, it pits on pressure. That means when you do the pitting test, there is pitting edema, and if you ask the patient to rest, that is, the patient is lying down and you elevate the leg, or you elevate the leg end of the bed, this swelling disappears. So grade 2 is where the edema does not pit and does not significantly reduce upon elevation. Does not pit, does not significantly reduce upon elevation. And there is positive stemmer sign. So what do you mean by the stemmer sign? So in patients who have lymphedema, this is the toe and you pinch the skin of the toe. You're able to pinch the skin of the toe, right? But in stemmer sign, you're not able to pinch the skin. That is called a positive stemmer sign. Positive stemmer sign means it is grade 2 of Brana's grading. Grade 3 means along with the edema, there is skin changes. So in lymphedema, you always get skin changes. What are those skin changes? You might get weeping ulcers, you might get fibrosis, you might get papillae. So very easy to remember. Subclinical, where there is a problem in the histologically and there is excess fluid, but there is no edema which you can see. Grade 1, you can see the edema, but the edema, it is pitting type and it reduces on rest. Grade 2 is it is non-pitting edema and it does not significantly reduce upon elevation. Grade 3 is along with the edema, you will also get skin changes. So we'll take a technical break here, and after some time we will continue with GIT. After 5 weeks. So let us resume. Let us look at GIT. So we look at the question of liver first. Now a surgeon excises a portion of liver to the left of the attachment of the falciform ligament. So what segments has the surgeon resected? So this is a image of the liver that all of you would have seen from your first year. So basically you can see over here that you have something called the right lobe. You have something called the right lobe and something called the left lobe. And you can see something over here, which is basically the falciform ligament. So when you look at this gross appearance, you will feel that whatever is to the left of it is called the left lobe of the liver, and whatever is on the right is called the right lobe. But this was a very simple subdivision of the liver. So later they realized that the liver is more complicated, and then the liver is composed of 8 segments. So let us look at that anatomy in detail. Okay, so first of all, why is there a need to subdivide the liver into 8 segments? This is because each segment has its own portal pedicle. Each segment has its own portal pedicle. That means our own triad, which contains portal vein, the hepatic artery, and the bile duct. All right. So there are 8 segments. Each segment has its own portal pedicle or triad. This contains the portal vein, hepatic artery, and bile duct. Then there are 8 segments. These 8 segments are grouped into 4 sectors. All right. And each sector contains 2 segments, except for the medial sector of the left hemiliver, which contains only 1 segment. Then furthermore, sectors are separated by scissorae. So there are 8 segments, and each segment is supplied by its own portal pedicle. That is a portal triad. A triad consists of hepatic artery, portal vein, and the bile duct. All right. These 8 segments are grouped into 4 sectors. So 8 segments, 4 sectors, and each sector contains 2 segments, right? Except for one sector, which contains only 1 segment. Now, so wait a minute, 8 segments, 4 sectors. All right. And each sector is separated by scissorae. So supposing say you have 4 sectors, sector 1, 2, 3, 4. So you have 3 scissorae in between. So 8 segments, 4 sectors, and 3 scissorae. So you have to, these facts are you have to memorize. Now since there are 3 scissorae, that means there are 3 main hepatic veins. So you have the middle hepatic vein, left hepatic vein, and the right hepatic vein. All right, I'm showing this to you from your point of view. So you have the right hepatic vein, middle hepatic vein, and the left hepatic vein, and all these hepatic veins, they are present in the scissorium. So now these 4 sectors, then they are grouped into 2 hemilevers. So earlier there was this concept of right lobe and left lobe. However, that concept no longer holds good. So instead of calling it a right lobe or instead of calling it a left lobe, hepatic surgeons nowadays refer to it as a hemilever. So you have a right hemilever and left hemilever, and each hemilever contains 2 sectors, right? So basically there are 8 segments which are grouped into 4 sectors. Sectors are separated by scissorae. So there are 3 scissorae, and the sectors are separated into two hemilevers. So you have to remember these numbers. So first let us look at and let me show you this diagram actually. This will make more sense. So now this is a diagram which shows you 8 segments of the liver, right? So you notice over here that this is segment 1. This is present. It is present dorsally. So when you look at the human body, what is present at the back? This is your dorsal surface. This is the ventral surface. So segment 1 is present dorsally. So it is present posteriorly. On the left hand side, see, this is the left hand side. On the left hand side, you have segments. You have segments 2, segment 3, segment 4. Fine. On the right hand side, you have segments 5, 6, 7 and 8. On the right hand side, if you notice, it moves in a clockwise direction, 5, 6, 7 and 8. And in between these, you have your venous structures. So let me erase this sector ka thing. So here you have the middle hepatic vein. Here you have your right hepatic vein, and here you have your left hepatic vein. So these are present in the scissor, right? So whatever is to the right of the middle hepatic vein, this is the right hemiliver. This is the right hemiliver. This is the left hemiliver. So you will notice that the right hemiliver, it contains 4 segments, segments 5, 6, 7 and 8. The left hemiliver contains segments 2, 3 and 4. Segment 1 is unique. Segment 1 is, I'll discuss it later. But so right you have 5, 6, 7 and 8. Left you have 2, 3 and 4. Now among this 5, 6, 7 and 8, you will notice that segments 5 and 8, these are situated more medially or more anteriorly. And segments 6 and 7 are situated more posteriorly. So how do you remember whether which segments are forming the anterior sector or the posterior sector? So you remember the magic number 13. So 5 plus 8 will give you 13. 6 plus 7 will give you 13, right? So this is the way you remember it. So let us now go back. So the right hemiliver, it contains 4 segments. The 4 segments are 5, 6, 7 and 8. And these segments are grouped into 2 sectors. You have the anterior sector and you have the posterior sector. Anterior sector is segments 5 and 8, that is sum total of 13. Posterior sector is segments 6 and 7, sum total of 13, right? Now the anterior and posterior sectors are separated by the right scissora, which contains the right hepatic vein. So if you go back to this diagram, you can see that this is the anterior sector. You can see that this is the anterior sector and this is the, let me use a different color. This is the anterior sector. This is the posterior sector, right? Separating the anterior and the posterior sector, you can see a venous structure. This is your right hepatic vein. Okay. So the right hemiliver is supplied by the right hepatic artery, right branch of portal vein and biliary drainages via the right hepatic duct. Between the right and the left hemiliver is the main scissora. This main scissora contains the middle hepatic vein. So M for main and M for middle. No need for a mnemonic. So whatever is in the middle is the main. The main scissora is also known as the Cantley's line. You have to know this term. It is known as the Cantley's line. Cantley's line, it extends between the gallbladder fossa to the middle hepatic vein. Next, looking at the left hemiliver. So now let us look at the left hemiliver. So left hemiliver, it contains 3 sectors, 3 segments. Segments 2, segments 3 and segment 4, right? Now 2 and 3 are part of the lateral sector. 4 is the medial sector. So lateral sector, you have segments 3 and 4, and medial sector you have segment 2, right? The lateral and medial sectors are separated by the left scissora, which contains the left hepatic vein. So here you have one sector. This is the lateral sector and this is the medial sector. Why is this? See, 4 is closer to the middle line, so it is a medial sector. 2 and 3 are away from the middle line, so it is the lateral sector. So 2 and 3 are part of the lateral sector and this is part of the medial sector. These 2 sectors are separated by the left hepatic vein. So the lateral and medial sectors are separated by the left scissora, which contains the left hepatic vein, right? This left hemiliver, it is supplied by the left hepatic artery, the left branch of the portal vein, and the biliary drainages via the left hepatic duct. Next, so I have not, you will notice by now that I have not discussed segment 1 so far. Segment 1 is also known as the caudate lobe. So why is it called caudate lobe? So cauda means tail, right? So segment 1 is the most dorsal portion of the liver. So it is like the tail. It is the most posterior aspect. So it is called the caudate lobe. This is the dorsal portion of the liver, and it is unique because it receives its blood supply, hepatic artery, portal vein, and biliary, all the three things from both the right and the left. That is why it is unique, and it is called the caudate lobe. So coming back to the question. So if a surgeon excises a portion of the liver to the left of the falciform ligament, then that means it is a left hemiliver. Left hemiliver, you have segments 1, segments 2, segment 3, and segment 4. I'm sorry, segments 2, 3, and 4. 1 is dorsal. So that is where the answer is segments 2 to 4. So let us look at the nomenclature for hepatic resection. If you are going to remove segments 5 to 8, that means you are removing the right hemiliver. So that is called a right hepatic lobectomy. Right. Now, along with removing the right hemiliver, if you remove some part of the left hemiliver also, and so you will remove the part which is closest. What is closest to the right hemiliver is segment 4. If you see this diagram, see segment 4 is closest to the right hand side. If you include this, then it is called an extended right hepatic lobectomy, right? So segments 4 to 8 will be called an extended right hepatic lobectomy. Now supposing if you remove segments 2 to 4, if you remove segments 2, 3 and 4, then it is called a left hepatic lobectomy. Supposing if you remove segments just 2 and 3, you do not remove segment 4. Segment 4 you will remember is medial. You just remove 2 and 3, then it is called a left lateral segmentectomy. Now supposing along with the left hemiliver, you are going to remove part of the right liver which is closest to the left side. So if you see this diagram, 2, 3 and 4 is the left side. Right side, which is what is closest, is segment 8 and 5. So if you include this in the resection, then it is called an extended left hepatectomy, extended left lobectomy. So this diagram, it tells you basically the same thing. So in this A diagram, you are going to removing the right liver, right? Here you are removing right and segment 4. Here you are going to remove the left hemiliver completely. Here you are removing only the lateral portion, and this is an extended left. Okay, so moving ahead. What percentage of blood flow to the liver is supplied by the hepatic artery? Now, you would have read in your high school biology that the only vein in the body which supplies oxygenated blood is pulmonary vein, right? But there is one vein in the body which does not drain to the heart. So all veins drain to the heart, but there is one vein which does not drain to the heart. That is the portal vein. So the portal vein, it is taking all the blood supply from the entire GIT and it is draining that blood into the liver. So that is part of your first pass metabolism. So that if there is any toxins which are ingested in the blood, ingested in the food, that can be removed by the liver, right? So the portal vein is supplying the majority of the blood flow to the liver. Hepatic artery is supplying lesser. So portal vein is supplying approximately 80%. All right, and hepatic artery is supplying 20%. Now the arterial blood supply of the liver, it is variable in origin, fine. But in most individuals, it is derived from the celiac trunk. So there are three parts of embryological origins of the gut. It is foregut, midgut, and hindgut, right? Foregut is supplied by celiac trunk. What does the foregut consist of? Foregut, in the bowel aspect, it contains the esophagus, the stomach, and the first part, second part of duodenum up to the ligament of Treats, right? Now, along with this, the foregut also gives rise to the liver, the gallbladder, and the pancreas. So since the liver is a foregut structure, it is going to receive its blood supply from the celiac trunk. This celiac trunk, it usually divides into a left gastric artery, a common hepatic artery, and a splenic artery. after supplying the gastroduodenal artery, then the hepatic artery branches. Hepatic artery branches after giving rise to the gastroduodenal artery. So if an MCQ comes, which is the first branch of the hepatic artery, your answer is gastroduodenal artery. Once it gives that, then the hepatic artery branches. Sorry, the first branch of the celiac plexus, that is gastroduodenal artery. Then it is called the hepatic artery. Then that will branch to produce the right and the left hepatic arteries. Usually the right branch is larger. That is why which supplies the right lobe. Okay, moving ahead. All are true about pyogenic liver abscess except. So let us look at pyogenic liver abscess. The most common route of infection of the liver abscess is biliary. This is true. Most common is right lobe. This is also true. So why is the right lobe more preferentially affected? This is because of laminar flow. There is more blood flow happening to the right hand side. Klebsiella is the most common in gas from abscess. This is also true. Percutaneous drainage is least. This is false. Percutaneous drainage is in fact the treatment of choice for a pyogenic liver abscess. Now let us look at this pyogenic liver abscess. Now the incidence of causative organism, it varies and it reflects the changes in etiology according to geographical distribution. So all bacteria, parasites, viruses, fungi, all of them can cause liver abscesses. I'm sorry, not viruses. Bacteria, parasites and fungi can cause liver abscesses, but bacterial infection is the most common. Now, even though bacterial infection is, most of the liver infections are polymicrobial. So what are those organisms which will cause liver abscess? It is a combination of Escherichia coli, Klebsiella, Streptococcus miliary, right? Among these three, the most common is Escherichia coli. In the developing world, in India, Escherichia coli is the most common. In the West, Klebsiella is more common. Okay, so if you get a question in the exam, what is the most common cause of liver abscess? Your answer will be E. coli. Okay. Now, what is the most common source of this liver abscess? So, liver is going to receive blood source from via the portal vein from the GIT. All right, and it is also receiving biliary from the bile. So biliary tract pathology is the most common source. So how do you say it is biliary tract? It is because, see, you have the common bile duct and the main pancreatic duct, which form the ampulla of Vater, and then they open in the second part of the duodenum, right? So there might be ascending infection. So once there is bacteria over there, it can ascend via the bile and it can cause a liver abscess. So biliary tract pathology is the most common source. Second is portal spread. So biliary tract is first. Second is portal spread. This portal spread from the GIT. So what are the causes of infections in GIT? Most commonly, you will think of acute appendicitis and diverticulitis. So you can also have unusual etiologies. For example, there might be contiguous spread from subphrenic or intra-abdominal collections. There might be bacteremia secondary to trauma or infectious cysts, and there might be necrotic tumors following chemotherapy. Okay, now the treatment of choice for a pyogenic C. There is a basic dictum in surgery that wherever there is pus, you need to drain the pus. You need to remove the pus, because unless you remove the pus, it does not heal. So earlier, when there was no interventional radiology, back then the treatment of choice for pyogenic liver abscess was you do a laparotomy, drain the abscess. But since it is obviously a morbid procedure, and since we are living in an era of minimally invasive procedures, so for a pyogenic liver abscess, your idea is to remove the pus in the least invasive way. And the best way of doing that is you use the help of radiologists. So there is a branch of radiology called interventional radiology. So they can either do it CT guided or ultrasound guided. So once it is localized on the screen as to this part of the liver is affected, you then place a drain over there. So that is called percutaneous drainage, and this is the method of the treatment of choice for treating a pyogenic liver abscess. Now, what is more commonly asked in exams is usually you'll get a question, you have to differentiate between a pyogenic and a amoebic liver abscess. So what are the differences? So firstly, a pyogenic liver abscess is seen in elderly. It is in more than 50 years. Amoebic liver abscess, on the other hand, is seen in a younger age group. It is 20 to 40 years. Now, what is the reason behind this? How do you know the logic of this rather than memorizing it? So amoebic liver abscess is caused by an amoeba, entamoeba histolytica, that is usually present in countries like our country, which are referred to as third world countries, right? So when a foreigner or somebody is visiting this, supposing if he's visiting a third world country, who's more likely to visit a third world country? It is obviously young people who are traveling, right? So you can use that as a clue to remember amoebic liver abscess is more common in younger people than pyogenic liver abscess. Secondly, amoebic liver abscess is more common in males than females. So the male to female ratio is 10:1. Now a pyogenic abscess also is more common in males, but if you notice, the ratio is just 1.5:1. Next, amoebic abscess is usually solitary. It has a higher chance of being solitary than a pyogenic liver abscess. So for people who understand a bit of Hindi, so A is for akela. So amoebic abscess is usually solitary. It is not always. In medicine, there are always guidelines. It is not a norm. There are very few norms. So usually it is solitary. It is 80%. Pyogenic abscess on the other hand is solitary is 50%. Now this is the same in both. That is, the location is right liver in both. Amoebic liver abscess, there is a history of travel in an endemic area. That is not so in pyogenic abscess. This is why in pyogenic abscess the cause varies. So even though it is polymicrobial, in the developing world the answer is E. coli, and in the Western world the answer is Klebsiella. Suppose you get a question where they've not mentioned whether it is the developing world or a developed world, then which one do you choose? Your answer will still be E. coli, because E. coli is I mean, people in the third world are more prone to getting infections than in the developed world. So your answer should be E. coli. Then for pyogenic liver abscess, as for all infections, diabetes is more common. Diabetes is less common with amoebic abscess. Then alcohol use is common to both. Alcohol use is common to both. Jaundice and elevated bilirubin, these two basically mean the same thing, and this is more common with pyogenic abscess. This is because the pyogenic abscess is more prone to compress the biliary duct tubes or the biliary ducts, and it can cause jaundice. And elevated alkaline phosphatase, on the other hand, is common. It is seen in both. Now, positive blood culture. Now, for pyogenic liver abscess, you will get a positive blood culture. For amoebic abscess, you will not get a positive blood culture. If there is amoebic serology, you will get it in amoebic abscess. Obviously, you will not get it in a pyogenic abscess. So moving on, so let us go back to the question. All are true about pyogenic liver abscess except. So Klebsiella is most common in gas-forming abscess. This is one more point. If there is a abscess where there is gas present along with pus, then the answer for that, the cause for that abscess would be Klebsiella. I think while mentioning this, by mistake I told you that, no, I told the correct thing only. E. coli is more common, Klebsiella is second most common. Yes. Okay. During surgical exploration for hydrated cyst of the liver, any of the following agents can be used as colicidal agent except. Now, the most important danger, or the very common danger of a hydrated cyst, is that if the hydrated cyst ruptures and if those contents enter into the peritoneal cavity, it can cause anaphylaxis. I don't know if some of you watched, there is a show called House MD, which was very popular when I was doing my MBBS. So in that there's one episode where this guy, he comes and he asks House to treat him, but he's being refused by all other doctors because they feel that he's lying, he does not have any problem. So House also thinks he's pretending. So what House does is he uses his stick to hit House limbs. So he's carrying a walking stick, and he with very minimal force he hits that patient on the right upper quadrant. So immediately following that, the patient collapses. So now House is wondering, I have not used this much trauma. How can this minimal trauma cause this patient to collapse and go into anaphylactic shock? So later it is revealed that that patient had multiple hydrated cysts. So when he was hit with the walking stick, the cyst ruptured, the contents entered into the peritoneal cavity and caused the patient to have anaphylaxis. So What I'm trying to say is, in hydrated cyst, you have to take all possible precautions, all possible measures to ensure that the contents do not enter into the peritoneal cavity. So while you are treating the hydrated cyst, you want to first kill those scoliosis, the organism which is going to cause the hydrated cyst. So a question which is most commonly asked is, what are the substances which are used as scolicidal agents? So the options are, the substances usually are hypertonic saline, absolute alcohol, povidone iodine, or 5%, 0.5% cetrimide with 0.5%, 0.05% chlorhexidine. So cetrimide and chlorhexidine are used in combination as a scolicidal agent. The others are used individually. So if you look back at this question, hypertonic sodium chloride is used, formalin is not used. That is the answer. Okay, let us look at the treatment of hydrated cyst in slight more detail. Now, supposing that the cyst is asymptomatic and the cyst is inactive, then you leave it alone and you monitor the size of the cyst via USG. So if the cyst is increasing in size, then you will think of doing an intervention. Otherwise, leave the cyst alone. Now, supposing the cyst is active, then you have to first treat it with a full course of medical therapy. You usually will give albendazole. You can also use praziquantel. And then when the cyst becomes inactive, only then will you operate. Because then, see, the thing is, when you are operating on that patient, and there is obviously going to be some risk of spillage, right, during the surgery. So you will obviously use a technical skill to minimize spillage. Second, you do not want that thing to be active. So for an active cyst, you first treat by a full course of albendazole. You can also use praziquantel, and then you operate. So when you want to operate, what are the options which are available? So there is first something called PAIR. So what is this PAIR? PAIR stands for puncture, aspiration, injection, reaspiration. So first you puncture the cyst, you aspirate the contents, then you inject something, you inject the scolicidal agent, then you reaspirate. You continue to do this. Fine. So I've already discussed the agents which are going to be injected. So now, before PAIR is done, it must be ensured that the hydrated cyst does not communicate with the biliary tree. This is obvious because you are going to be injecting something into the cyst. Supposing if it were to communicate with the biliary tree, then that is going to cause systemic issues, right? So what systemic issue can it cause? It can cause sclerosing cholangitis because it is a foreign substance. Once it enters the biliary cavity, it will cause irritation of the biliary epithelium. It can cause sclerosing cholangitis. Now this PAIR, it can either be done by open surgery or it can be done by laparoscopically. Now when I was preparing for NEET-PG, I used to make a very common mistake. I used to think the P in PAIR stands for percutaneous aspiration. No, it is puncture and aspiration. You are never going to do this hydrated surgery percutaneous. Percutaneous is done only for pyogenic liver abscess. Alright, so the P in PAIR stands for puncture. It does not stand for percutaneous. So please do not get confused like I used to get confused. So you will do this PAIR either open surgery or laparoscopically. Now what else can you do? You can also do something called pericystectomy with omentoplasty. This means you do a dissection around the cyst, you remove the cyst, and so there's a gap in the liver. You plug that gap using omentum. Supposing if it is supposing if you're not able to do pericystectomy, you're not able to do PAIR, you can also do a hepatic segmentectomy. That is, you remove that part of the liver which contains the hydrated cyst. So this hepatic segmentectomy, it is preferred if this lesion is present in a peripheral part of the liver. All right. One more option of treatment you have where you do laparoscopic marsupialization. That is, you de-roof the cyst and you marsupialize the cyst. So when you de-roof the cyst, you have to take very good care that you are going to remove the endocyst. You have to remove the endocyst along with the daughter cysts, right? You have to be very, very careful about this. So another commonly asked question is, what are the characteristics of pulmonary hydratosis? So there are a lot of flowers and moons and stars which are mentioned. So let us look at this question. So the characteristic signs of pulmonary hydratosis are meniscus sign, double arc sign, moon sign, water lily sign, and crescent sign. So very irritating question. I always get annoyed by this question, but there's an easy way of remembering it. See, this is what a meniscus looks like. This is what a double arc looks like. This is what a moon looks like. And this is what a crescent looks like. So basically, these were jobless doctors in the past who wanted to make your life miserable. And they decided by ensuring that you get confused in this question in NEET. But we are smarter than them. Don't get confused. So when you hear these names, whatever you think of this shape, whatever looks in this shape, that is seen in pulmonary hydatidosis. Also, you will see something called water lily sign. Water lily sign is always seen in pulmonary hydatidosis. The thing is, you always get confused in the exam with one more term, which is called drooping lily sign. So do not get confused. Drooping lily sign is seen in neuroblastomas and duplication of ureter, whereas water lily sign is seen in pulmonary hydatidosis. I know it is very annoying, but it is these annoying questions which can cost you the seat of your choice. So don't make this mistake. So let us look at this question again. So water lily sign is seen in pulmonary, that is true. Rising sun sign, I did not mention it over here. But the thing is, when you see something like this, it can either be a meniscus, or it can be a double arc, or it can be the rising sun. So supposing, say, you were to look at a meniscus. Earlier when I drew it, I drew the meniscus ulta. I drew it like this because a meniscus can be either this or this. Now a normal individual, when he sees this shape, he can just tell it is inverted U shape, or it can tell it is meniscus. But some doctors, they want their names to be published in papers. Those are the doctors who make your life miserable. So when he sees this, he is not happy with just calling it a meniscus sign. He thinks that it looks like the rising sun, right? He thinks this looks like the rising sun. So rising sun is also seen in pulmonary hydatidosis. Fine. All are true about liver hemangioma except. Now, liver hemangioma, it is the most common benign tumor of the liver, right? The most common benign lesion of the liver is a simple hepatic cyst, but the most common benign tumor is liver hemangioma. So let us look at it in some detail. So hemangioma is the most common benign tumor of the liver. It consists of an abnormal plexus of vessels. The enlargement is by ectasia rather than by neoplasia. It is usually solitary. It is less than 5 centimeters in diameter. If it is more than 5 centimeters in diameter, then it is called a giant hemangioma. This is the same as fibroadenoma of a breast, the size. Less than 5 centimeters is called hemangioma or a fibroadenoma. More than 5 will be called a giant fibroadenoma or a giant hemangioma. Hemangioma occurs with equal incidence in both right and left hemilivers. It loves the right and the left equally. So when you do a histopathology, what do you see? You will see endothelium lined, blood-filled spaces which are separated by thin fibrous septum. What are the clinical features? They are usually asymptomatic and found incidentally on imaging studies. This is why it is the most common benign tumor. Supposing if it were to cause symptoms, supposing if it were not to be found incidentally, it would not be the most common benign tumor. So, supposing if it is large and it is compressing the surrounding structures, then it can cause vague upper abdominal symptoms. Okay, and many times the symptom is thought to be because of a liver hemangioma, but it can be because of something else. Now, supposing, say, if there is rapid expansion of the hemangioma or if there is acute thrombosis, then that can also cause symptoms. Spontaneous rupture of a hemangioma is very, very, very rare. So, if a question comes to you that there is a hemoperitoneum with an underlying liver lesion, your answer will not be hemangioma. Your answer will be the other options which are present. So, spontaneous rupture is very rare, important point in hemangioma. And there is also something called Kasabach-Merritt syndrome. So what is this Kasabach-Merritt syndrome? This Kasabach-Merritt syndrome, it is associated with giant hemangiomas, so more than 5 centimeters. And since it is a big hemangioma, you get something called a consumptive coagulopathy. So since it is giant, imagine that all the coagulation factors are being eaten up by that giant. So it is a consumptive coagulopathy, and there is thrombocytopenia. Okay, so how do you investigate this hemangioma? USG is diagnostic. So usually what happens is, when you want to choose an investigation, the closer that your target organ is to the skin, to the probe, that usually is the investigation of choice. So for example, for liver and gallbladder, it is if you place a probe, the liver and gallbladder are very close to the probe, right? So then that would be the investigation of choice, that is USG. Supposing, say, if you want to investigate the pancreas. Now pancreas is a retroperitoneal organ, and you have the stomach, you have the duodenum anterior to it. You also have the transverse colon which is anterior to it. So to view it properly, you can't place a probe because the organs are going to come in between. So for those, so that is for pancreas, you will want to use a CT scan. So pancreas, adrenal glands, kidney, and these are all retroperitoneal. So you will want to use a CT scan. So USG is diagnostic. Along with USG, you can also use CT scan if there is a diagnostic dilemma, or if you want to make money via CT scan. CT scan, you will obviously make more money, right, than a USG. USG scan is cheaper. Anyways, jokes apart, CT scan is seen, you will use delayed contrast enhancement. This will show the characteristic appearance of slow contrast enhancement owing to small vessel uptake. So when you give the contrast, the hemangioma takes up the contrast very slowly. So, and since it is taking it up slowly, the screen lights up very slowly. You can also use an MRI where you will have to use an isotope labeled RBC scan. I mean, you can use an MRI, you can also use an isotope. These are two different things. You can also use an isotope labeled RBC scan. That is an accurate test, but it is rarely necessary, and it is not easily available either. Now, you should never do a biopsy of a hemangioma for obvious common sense reasons, because it is going to bleed, right? Okay. Now, how do you treat hemangioma? So now diagnosis is usually incidental, therefore it requires no treatment. So what are the indications of surgical resection? If the patient is symptomatic, if there is some diagnostic uncertainty, then you will want to do an intervention. So if you do an intervention, what do you do? So the preferred approach is enucleation with arterial inflow control. So if you enucleate it and if you control the inflow, that is enough. So what is meant by this enucleation? Supposing, say, if you're eating a fruit, right, and the shell of the fruit is there with you, and you're going to peel the inside and you're going to eat it. So the shell remains, but whatever inside is removed. That is called enucleation. Like, for example, if you're eating an ice cream from a cup, so you're going to remove all the ice cream and the cup remains. That is called enucleation. So if you do enucleation with arterial inflow control, that is usually enough. Anatomic resection may be necessary, but it is only in some cases. So let us go back to the question. So all are true about liver hemangioma except CHF is very common. This is false. CHF will be common only in giant hemangiomas where there is Kasabach-Merritt syndrome. And a giant hemangioma, see, liver hemangioma is the most common benign tumor. So obviously it is being detected incidentally. They are not causing symptoms. That is why, supposing, say, if it were to cause CHF and hemangioma is the most common benign tumor, you will have so many patients coming to hospital with congestive heart failure. So the others are all true. You can also get spontaneous regression sometimes. So moving ahead, which of the following most significantly increases the risk of hepatocellular carcinoma? So hepatitis B virus most significantly increases the risk of HCC. So let us look at the etiology of HCC. So there is the difference in etiology of HCC. It reflects the geographical variation. So for example, chronic hepatitis B, hepatitis B is more common in underdeveloped and third world countries, right? That is why there is a difference in etiology. So chronic hepatitis B, how do we know that it causes HCC? And few important points about it. One is HPV infection, it usually precedes the development of HCC. Not all cases, obviously, because not all patients who have HCC are going to have hepatitis B. But in where there is an association, it usually precedes the development of hepatocellular carcinoma. Also, if you study these patients over time, you can easily see the sequence. You will first get HPV infection, then you get cirrhosis, then you get HCC. Lastly, and most importantly, wherever there is an hepatitis B vaccination program, it will reduce the incidence in high-risk areas. Next, hepatitis C virus, it increases the risk of HCC. So along with HBV, even HCV increases the risk of HCC, but hepatitis C does it by promoting end-stage liver disease. The other etiologies are alpha toxin contamination of rice. So alpha toxin contamination of rice in some parts of the world is responsible. And then lifetime alcohol exposure remains an intractable risk factor. So people who drink a lot, since they're more prone to getting hepatic cirrhosis, it can cause, and cirrhosis can convert into carcinoma. Then obesity and diabetes. Let us know a few more important points about hepatocellular. Let us look at the treatment. So, how do you treat a hepatocellular carcinoma? So, for any tumor, obviously, if you can do a surgical treatment, that is good. So, you can do either a resection or you can do an orthotopic liver transplantation. So, now why is just removing the tumor not enough? Now, the liver is an essential organ, right? Without a liver, a patient can survive only for 48 hours, for 24 to 48 hours. And usually what happens is, supposing say only a part of the liver has carcinoma, right? The rest of the liver does not have the tumor. Now, the problem is in hepatocellular carcinoma, usually the carcinoma is seen in a diseased organ because there is a sequence from cirrhosis to carcinoma, right? So you are not only going to treat the carcinoma, you also have to treat the underlying condition. And that is why once you resect the tumor, there may not be enough liver left behind which can carry the functional liver. So you might have to do a orthotopic liver transplantation along with that. Okay, then there are some other methods of treatment. One is ablation. So in ablation, what they do is you try to destroy the tumor. This can be done either via injecting alcohol, acetic acid, or you can use thermal ablation. Thermal ablation, you will be using, you can either use heat or you can use cold. That is why it is called thermal ablation. You are using temperature to destroy the tumor. So you can use cryotherapy. In cryotherapy, you are going to use very low temperatures. You can also use radio frequency waves or microwaves. Then transarterial. So the logic, what they say is, if you embolize the tumor, that can be enough. So you can either do an embolization or a chemoembolization, where there are certain substances such as glass beads or plastic beads which are used as emboli. Then there is radiotherapy. Radiotherapy, you are going to use combination transarterial and ablation. You will be using external beam radiation. This external beam radiation, it can be used, it is obviously being used from the outside of the body, but it is a combination of transarterial as well as ablation. Then systemic. So you have those different drugs: chemotherapy, hormonal therapy, and immunotherapy. Now, there is one type of liver carcinoma which is separate from the other types. So that is called the fibrolamellar hepatocellular carcinoma. So when you're preparing for NEET-PG, you will notice that mostly there are some questions where you have to know the differences between two things. You tend to get confused in those differences. Like, for example, in an earlier question, I had discussed the difference between pyogenic liver abscess and an amoebic liver abscess. Similarly, there is a high chance of you getting confused between standard HCC and fibrolamellar HCC. So let us look at the differences. HCC is more common in males. So the ratio is 2:1:8:1. But a fibrolamellar carcinoma, it is more common in females compared to an HCC, but the overall incidence is equal. So F is for female. So the ratio is 1:1. HCC is going to appear in older people. This is going to appear in younger people. HCC is invasive. F is well circumscribed. So HCC is resectable only in few cases, resectable in more number of cases. Then a history of cirrhosis, the tumor marker alpha fetoprotein being positive, and the patient also being hepatitis B positive. These are all common in standard HCC and not in fibrolamellar carcinoma. So let us look at this question again. So all of the following are true about fibrolamellar carcinoma. More common in females, true. Better prognosis, yes. Why does it have better prognosis? Because of the fact that it is well circumscribed, right? AFP levels are always more than 1000 picograms per ml. This is false. AFP is associated with standard HCC and not with fibrolamellar HCC. Now, we know that this is the answer, but there is another way. Supposing, say, and it occurs in younger individuals. Fine, this is also true. Now, supposing you had no idea about this question, about the options, right? And you still wanted to take a guess in the exam. How do you guess? So, wherever the term always is mentioned in the options, always, this is a thumb rule. This means it is usually true, but there are certain exceptions. Always is always incorrect. So wherever the term always is given, that is the answer. If you want to take a guess, you take that guess. 90% of times you will be right. Sometimes you will be wrong. Supposing, so always is always incorrect and never is never correct. So supposing you get a question where the term never is given, that is never the answer. Fine. So moving ahead. So what is this Fitz-Hugh-Curtis syndrome? So perihepatic fibrosis occurring in Fitz-Hugh-Curtis syndrome. So in Fitz-Hugh-Curtis syndrome, you are going to get perihepatic fibrosis. Now, what is this perihepatic fibrosis due to? So it is usually due to pelvic inflammatory disease. So Fitz-Hugh-Curtis syndrome is a condition characterized by inflammation of the liver capsule and the surrounding tissue. Because of this, there are adhesions being formed. So it is caused by pelvic inflammatory disease, which is often triggered by sexually transmitted infections such as chlamydia and gonorrhea. So the route of spread is the bacteria travel from the vagina or the cervix, they travel upward via the uterus, fallopian tubes, the peritoneum. Once it enters the peritoneum, it can reach the liver capsule, and once it reaches the liver capsule, it can cause inflammation and scarring. So this upward spread of bacteria causes Fitz-Hugh-Curtis syndrome. And this is the image of Fitz-Hugh-Curtis syndrome. So you can see this is the liver, all right, and this is the parietis. So this can be the rib cage. The liver is covered by the rib cage, right? So you can see the liver. This is the anterior wall. This is the rib cage, and you can see these flimsy adhesions. You can see these plastic-like things, right? This plastic-like thing. This is the perihepatic adhesion. This is called Fitz-Hugh-Curtis syndrome. Okay. In patients with cirrhosis of the liver, the site of obstruction in the portal system is in what? So basically, this is another way of asking which is the most common cause of cirrhosis of the liver. So the most common cause of cirrhosis of the liver is sinusitis. So let us look at the causes of cirrhosis. Now, cirrhosis is the most common cause of portal hypertension, right? Among the cirrhosis, so the most common causes of portal hypertension, liver cirrhosis, and let us look at the cause of cirrhosis. Now, cirrhosis can be pre-sinusoidal, it can be sinusoidal, or it can be post-sinusoidal. So pre-sinusoidal means it is pre-hepatic, sinusoidal means it is intrahepatic, and post-sinusoidal means it is post-hepatic. So pre-sinusoidal or pre-hepatic, that means it is before the liver, right? The causes of this are, you have portal vein thrombosis, splenic vein thrombosis, myelofibrosis, arterioportal shunt, tropical splenomegaly. These are all extrahepatic. These are occurring before the sinusoids. This is before the hepatic end, but it is outside the liver. Now it can still be pre-sinusoidal, but it can be intrahepatic. Those are schistosomiasis, congenital hepatic fibrosis and portal infiltration, sarcoidosis, drugs and toxins, and veno-occlusive disease. Now, sinusoidal or intrahepatic, this is the most common cause, and this is cirrhosis. The other causes are post-hepatic. So you have Budd-Chiari syndrome. What is Budd-Chiari syndrome? It is thrombosis of the hepatic veins. They can be veno-occlusive disease. They can also be congestive cardiac failure. So what is common among all these post-sinusoidal causes is there is some problem in the occlusion of the vein. So supposing if there is a thrombosis of the hepatic vein, it is called Budd-Chiari syndrome. Supposing the vein is being occluded due to any other cause, it is called veno-occlusive disease. And if there is congestive cardiac failure, that means there is decreased venous return, right? If there is decreased venous return, there is pooling of blood in the inferior vena cava and the hepatic veins, and then that is going to cause thrombosis due to stasis. So that is congestive cardiac failure. So in the exam, if you're given a question and you have to identify whether it is pre-sinusoidal, sinusoidal or post-sinusoidal, it is very easy to remember. No need to remember this pre-sinusoidal part. You just remember what are the post-sinusoidal things, and that way you can get the answer. Okay, moving ahead. In a patient with compensated liver cirrhosis presented with history of variceal bleed, what is the treatment of choice in this patient? Now, first of all, what do you mean by compensated? So, every organ, whether it is the liver or the kidney or the heart or the pancreas, they have a functional reserve. That means it is the organ, or even the brain for that matter, the organ is not functioning to its full capacity. We are never using the full capacity of our brain, but still we are functioning so well. So this is a mechanism given by nature where even though the organ gets diseased, the organ is still functioning. So there is a disease in the organ is still functioning. That means that disease is being compensated for. But there occurs a time where the disease is advanced to such an extent that the organ can no longer compensate for that. That is called decompensated. So in this patient, there is compensated liver cirrhosis who presents with a history of variceal bleed. So how do you treat this patient? Now, the treatment of choice of portal hypertension is always a minimally invasive measure, and that is endoscopy. So you use endoscopy, and you use endoscopy sclerotherapy to be more specific. Actually, band ligation is preferred. Supposing in the exam there is a question which says band, supposing if you have 5 options over here, and the 5th option is band ligation, this would be your answer. So band ligation is preferred to sclerotherapy. So let us look at the treatment of portal hypertension, that is the treatment of upper GI bleed. So the treatment of upper GI bleed, the treatment of portal hypertension, it revolves around the treatment of bleeding from these varices. So why is it important? Because upper GI bleed is responsible for 1/3 deaths in all patients with cirrhosis. Of these patients who are dying because of cirrhosis, upper GI bleed, 50% is due to uncontrolled bleeding. And the risk for death is related to the underlying hepatic functional reserve. That is, since the liver is diseased, how much of the liver is remaining which is actually functioning properly. So what are the measures? The general measures, and you will do general measures. You have to maintain airway, give IV access, give fluids matching, cross-matching, blood transfusion. You correct coagulopathy. Then there is something called pharmacotherapy. Pharmacotherapy, you will be using certain drugs. So these drugs are terlipressin and vasopressin. These should be initiated at the onset of variceal bleeding. You can also use propranolol. Then you'll use endoscopy. When you use endoscopy, endoscopic intervention, it is the mainstay of treatment for control of acute variceal bleeding. Options are, you'll be using band ligation and sclerotherapy. Band ligation is more preferred than sclerotherapy. So what do you do in band ligation? In band ligation, basically wherever you see the varices, you sort of plug the varices, and at the base you put a rubber band. That is called band ligation. Now, sclerotherapy is where you see the varices, you inject something into the varix so that does not bleed. Next, you can also use something called a balloon tamponade. So when a patient is coming to you in casualty, and before you have to, so you cannot do an endoscopy, right? You are dependent on the medical gastro guy or somebody who knows an endoscopy. So what do you do till then? So you can do something called a balloon tamponade. So what is a balloon tamponade? You can use 2 balloons. You can use a few types of tubes, two which are most commonly used as Sengstick and Blakemore tube and a Minnesota tube. So this is like a Riles tube. So supposing say this is the esophagus, this is the stomach. You insert the tube. This tube has various balloons, right? Now the varices are usually present in the lower end of the esophagus or upper GI. Usually in the lower end, maximum in the lower end of the esophagus, then the upper stomach. So once you insert the tube, there are 2, you have to put it in place. See, supposing if you want to do first aid and there is bleeding, say from the scalp, that is a MCQ which has been asked, how do you control bleeding from the scalp? You put direct pressure. Even in OT, when you are assisting, whenever there is some bleeding happening, they first will put pressure. So even if there's bleeding from your, say, your hand, anywhere in the body, you put pressure. So that same funda is being used in balloon tamponade. You insert the balloon and you insert the tube like a Riles tube, and you inflate the balloon. So there is one balloon in the stomach which is inflated, another in the esophagus. So when you inflate this balloon, this is going to cause pressure on the varices that will prevent bleeding. So this is used as a bridge to definitive treatment. You cannot use this tubes indefinitely, because if you put pressure on that, it can cause necrosis. So there can be esophageal pressure necrosis. So it is a bridge therapy. Next, there is something called a TIPS, or a transjugular intrahepatic portosystemic shunt. So what you do in this is, so in portal hypertension, as the name suggests, the pressure in the portal system is high, right? This is the liver. Now imagine that this is a portal. Let me use a different color. Imagine that this is a portal structure, which is the portal hypertension. This is a portal vein. This is a branch of the portal vein, and this is the normal systemic vein, right? So what your idea is you want to decrease the pressure in the portal vein, because there is portal hypertension. You want to decrease the pressure. So you will be using TIPS. TIPS is transjugular. Transjugular means you get access via the external jugular vein. You insert via the internal jugular vein, you enter into the right heart and you go further. You're going to access the liver. Once you access the liver, your catheter is going to come out of the hepatic vein and enter into the it is going to come out of the systemic circulation and enter into the portal circulation. So it is a transjugular intrahepatic. It is called intrahepatic because it is happening in the liver. Transjugular intrahepatic portosystemic stent. So what you do is you create a channel, a pathway between the portal and the systemic circulation, and you place a stent over there, which acts as a shunt. So what happens is, because there is a stent over there, this portal, the excess blood, the excess tension in the portal vein will come down, because now there is some amount of blood which is going to flow from the portal vein into the systemic circulation, right? So once the blood goes over there, the pressure in the portal vein decreases, therefore the bleeding will decrease. So this is called a transjugular intrahepatic portosystemic stent. Now then you can also use surgical shunts. Surgical shunts are rarely performed because they have high morbidity and mortality. Indications of surgical shunt are if there is failure of medical management, for example in patients with non-cirrhotic patients who have extrahepatic portal vein occlusion. Now, there are two kinds of shunt. There are three types of shunt. You can either have a selective shunt, non-selective shunt, or a partial shunt. We always want to use a partial shunt or a selective shunt, because see, supposing if you're going to bypass the liver, if you're going to create a shunt, that means all the metabolites of digestion are going to bypass the liver and enter into the systemic circulation. Now the liver is there for a reason. The liver is there to detoxify the blood, right? So if all these substances are not going to be bypassed in the liver, that is, if they're not going to undergo first pass metabolism in the liver, they are going to enter into the systemic circulation. Once they enter into the systemic circulation, they can enter the brain. It can cause encephalopathy in the brain. We do not want that happening. So there are three types of shunts: selective, non-selective, and partial. Our goal is always to use selective or a partial shunt, because that will have a lesser chance of encephalopathy than a non-selective shunt. Then the best treatment is liver transplantation, because in liver transplantation you are treating the portal hypertension as well as you're going to treat the underlying liver disease, right? So because the patient has got cirrhosis. So supposing if you do a liver transplantation, you are not only removing the liver, you're not only treating the portal hypertension, you're also curing the underlying disease. Now supposing, say, if a patient comes to you with recurrent or refractory variceal bleeding, in such patients you can do something called a Sugiura procedure. In a Sugiura procedure, you're going to do two things. One is you will do a splenectomy. Second is you will do esophagogastric devascularization. no need to go into details of this procedure, just memorize it. It is splenectomy plus esophagogastric devascularization. Okay, so we'll take a technical break here, and after the break, we shall resume. 1 minute. So welcome back to the session post lunch. Moving on. So the next question, the sentinel node of gallbladder is called what? The gallbladder lymph node is known as the lymph node of Lund. So let us look at some of the other named lymph nodes. The Rota's nodes refers to the interpectoral nodes. This is seen in CA breast. The Rouviers nodes refers to the retropharyngeal nodes, which is seen in CA nasopharynx. Delphian nodes is also known as the precricoid, pretracheal, prelaryngeal nodes. Irish nodes are seen in the left axilla. This is seen in the CA stomach. Sister Mary Joseph nodules or nodes are periumbilical metastatic cutaneous nodules. This is usually seen in CA stomach. It can also be seen in CA gallbladder or any other intra-abdominal malignancy. Virchow nodes are left supraclavicular nodes. Virchow nodes, if present, it usually indicates that that malignancy is inoperable. Cloquet nodes are the femoral canal nodes. Lymph nodes of Lund is cystic lymph node. Krauss lymph nodes are the jugular fossa lymph nodes. And Cabana nodes are the nodes seen in CA penis. Cabana nodes are nothing but inguinal lymph nodes, which is enlarged in CA penis. So moving on, what is the best investigative modality for gallbladder? Now, as I was telling in one of the previous sessions, for any organ which is close to the surface, that means if you can place a probe close to the organ of interest, then in that organ the ultrasound becomes the best investigative modality or the investigative modality of choice. In fact, you try to understand this in a way such that, so for example, sometimes if you want to look at periesophageal lymph nodes, or if you want to look at structures just posterior to the esophagus or the stomach, if you want to look at the lymphatic spread specifically, or if you want to know the thickness of the tumor involving the esophagus or the stomach, you can also use endoscopic ultrasound. So basically what I'm going to tell you is that see, you have to memorize what investigation is used where, but try and understand the concept behind it. So wherever you can place a probe near the lesion, in those patients, the ultrasound is the best investigative modality. So for example, now in the liver and gallbladder, it is close to the surface of the anterior-abdominal wall. So USG is used. Now supposing if there is a pathology in any of the retroperitoneal organs, then you have to use CT scan. Now when is MRI used? MRI is used whenever you need soft tissue detail. So for example, if you want to look at lesions of the brain, or if you want to look at the pelvis, where there are too many structures and you want to know the relationship of the tumor to the surrounding structures. So for soft tissue detail, MRI is the best investigative modality. Okay, so transabdominal ultrasound is the initial imaging modality of choice because it is accurate, readily available, it is inexpensive, it is quick to perform. Now the problem of USG is it is operator dependent and therefore it might be compromised by excessive body fat or intraluminal bowel gas. Now the size, so what information do you get in an when you do a USG of the gallbladder? So you can get to know the size of the gallbladder, whether it is distended or not distended. You can know the presence of stones or polyps, that also can be determined. It can also give you information about the thickness of the gallbladder wall and whether there is any collection of fluid around the gallbladder. For example, if there is acute calculus cholecystitis, it is diagnosed radiologically. It has a very high sensitivity and what is present. So thickening of the gallbladder wall, that is more than 3 mm. Presence of pericholecystic fluid, yes. Direct tenderness when the probe is pushed against the gallbladder. This is known as ultrasonographic Murphy's sign. So Murphy's sign can be seen in two scenarios. One is ultrasonographically when the radiologist puts the probe against the gallbladder in a case of acute calculus cholecystitis. Second is whenever you are palpating the abdomen and at the peak of inspiration, when you put pressure over the gallbladder area, the patient, there's a catch in the patient's breath. That is also Murphy's sign. So along with that, it will also give you information about the presence of inflammation around the gallbladder, the size of the CBD, and occasionally the presence of stones within the extrahepatic biliary tree can be determined. So now supposing, say, if the stones are present in the distal part of the CBD, it can easily be, not easily, depending on the radiologist skill, but you can still tell it with fair amount of certainty using a USG. Now, in a patient with obstructive jaundice, USG can identify intra and extrahepatic biliary dilatation. So, it is a very useful information. The level of the obstruction can also be told, and the cause of the obstruction, whether it is because of a stone or because of common hepatic duct or CBD lesions within the wall of the CBD, which are suggestive of cholangiocarcinoma. Now, usually whenever there is a stone in the gallbladder or the common bile duct, usually more so in the gallbladder, you will get a sign known as wall acoustic shadow. Wall acoustic shadow. This is usually seen in gallbladder stones. Okay. Now, let us look at some of the other imaging modalities of gallbladder. So, when you use MRCP. Now, MRCP, which stands for magnetic resonance cholangiopancreatography, this is a non-invasive modality and it provides excellent images of the gallbladder and the biliary system. And along with this, it also gives you information on the pancreas. So, if you want to delineate the structures in detail, that is the biliary apparatus or the gallbladder or the pancreas and its ducts, the best non-invasive modality would be a MRCP. Now, earlier they were doing something called ERCP, which is endoscopic retrograde cholangiopancreatography. The problem with ERCP is it is an invasive test. That is, you have to push an endoscope via the oral cavity. The endoscope has to go down. So, it is slightly technically demanding and it is invasive. The advantage with MRCP is it is a non-invasive procedure. Now, what is the disadvantage? Obviously, since an endoscopy, it is an invasive procedure, so you are able to take biopsy. You can also do minor therapeutic interventions. For example, there is a stone in the CBD. You can remove the stone via ERCP. You can also place a stent in the CBD, which will ensure the patency of the CBD. These things cannot be done via an MRCP. But MRCP is usually preferred over ERCP whenever you are contemplating a diagnostic modality. Okay, so moving on, this is an important table from Bailey and Love. You need to know this box properly, so I'll just explain it to you. So if you take a plain X-ray of the abdomen, what information can you get? You will get to know calcification if there is a stone or whether there is air within the biliary system. For example, if there is a gallstone ileus, in gallstone ileus, there is basically there is a communication between the gallbladder and the intestine, the second part of duodenum. So that causes air to go into the biliary system. So that is called Wriggler's triad. It is called Wriggler's triad. So air in the biliary system is part of Wriggler's triad. That can be seen on plain X-rays. USG already discussed, MRCP already discussed. CT scan will give you information about the anatomy, the liver, the biliary and the pancreatic cancer, right? It will tell you the information of that with the nearby structures. Now, radioisotope scanning or HIDA scan will give you information about the function of the biliary apparatus. So this is usually the investigation of choice in acute acalculous cholecystitis. So what happens in HIDA scan is I'm sorry. So in HIDA scan, what happens is there is a dye which is given intravenously in the elbow. Now this dye will then travel to the liver. It is excreted via the biliary apparatus. So how does the bile enter the gallbladder? Once the bile is excreted into the common hepatic duct, there is backflow, retrograde flow into the gallbladder. So similarly with HIDA scan, the dye, it enters the common hepatic duct from the via the biliary apparatus. So let me just make this slightly clear. This is the right and left hepatic duct. This is the common hepatic duct. You have the cystic duct, and this is the main pancreatic duct. This is the cystic duct. Here you have the gallbladder. So what happens is the HIDA, the dye, it enters this CHD via the hepatic ducts. That is the right and left hepatic duct. It comes over here and then it tries to go back into the gallbladder. So normally the HIDA will enter the gallbladder via the cystic duct. But in acute acalculous cholecystitis, what happens is this opening is blocked. so the dye does not go. So if there is non-visualization of gallbladder in HIRA scan, that means the patient has acute acalculous cholecystitis. So ERCP we've already discussed. ERCP will tell you information of the anatomy, stones and biliary strictures with or without cholangioscopy. Then there is something called PTC, or percutaneous transhepatic cholangiography. In PTC, what happens is this gives you information on the anatomy and biliary strictures. So what happens in PTC, I will just explain this to you. So now imagine this is the liver. So it is percutaneous transhepatic cholangiography. So access is gained into the biliary system via the skin. So that is why it is percutaneous. It is transhepatic. So you go across the liver. You supposing there is a biliary ductule over here. All right. This is a schematic diagram. It is not a literal diagram. So once you gain access into this biliary ductule, that is where you inject a dye. You inject a dye over here, and then you take an image. So then this dye, it will enter all the other biliary ductules. It can also come out via the common hepatic duct, and you'll get a good picture. This is called percutaneous transhepatic cholangiography. Endoscopic ultrasound, I've already told you. You can get to know about anatomy as well as stones. If there are stones in the main pancreatic duct of the pancreas, you can get to know from endoscopic ultrasound. Also stones in the CVD, that will also be easily seen via an endoscopic ultrasound. Okay. Next question. 80% of the gallstones contain what? That is to say, what is the most common content in gallstones? So, the most common content of gallstones is cholesterol. So, let us look at the types of gallstones. Now, in USA or Europe, 80% of the stones in the gallbladder are cholesterol or mixed stones, right? In parts of Asia, 80% of the stones are pigment stones. So this is the difference between the West and developing countries. In India, in Asia, the most common stones are pigment stones. But in the West, the most common stones are cholesterol or mixed stones. Now, even if it is a pigment stone, the stone does contain some amount of cholesterol. So overall, if the question is asked, what is the most common content of a gallstone? Your answer should be cholesterol. Now let us look at the types of gallstones. So gallstones are divided into three types. First, you have cholesterol stones. These stones consist almost entirely of cholesterol. These are often solitary. Because it is solitary, it is also called cholesterol solitaire. Next, you have something called mixed stones. In mixed stones, cholesterol is the major component. Other components are calcium salts, bile acids, bile pigments, and phospholipids. Mixed stones are usually multiple. So cholesterol is usually alone, that is why it is called cholesterol solitaire. But mixed stones, usually they are multiple. They are often faceted. Faceted means when you, supposing if you see the introp image, it has very neat, very good looking sides. It's like you play dice when you're playing Ludo. It has that kind of an appearance, or a diamond. It has that kind of a beautiful appearance. Now let us look at pigment stones. Pigment stones, they can be of two types. They can either be black stones or they can be brown stones. So even though it is a pigment stone, it still contains less than 30% of cholesterol. Now patients with cirrhosis have a higher incidence of pigment stones. So if a question is asked in the exam, which of the following is a cause of pigment stones, and one of the options is cirrhosis, that is your answer. So like I told you, there are two types of, before that, you need to remember one more important point. In gallbladder stones, 80% are radiolucent. In kidney stones, 80% are radio-opaque. So basically, whenever for a stone to become radio-opaque, the stone needs to contain calcium. Now, since in gallbladder stones, the most common content is cholesterol, that is why 80% are radiolucent. Whereas in kidney stones, the most common content is calcium. That is why these stones are radio-opaque. So let us look at the types of stones, types of pigment stones. So there are two types. One is a black stone and one is a brown stone. Now black stone, they contain insoluble bilirubin pigment polymer plus calcium phosphate. plus calcium bicarbonate and cholesterol. They are usually associated with hemolysis. They are usually associated with hemolysis. So, for example, any patient who has a hemolytic anemia, for example, if the patient has hereditary spherocytosis or sickle cell anemia, then these patients are prone to getting black stones. They're prone to getting pigment stones, and those pigments are of the black type. Now, brown stones, they consist of calcium bilirubinate, calcium palmitate, calcium stearate plus cholesterol. Right. So, I'm sorry. So they contain calcium bilirubinate, palmitate, stearate or cholesterol. Brown stones are more commonly present in the bile ducts. So that is, it is present in the common hepatic duct and common bile duct. So this is related to bile stasis and infection. Now there is a rule in the human body, wherever there is stasis, something hard forms. Supposing there is stasis of blood in the veins or in the, so that is called virtuous striate, and a clot forms, a thrombus forms. If there is stasis in the urinary tract, a renal stone forms. If there is stasis in the biliary system, then gallstone forms. So wherever there is bile stasis and infection, the stone is being formed. That stone is more commonly of the brown stone type. Fine. Now these stones are associated with the presence of foreign bodies within the bile ducts. So what can these foreign bodies be? They can be stents, that is your ERCP stent. The stent which is placed during an ERCP in the common bile duct, it is called an Amsterdam stent. Okay, there can also be parasites within the common bile duct. So these parasites usually are Clonorchis sinensis and Ascaris lubricoides, that is the roundworm. Okay, so let us know the factors which are associated with gallstone formation. So what are the factors which are associated with gallstone formation? So there are 4 factors. One is impaired gallbladder function. Basically, if there is stasis, then there is gallstone formation. So if the gallbladder is not able to empty properly, not able to function properly, then there is stone formation. So impaired gallbladder function, it can be in the form of emptying, it can be in the form of absorption or excretion. So basically all these will promote stasis of bile in the gallbladder, which can then cause stones. Next is the presence of supersaturated bile. So this is more commonly seen in age, sex, genetics, obesity, diet. This is why earlier, in the earlier books, there used to be a mnemonic that gallstones are seen in fat, fertile, 40, female. So if the female, in female patients, especially who are fat, who are fertile, that is in the reproductive age group, and they are 40 years of age, that is 40 plus, they would be more prone to getting gallstones. Next, you have cholesterol nucleating factors. Now, see, cholesterol is not soluble in bile, right? Cholesterol is not soluble in water. I'm sorry. Cholesterol is not soluble in water. So what keeps the cholesterol in the bile soluble? That is the presence of bilirubin. So there has to be an appropriate ratio of cholesterol and bilirubin, which will ensure that the cholesterol remains soluble. Right. Now, supposing if there are some cholesterol nucleating factors, that is, or rather there is, it is not enough for the cholesterol to be soluble, then that will precipitate stone formation. So, for example, if there is mucus or glycoprotein or infection. Okay, what is the 4th factor? This was number 3, this was 4. So, absorption or enterohepatic circulation of bile acids. If this is disturbed, that also promotes gallstone formations. For example, the use of deoxycholates, bowel transit time, fecal enteric flora, ileal resection, cholestyramine. So these are also associated with gallstone formation. Fine. Now, what is the commonest site of obstruction in gallstone ileus? So let us look at the topic of gallstone ileus. Now, gallstone ileus means that there is some connection between the gallbladder and the duodenum, via which the stone enters from the gallbladder into the duodenum, and then that stone is passing in the duodenum, it enters the jejunum, it enters the ileum, and it gets stuck somewhere. So the question is, what is the most common site of obstruction where the stone can get stuck? So the answer to that is distal ileum, because the distal ileum is the narrowest part of the ileum. So gallstone ileus, it is a rare complication of cholelithiasis as a result of impaction of one or more gallstones within the gastrointestinal tract. Then an episode of acute cholecystitis leads to erosion of inflamed tissues, resulting in a cholecystointestinal fistula. Basically, there is a lot of inflammation over there because of acute cholecystitis. After inflammation, some scarring can happen, some fibrosis can happen, and during inflammation, the tissues are fragile, friable. So it is during that stage that there might be a fistula which is forming between the gallbladder and the duodenum. So a majority of the small gallstones, they pass through the intestines spontaneously, right? But gallstones which are of size 2 to 5 centimeters, they get impacted, usually in the terminal ileum or at the ileocecal valve, because of the narrow lumen, and also the peristalsis is less active in the terminal ileum. There are two reasons why gallstone gets stuck in the gallstone in the terminal ileum. Next, supposing, say, if a stone gets impacted in the ileum, there is an obstruction that might lead to necrosis and perforation of the ileum, which is then followed by peritonitis, right? Now, there are also some other stones where there are also some other sites where the stone can get stuck. So some, never say never in medicine. So sometimes there can also be a fistula between the gallbladder and the stomach. Sometimes the stone can get stuck even in the duodenum. If the stone gets stuck in the duodenum, it is called Bouveret's syndrome. It is called Bouveret's syndrome. So let's look at the investigations. So X-ray abdomen is useful in gallstone ileus because an X-ray abdomen will give you all the features of intestinal obstruction. Next, you will see pneumobilia or contrast material which is present in the biliary tree. Fine. And thirdly, you will see an ectopic calcified gallstone. This means that a gallstone which should have been present in the gallbladder, you are seeing that stone in the distal ileum. Right. Now, obviously that is an ectopic site because that is not the normal site of gallstones. Now, when these three are present together, then it is called Regulus triad. It's a fairly simple triad. One is you will see signs of intestinal obstruction. Second is you will see pneumobilia or contrast material in the biliary tree. That means normally there is no air in the biliary tree, right? But when there is a fistula, stone can enter from gallbladder into the ileum, and air in the ileum or any contrast, if a contrast study is being done, that can also go via the tract into the biliary apparatus. So that is called, these three are together called Regulus triad. Now, there is one more sign called tumbling sign. Tumbling, basically it means something which is falling, right? So whenever there is a change in the position of a gallstone on serial film, supposing you take a film and it is present, say 10 centimeters proximal to ileocecal valve, the next one it is present 8 centimeters proximal. So that change in position of the gallstone is called tumbling sign. Now a CT abdomen is superior to plain X-rays and ultrasound. A CT abdomen, it shows an abnormal gallbladder with air and air fluid level or fluid accumulation with an irregular wall. Again, all the signs of a communication. Now, how do you treat such patients? So first, like all obstruction patients, you have to first manage the obstruction itself. So you have to first resuscitate the patient. Once you resuscitate the patient, then you have to operate. How do you operate, or rather what do you do? So you do a laparotomy, you palpate in the ileocecal valve because that is the most common site, and you make an opening in the bowel over there. When you make an opening in the bowel wall, you can extract the stone. So opening and making an opening in the bowel wall and extracting the stone, that procedure is called enterolithotomy. This is the most common surgical procedure which is performed. Now, so you have done an enterolithotomy. So the second question that arises is, should you resect the fistula between the gallbladder and the intestine, or should you leave it alone? Right. So now the thing is, if a patient is in obstruction, so again you correlate this with damage control surgery. If the patient is in obstruction, that means the patient's physiological reserves have been exhausted. The patient needs resuscitation first, and only then should you do a definitive reconstructive procedure, right? So if the patient is unstable, because usually if the patient has had an obstruction, and usually the patient will be in middle ages or elderly, so the patient's physiological reserves are exhausted. So you cannot spend more time doing the OT where you resect the fistula. So what you can do is, if the patient is stable, then you resect the fistula. Otherwise, you leave it and do it in the next sitting. Fine. Which of the following is not an indication for cholecystectomy? So again, a very important topic. What are the indications of cholecystectomy? Now, supposing, say, if a patient has, if there's a 20-year-old female who does not have any problems, she has no health problems. Now she undergoes a USG, and the USG, it says that she has stones in the gallbladder. So then obviously she'll come and ask you, doctor, do I get operated? So now, will you or will you not operate on that patient? So it is an incidental finding because she has not come with complaints of gallstones, but still she's getting gallstone. But still the scan shows a gallstone. So it is an incidental finding. So there are a few indications where you will do it. Let us look at those indications. So asymptomatic gallstones do not need intervention. Fine. But prophylactic cholecystectomy may be performed for asymptomatic cholelithiasis in the following situations. One is large gallstones. So the definition of large here is more than 3 centimeters. In the earlier editions of BD Lab, it was mentioned 2.5 centimeters. They have, however, changed it. So if it is more than 3 centimeters, it is said that these stones have a risk of malignancy, CA gallbladder. So to obviate the risk of CA gallbladder, you will do a cholecystectomy. Next, if there is choledocholithiasis. Choledocholithiasis means what? So let us draw a diagram again. This is the right hepatic duct, left hepatic duct, common hepatic duct, which is joined by the cystic duct to give rise to the common bile duct. And here you have the cystic duct. This common bile duct, communicates with the main pancreatic duct to form the ampulla of Vater. Fine. Now, if there is choledocholithiasis, that means if there are stones present within the common bile duct, then you have to do a cholecystectomy. The reason is that supposing if the stone gets impacted over here, if the stone is lesser than the diameter of the cavity, then that is fine. It will pass into the bowel. But if the stone gets impacted, it will cause, so supposing let us say the stone has got impacted over here. Fine. Then there will be stasis of bile over here, so there will be jaundice. Then the patient will have, there is no flow, no downward flow, so the patient will have jaundice. Then the patient can also have cholangitis. Patient can also have Charcot's triad, Reynolds pentad, which is seen in cholangitis, right? So to prevent those complications, it is better to operate if the patient is stone in the common bile duct. Also, supposing say the patient has a stone which is stuck in the ampulla of Vater, then there is stasis in the main pancreatic duct, right? If there is stasis in the main pancreatic duct, it can also lead to pancreatic ductal stones. It can also lead to pancreatitis. So whenever there is a stone in the CVD, you have to operate. So any chronic hemolytic conditions, for example, sickle cell disease, hereditary. Now these patients are more prone to getting pigment stones. Which pigment stones? Black pigment stones. Black pigment stone is with hemolytic anemia, hemolytic conditions. Brown is seen with obstruction, for example, CBD or a stent or parasites. So if there's a patient who's come to with sickle cell disease, you can tell the patient that, look, in future you might have a risk of a pigment stone. So let us do a prophylactic cholecystectomy. Next, if there are gallbladder polyps and the polyp is more than 1 centimeter in diameter, again it is considered that a polyp which is more than 1 centimeter in diameter, there is a risk of malignancy. Next, suspicion or risk of malignancy. For example, if the patient has an anomalous pancreatic ductal drainage. If there is a porcelain gallbladder means there is a calcification in the wall of the gallbladder. Next, some ethnic groups or subjects who live in areas with a high prevalence of gallbladder cancer and are associated with gallstones. So, for example, it is said that in North India, especially in the Gangetic belt, so in West Bengal, in Bihar, in Jharkhand, there is a higher chance of getting gallstones, and there is a higher chance of these gallstones turning into malignancy. So in these areas, if a patient comes to gallstones, it is acceptable to do a prophylactic cholecystectomy even if the patient is asymptomatic. Next is transplant patients, that is during transplantation. So when you're doing a transplant surgery, you can do a cholecystectomy, because then a second surgery will be difficult, right? Because the patient is on immunosuppressants. Now, bariatric surgery. Now, for patients with who are undergoing bariatric surgery, the thing is, then they're supposing they're undergoing Roux-en-Y surgery or some other surgeries, then the anatomy of that area gets distorted, right? We change the, if you're doing a Roux-en-Y surgery, or if you're doing a duodenal switch or a biliopancreatic diversion, the anatomy of that area is changed. So when the anatomy of the area gets changed, there is no scope for an endoscopic intervention in future, and the patient might have an emergency. So it is, you can do a prophylactic cholecystectomy in bariatric surgery. Now, for a patient with symptomatic gallstones, if a patient comes with a symptomatic gallstone and tells, I have gallstones, and the patient has symptoms, you have to do cholecystectomy, unless the patient has any contraindications which prevents the patient from undergoing a surgery. Okay. Which of the following does not form the boundary of Callot's triangle? Now, Callot's triangle is a very important triangle, especially as far as lap cholecystectomy is concerned. So let us look at the diagram. So when you're doing lap cholecystectomy, you have to delineate the Callot's triangle properly. So the what are the borders of Callot's triangle? Medially, that is on this side, medially you have the common hepatic duct. All right. Inferiorly you have the cystic duct, and superiorly you have the inferior surface of the liver. So if you take these three margins, that is the common hepatic duct, the cystic duct, and the inferior edge of the liver, then there is something present within the Callot's triangle, that is the cystic artery, right? So that is the content of the Callot's triangle. Now, in the original description of Callot's triangle, that is when Callot, for the first time, he gave the description of Callot's triangle. In his description, he said that the cystic artery was a superior border. So as far as he was concerned, cystic artery was a superior border and not the inferior surface of the liver. But as time progressed, so now why did Callot think that cystic artery is the border and not inferior edge? So he was looking from on top, right? But when we do a lap cholecystectomy, the camera is present. The camera is present inside the abdomen, so you are getting a different view. So lap cholecystomy, we are looking at the gallbladder in this direction, whereas if you do dissection from on top, you are seeing the organ from on top, right? So you're getting a different view. That is why this difference. So initially, when the Callot's triangle was described, he had given cystic artery as the superior border, but modern day it is the inferior surface of the liver which is the superior border. So one way of remembering it, now the cystic artery, it has a variable anatomical course. So if you use the inferior edge of the liver, then it gives you a better definition of it gives you a more consistent border, right? So that is one reason why it is used. So in an earlier question, I was mentioning acalculous cholecystitis when we were discussing HIDA scan, right? So now what are the causes of this acalculous cholecystitis? Now acalculous cholecystitis, it is an emergency. So let us discuss this topic. So if there is acute or chronic inflammation of the gallbladder, in the absence of stones, it can give rise to a clinical picture which is similar to that of calculous cholecystitis, right? So some patients, they have non-specific inflammation of the gallbladder, whereas others might have one of the cholecystosis. So they might have cholesterolosis, but some people might have non-specific inflammation. Now this is more common in patients, especially patients who are critically ill. So usually what happens is, you are supposing, say tomorrow you get a surgery seat, you're a first year resident and you get a call from medicine or from the ICU that this patient has pain abdomen. The medicine department, they got a USG done, and the USG says that there are no stones, but the gallbladder wall is inflamed. So it is an acalculous cholecystitis. So usually when you go to see such patients, you will notice a pattern. These patients are all usually elderly, they are critically ill, or they might be recovering from major surgery. For example, if the patient has undergone an abdominal aneurysm repair or cardiopulmonary bypass, when the patient is recovering from the surgery, the patient might get acute acalculous cholecystitis, or seen in trauma patients, burns patients, or long-term TPN. Now, the problem with acalculous cholecystitis is two things. One is that the mortality rate is high. Second problem is about the treatment. Now, for the treatment of cholecystitis is very easy. You just do a lap cholecystectomy. But the problem in such patients is that these patients, they are already terminally ill, or they might be critically ill. If not terminal, they might be critically ill, and they might already be recovering from a different surgery. So they will not get fitness to undergo a second surgery. So what do you do in such patients? So in certain patients, you can do a non-surgical treatment. So what is a non-surgical treatment? You give antibiotics, or you can do a percutaneous cholecystostomy. So what does this cholecystostomy mean? So cholecystectomy means you're going to remove the gallbladder. But in cholecystostomy, what do you do? Because the seen acute in any cholecystitis is this is the gallbladder and this is the cystic duct. Usually this portion gets occluded. Now, supposing there is a stone, so there is stasis of blood of bile over here, right? So sometimes what happens is the bilirubin might get absorbed, and only the remaining contents of bile are present. So that these patients are called a mucocele. Sometimes this bile might get infected, and then it forms an empyema. So if it is infected, where is the infection coming from? So if this is the common bile duct and this is the C loop of the duodenum, right? So there are bacteria present in the duodenum, and that might cause a retrograde infection. It might cause an empyema. Now, so supposing, so in this patient with acute acalculous cholecystitis, also there is acute acalculous cholecystitis. So there is no stone, but still this place gets occluded. Why? Because there might be inflammation, there might be edema of that area of the neck of the gallbladder. And so when there is edema, that edema, so normally say this is patent, right? When there is edema, both sides become swollen. So this becomes occluded. So it does not allow the bile to drain. So when it does not allow the bile to drain, there is collection of bile over here. There is stasis of bile that gets converted into pus. Supposing say the patient cannot undergo surgery, you can do another thing. What you can do is you take the patient to a good radiologist who is an interventional radiologist, and you do a percutaneous cholecystostomy. That means under radiological guidance, that is under USG or under CT scan, you picture where the gallbladder is, you see it on the screen, you place a needle above that, you aspirate the contents, right? So that is called a percutaneous cholecystostomy. While you are aspirating the contents, supposing if you place a drain over there and you keep the drain, you suture the drain in place, that is called that can also be done, and these patients, this procedure is called a percutaneous cholecystostomy. Fine. Next, all of the following are risk factors for CA gallbladder except. So typhoid carriers, yes, they are risk factors. Adenomatous gallbladder polyps, yes, especially the polyp is more than 1 centimeter. Choledochal cyst, yes, it is definitely a risk of malignancy. Oral contraceptives, no. So the answer is oral contraceptives. So let us look at the risk factors of CA gallbladder. Now, the risk factor of CA gallbladder is extremely variable by geographical region and racial ethnic groups. So especially it is common in parts of North India. So in West Bengal, Bihar, Northeast India, Bangladesh, in the Gangetic belt, it is common. Then there is an association with pre-existing gallstone disease. So gallstones more than 3 centimeter. 3 centimeter is the magic number. So this can cause chronic inflammation, which can cause gallbladder cancer. If the wall gets calcified, so for example, if there is porcelain gallbladder, if there is chronic infection, for example, in typhoid carriers, there is primary sclerosing cholangitis, especially in patients who have concomitant inflammatory bowel disease. So PSC or primary sclerosing cholangitis, it is more common in, there is an association with inflammatory bowel disease. If the patient has both IBD as well as PSC, then there is a risk for gallbladder cancer. If there is an abnormal pancreatic biliary junction, so what does this junction mean? What does this anomalous junction mean? So I told you in a previous diagram, Let me draw it again. Right hepatic duct, left hepatic duct, common hepatic duct, cystic duct, common bile duct, main pancreatic duct, and this is what you have. Now we have the ampulovator. Now supposing, let us say that this pancreatic duct, if it opens slightly separately, or if instead of both of them opening into the ampulovator, if they have the same opening, so that is an anomalous pancreatobiliary junction. Okay, next is gallbladder polyps. 1 centimeter is the magic number. So yeah, 10 mm. Choledochal cyst. Choledochal cyst, again in a choledochal cyst, there are two things. One is there is stasis of bile. Second is choledochal cysts are usually associated with an anomalous pancreaticobiliary junction. And PSC. PSC I've already mentioned. I think I mentioned it twice by mistake. Okay, moving on. A 40-year-old woman has undergone a cholecystectomy. The histopathology reveals that she's undergone a cholecystectomy maybe for gallstones, right? Histopathology reveals that she has a 3 centimeter adenocarcinoma in the body of the gallbladder, which infiltrates up to the serosa. So, which of the following further management would you advise her? Now, you have to TNM staging for all cancers, right? As far as the GIT is concerned, that is all tubular organs are concerned, size does not matter. Size matters, for example, in breast, where size matters, but in tubular structures, size does not matter. So similarly in gallbladder, so you want to see what are the layers of gallbladder. You have the mucosa or GIT, you have the mucosa, you have the submucosa, you have the muscularis propria. This contains an outer longitudinal and an inner circular muscle, and beyond this you have the serosa. So supposing if the tumor is over here, it has a different prognosis to a tumor which is say present, which is invading the deeper layers, right? So in this patient, it is infiltrating the serosa. So it is coming up to the serosa layer. So what do you do? Now, a gallbladder cancer can be detected in two ways. One is you do a cholecystectomy for a stone, you send the specimen for biopsy, and then they tell you that the patient has a malignancy. Now that is an incidental finding. Secondly, the patient might develop symptoms, you investigate, and it turns out that the patient has gallbladder cancer. So let us look at the treatment of CA gallbladder. Supposing if it is a pre-op diagnosis, that means she's got symptoms of jaundice, she gets cancer, then what do you do? So majority of these patients have advanced disease at presentation, and they're not candidates for surgical therapy. So there is no, in most of these patients, there is no way that you can remove the tumor and do, you remove all the tumor. So what you do is, you can do a diagnostic laparoscopy. You can do a diagnostic laparoscopy or a staging laparoscopy that is mandatory before you do a formal laparotomy. So you do a laparoscopy and see whether the tumor has spread or not. If there is occult mets, or if there is mets in lymph nodes which were not picked up on imaging, and you can see those mets on laparoscopy, then do not operate. Okay. Supposing if the patient is, you can do surgery, then what surgery will you do? You will do radical en bloc resection. Radical en bloc resection includes the gallbladder. So what will you remove? You will remove the gallbladder. You will do a wedge hepatectomy. So what is this wedge hepatectomy? You will remove 2 centimeters of liver in the gallbladder bed, or segments 4B and 5 if there is concomitant liver infiltration. So one more MCQ question. Which segment of the liver forms part of the gallbladder bed? That is segment 4. To be more specific, it is segment 4B. So if there is infiltration of the liver, you can either remove segment 4B, or you can even remove segment 4B as well as segment 5, which is next to it. So this is wedge hepatectomy. Sometimes you may also have to do what is called an extended hepatectomy. In extended hepatectomy, you are not only removing parts of the liver, you are also removing the common hepatic duct. So you will do bile duct resection if the bile duct is involved, or the cystic duct is positive on intraoperative frozen section. That means you know pre-op that the patient has gallbladder cancer. You go in, you do a laparotomy. You first do a diagnostic laparoscopy. You see that the patient is operable. You convert the diagnostic laparoscopy into a laparotomy. You start operating. And wherever you're planning to resect, you send the specimen for frozen section. What does frozen section mean? So usually whenever you send a biopsy for report, the pathologist takes some time, maybe 2 weeks or 3 weeks, 5 days, depending on where the center, depending on what kind of a center it is, and they'll give you the report. But supposing if you want an immediate decision, then it is called an frozen section. So what happens is you give the you send the specimen immediately to the lab pathologist, and they'll give you a diagnosis immediately. That is called an intraoperative frozen section. So supposing if you do an intraoperative frozen section, the cystic duct margin comes positive, then you might have to resect the bile duct. So along with removing the parts of the liver and along with removing the bile duct, you will also want to do a regional lymphadenectomy. So what do you remove in a regional lymphadenectomy? You will remove paracholedochal portal lymph nodes along with nodes of the right hepatic artery and the retroduodenal nodes. You will also consider removing these lymph nodes. The aim is to remove the tumor entirely and to achieve negative histopathological margins. So this is where you already know it is a gallbladder cancer. Now supposing if it is incidental gallbladder cancer, this was like, for example, in our patient in this question, so she underwent a cholecystectomy and then the histopath reveals that she has a malignancy. So in such patients, how do you approach such patients? So incidental gallbladder cancer is diagnosed following HPE, that is histopathological examination of gallbladder after it has been removed for presumed benign disease, maybe gallstones or gallbladder polyp or cholesterolysis. Okay? So in these cases, the need for further surgery is determined by the stage of the disease. So for an early stage disease which is confined to the mucosa of the gallbladder, if it is only the mucosa which is involved and the cystic duct margin is negative, right, then there is no treatment which is required. So look at the layers of the gallbladder which is involved. Supposing only the mucosa is involved, the duct margin is negative, then you no need to do any treatment. Supposing there is transmural disease. Transmural disease means it is infiltrating up to the serosa, or it is going deeper to the mucosa, going to submucosa or muscularis mucosa or serosa. In these patients, what will you do? You will do a radical en bloc resection of the gallbladder fossa and the surrounding wedge of liver along with regional lymph nodes. Fine. Now, supposing say if the first surgery was done laparoscopically, then because when you're extracting the gallbladder bed, there might be contamination of the port sites. How do I explain this to you? Wait. So when you're doing a lap chole, there are 4 ports, right? 10 mm, 10 mm, 5 mm, 5 mm. So usually you remove the gallbladder specimen from the epigastric port, right? So some surgeons, they use a bag routinely to remove the gallbladder. That means after they resect the gallbladder, they put the gallbladder in a bag and they remove the specimen along with the bag. But many times, many surgeons, they do not use a bag. So if you do not use a bag and you remove the gallbladder, it might touch the place where the port has been made. So there might be contamination and there is a theoretical risk of that port site being infected and malignancy occurring. So earlier, when I was preparing for NEET-PG, the answer for such a question was you have to remove the tissue at the port site. But now, the latest editions of Bailey and Love, it says that there is no need to routinely resect the port site. You examine the port site. If you feel that there is recurrence, then you do an extensive surgery. If you feel that there has been no recurrence, then you do not do the surgery. Now, supposing, say, if you see that there is, if you examine and you see that there is disease at the port site, then what surgery will you do? So if you want, you can remove the tissue and get negative margins. But the problem is that if you find disease at the port site, it usually means that the patient has generalized peritoneal disease. All right. And if there's generalized peritoneal disease, the patient carries a very poor prognosis. So the patient may not be able to withstand, tolerate a second surgery. Second thing is, even if you operate, the patient will anyways die. So what do you do? Instead of that, you give chemotherapy. Chemotherapy, so what is the drug of choice? You give capecitabine plus or minus gemcitabine or oxaliplatin. So in our patient, In our patient, there's a adenocarcinoma. See, the size does not matter. Like I told you, as far as tubular malignancies are concerned, size does not matter, unlike CA breast. All right. So is it infiltrating up to the serosa? That means you have to do a radical surgery. So the answer is radical cholecystectomy. Can be radical cholecystectomy along with the wedge hepatectomy, or it can be an extended cholecystectomy, depending on the frozen section findings. Now, what do you do in advanced disease? Advanced disease means you have diagnosed the patient preoperatively. Patient has symptoms of malignancy. The patient has mets in the virtual zone, that is in the supraclavicular lymph, left side supraclavicular lymph node. In such patients, what do you do? Such patients, there is no point operating in such patients. So you will do palliative therapy. What does palliative therapy mean? Palliative therapy basically means that for the remaining existence of the patient, you just take care of the symptoms of the patient. So suppose the patient gets pain, you give an opioid, you give a painkiller. The patient has nausea, you give an antiemetic. Now, supposing the patient gets obstructive jaundice, this means, when you go back to our previous diagram, and the patient gets obstructive jaundice, so maybe the tumor is infiltrating over here, over it is infiltrating. Then what do you do? You can place a stent over here. So because of this infiltration, if it infiltrates further and causes obstruction, you can place a stent over here. You place let me shade this obstruction. So in this place, obstruction has happened, right? So you place a stent over here. So once you place a stent, there is a pathway for bile drainage. Okay, moving ahead. So what is the most common surgical cause of obstructive jaundice? Now, jaundice can usually be two types. One is obstructive jaundice and one is medical jaundice, one is surgical jaundice. So jaundice can be medical or surgical. So surgical is usually obstructive jaundice. That means you require some form of surgical therapy. In a medical jaundice, you don't require surgery, you require some other form of therapy. So what is the most common surgical cause of obstructive jaundice? Actually, obstructive and surgical means the same thing. So the most common cause is CBD stones. So let us look at the cause. Causes of obstructive jaundice are choredocolithiasis of CBD stones. By the way, obstructive jaundice is a very favorite question of examiners in both NEET-PG and INI-CT. Even in NEET-SS, obstructive jaundice is a very favorite question of examiners. So you look choredocolithiasis or CBD stones, biliary strictures, cholangiocarcinoma, choredocal cyst, biliary atresia, carcinoma head of pancreas, serous cystic neoplasm of pancreas, intraductal papillary mucinous neoplasm, that is IPMN. These can all cause obstructive jaundice. A rare cause is a hepatocellular carcinoma. Now, how do you investigate such patients? So when you investigate such patients, when you do a liver function test, you will see two important things. You will see hyperbilirubinemia and you will see alkaline phosphatase. So when you look at liver function tests, liver function test, what are the components? You have bilirubin, right? Then you have two liver enzymes, SGOT and SGPT. This SGOT, SGPT, they are present within the hepatocyte. So whenever there is hepatic cell necrosis, these enzymes leak out and you get a raise in these enzymes. For example, if there is hepatitis due to any cause, it will cause raised SGOT and SGPT. The other two enzymes are ALP and GGT. So alkaline phosphatase is usually increased in cases of obstruction of the common bile duct. This obstruction can be in the form of anything. All the causes that we've detailed over here of obstructive jaundice, any of these causes can cause raised alkaline phosphatase. Next is GGT. GGT, the one function of GGT is, in obstruction cases, it is raised along with ALP. So it will give you a good idea as to, it will supplement your diagnosis. Second thing is GGT. So G for GGT and G for gin. Gin is an alcoholic drink. So GGT is raised GGT is usually present in chronic alcoholics. Now, suppose you want to get married and you do not know whether the girl or the boy drinks or not. and you want to be careful, you can get an LFT done. If GGT is elevated, it means the patient is a chronic alcoholic. Okay, so what other investigation will you do? You will do a USG, because the USG can detect CVD stones. The USG will also show intrahepatic biliary ductal dilatation. What does this mean? So this is the liver. You have the extrahepatic biliary apparatus over here, right? So you have biliary radicals, ductules even here. So you can see a dilatation of this on USG, and that is called intrahepatic biliary radical dilatation. Next, you can do an MRCP. Obviously, MRCP is one of the best investigative modalities. So how do you treat such patients? An ERCP is used to perform CVD clearance and also for the placement of stent. So it is both diagnostic as well as therapeutic. It is now usually used for therapeutic purposes. So now when you are doing an ERCP, so you are looking at the ampulla of Vater from an endoscopist point of view. So that means your camera is within the duodenum and you see an opening, right? So how do you remove the stone? You have to do a sphincterotomy. So wait a minute, let me draw this properly. So this is what you are seeing, right? So you have to make an incision in this opening, in this sphincter, that will cause a stone to come out. So what they usually do is, so you have to place the incision such that it does not hamper with the blood supply. So usually we do 9 to 4 jobs, right? Or 9 to 3 jobs. You go in the morning at 9 a.m., you come back by 3 p.m. That is your school timing also. So there is an artery at 3 o'clock and an artery at 9 o'clock. So an incision is usually made away from these sites. Usually you make the incision at 11 o'clock. Some people make it at 5 o'clock. So basically, why I'm mentioning this is you do not make it at 3 o'clock or 9 o'clock. Fine. Once you make an incision on this sphincter, the sphincter widens. Then you can insert something via the opening, extract the stone comes out, and then you place the stent. Once you remove the stone, then what do you do? Then that is followed by cholecystectomy. Next, so what is this Charcot's triad? Charcot's triad is seen in obstructive jaundice. Charcot's triad has 3 components. That is, there is fever, there is pain, and jaundice. This is usually seen in cholangitis. So in a patient who comes with obstructive jaundice and the patient has these 3 symptoms, fever, right upper quadrant pain, and jaundice, that means the patient is in Charcot's triad. Why is the Charcot's triad important? Because Charcot's triad, if it progresses into Reynolds pentad, then these patients have a almost 100% mortality. 100% mortality without treatment. So what do you call, so when it is called Reynolds pentad? Reynolds pentad means Charcot's triad plus shock plus mental changes. Okay, Charcot's triad, okay, I've already discussed this with you. Fine. Okay, we'll take a 5-minute break, a technical break, and then we'll resume. Okay, so let us continue. According to Strasbourg classification, lateral CVD injuries are classified as what? So let us look at the Strasbourg classification of CVD injuries. Okay, so in type A injuries, let me use a different color than green. In type A injuries, there is a bi-leak which can happen either. Okay, before that, let me just tell you how cholecystectomy is done. So this is the right hepatic duct, left hepatic duct, common hepatic duct, cystic duct, CBD. All right, common hepatic, CBD, right, left, and cystic duct. This is the gallbladder. So usually what we do in lap cholecystectomy is we place two clips. We have to basically separate the gallbladder from the biliary apparatus. So we place two clips proximally, one clip distally. All right, and we make a cut in between this. So when you make a cut in between this, that is, you make a cut over here. Make a cut over here. So when you make a cut over here, what happens is the gallbladder gets separated from the biliary and then you can extract it. So what is type A injury? In type A injury, what happens is there is leak from the cystic duct. So you can see some drops coming out, right? So there is some leak from the cystic duct stump. Along with that, see, now you have, this is the right hepatic duct and this is the left hepatic duct, right? But sometimes there might also be an aberrant duct. This is an aberrant duct. So sometimes there might be a bi-leak from the aberrant duct, and this is something which you're not anticipating. So if there's a leak from either the aberrant duct or the cystic duct stump, then it is called a type A injury. Now, supposing, see, so here you can see, this is type B. Here you can see that they've placed a knot over here, right? This is the knot. So supposing if you have accidentally ligated a right posterior sectoral duct, if you have ligated a right posterior duct, that is called type B. In type A, the duct was open. Type B, you have ligated it. So the way I remember it is B for band. So you have closed it, right? So what is type C? In type C, so see, whatever I am telling you, you need not fret because it is given over here. Type A, bi-leak from the cystic duct stump or minor biliary radical. Type B is occluded right posterior sectoral duct. So now let us look at type C. So in type C, there is, so in type B you had, it was bund, it was, you had ligated it. In type C, you have not been able to ligate it and there is bi-leak which is happening. You can see these drops coming out. This is type C. In type D, what happens is, there is an injury of the main, what is that? The duct. That is injury of either the CHD, common hepatic duct, or CBD, right? And but this injury, it is happening lateral. So supposing, say, if this is the duct, the injury is happening over here. So it is only over here. It is not, the entire structure has not been damaged. This is type D. Then type E. In type E, so see, in type D, you have only made an incision over here. There is no loss of the biliary tissue. In type E, on the other hand, there is some tissue loss which is happening, right? So in E1, whatever loss is happening in the biliary tissue, that is more than 2 centimeters from this, from the opening of the right and left hepatic duct. That is from the bifurcation, it is more than 2 centimeters. Type 2 is less than 2 centimeters. Type 3 is, it is at the bifurcation. So type E1 over here, it is more than 2 centimeters. Type E2, it is less than 2 centimeters. Type E3, it is at the bifurcation. But even though it is at the bifurcation, you can see that both these ducts, they are communicating with each other still. All right. But in E4, what happens is, actually this diagram is slightly wrong. There should be a separation over here. In E4, what happens is the left and the right hepatic duct, they get separated. All right. In E5, what happens is, this is E5. In E5, there is a stricture which involves both. So there's a stricture over here. That is why it has become narrow. And there's a stricture in the right posterior sectoral duct. Okay. And E6 is where this entire thing is removed. So only the two openings of the right and left hepatic ducts are remaining. Everything else, there's a loss of tissue. So now, how do you treat such injuries? So what are the goals of therapy? So in the goals of injury are, first one is you control infection, which limits inflammation. Basically, so whenever there's an injury where there's going to be bile leak over there, along with bile leak, there might be some, because the biliary tree is communicating with the duodenum, there might be some contamination of the bile that might cause an infection. So your first goal is to control the infection, which will limit the inflammation. You do this how? Either by giving parenteral antibiotics, or you might also have to do a percutaneous drainage. That is, you place if you do a surgery, you place a drain and you come out. Or if you want to do a minimally invasive technique, you can do a percutaneous drainage. Second is, you need to know clear and thorough delineation of the entire biliary anatomy. This means that you need to, so these injuries, it can happen two reasons. I mean, once the injury happens, you can identify it in two times. One is you identify it intraoperatively. While after doing the injury, you realize that there is some problem and you can identify the injury. Second thing is intraop, you're not able to identify it, and post-operatively maybe the patient has jaundice, or maybe the patient, the drain that you've placed over there, that starts leaking bile. So then you have to send the patient for an MRCP. Once you send the patient for an MRCP or maybe even a PTC, a percutaneous transhepatic cholangiography, that will delineate the anatomy properly. Third one is you can do an ERCP. ERCP is an endoscopic we already discussed it. So an ERCP is usually done, especially when you suspect a cystic duct stump leak. Okay, that means cystic duct stump leak was present in type A and type C, in both these places, in type A and type C. Now, the thing is, supposing if the leak is happening from a sectoral duct, usually the leak settles on its own. If the leak is from a cystic duct, then what happens is you place a stent over here via ERCP. Once you place a stent over there via ERCP, there is no bile which is going to enter the cystic duct, right? So that bile will stop leaking, and with time, the opening, it closes automatically. There is epithelialization which occurs and it closes automatically. That is why you do a ERCP. Now, supposing if there is loss of tissue, that is from type E onwards, what do you do? Your idea is to re-establish biliary enteric continuity. So how do you do that? You can either do a tension-free mucosa to mucosa anastomosis. That is, if those cut ends of the biliary, supposing if say this is in continuity, this is the bile duct, right? And you made a cut over here, so it gets separated. Supposing if you can bring them back together and anastomose it such that there is no tension in this anastomosis. That is, you do a tension-free mucosa to mucosa anastomosis. Fine, that is one thing. Second thing is you might have to do a Roux-en-Y hepatico-jejunostomy. That is, in patients over here where such as E3, where the entire biliary, the distal biliary apparatus is lost. So you bring a loop of jejunum over here, and you make the anastomosis. That is called a Roux-en-Y hepatico-jejunostomy. Last option is you can do a long-term trans-anastomotic stent if bifurcation or higher is involved. So you place a stent over there and allow the injury to heal. Next, what are the risk factors of cholangiocarcinoma? So risk factors of cholangiocarcinoma are all except which of the following? So ulcerative colitis, yes. So whenever there is inflammatory bowel disease, it predisposes to getting cholangiocarcinoma, especially if the patient also has primary sclerosing cholangitis. If there is hepatolithiasis, basically if there is any inflammation in the biliary apparatus, that predisposes to getting cholangiocarcinoma. Non-alcoholic fatty liver disease. In biliary atresia, there is no inflammation which is happening. So that is why it is not a risk factor. So let us look at the risk factors. So this is a table given from Bailey and Love. So PSC, Oriental cholangiohepatitis, hepatitis C infection. These are chronic inflammatory conditions. Along with that, infections such as Clonorchis sinensis, Opisthochus viverrini. So this is these will also called brown pigment stones. We will discuss this in a separate question. If there is choledochal cyst or Caroli's disease, that can also cause cholangiocarcinoma. Chemical agents, for example, if the patient you are going to use thorotrast, which was used earlier, vinyl chloride, dioxin, asbestos, post-surgical with biliary enteric anastomosis or non-alcoholic fatty liver disease. These can all cause cholangiocarcinoma. Now, the risk of development of cholangiocarcinoma, it correlates with chronic inflammation in the biliary tree. So, choledochal cyst will predispose to development of cholangiocarcinoma because choledochal cysts usually are associated with anomalous pancreatobiliary junction. So the pancreatic duct is also exposed to certain bile duct excretions. That is why there is an inflammation over there, predisposes to cholangiocarcinoma. Whatever I have typed over here, these are not mentioned in the box above. That is why I have typed it separately. Next is recurrent pyogenic cholangitis. Then PSC, primary sclerosing cholangitis. It's mentioned over here, but I've mentioned it separately because this is the most common risk factor for cholangiocarcinoma in the West. This is an MCQ question. This risk is increased in those with associated inflammatory bowel disease. Then oral contraceptives, smoking, and cirrhosis of the liver. Now let us look at the Bismuth-Corlett classification of cholangiocarcinoma. So type 1 is confined to the hepatic duct. It is confined to the hepatic duct, but it does not involve the main biliary confluence. Type 2 is it involves the, so you can see over here, it involves the confluence, right? Type 3A is it involves the right hand side. So this is being involved. 3B is it involves the left side. And 4 is it involves both sides. That's what I've mentioned over here. Type 1 is confined to the hepatic duct, not involving main biliary confluence. Type 2 is it involves the main. 3A is right. 3B, this is a typing mistake. This should be left secondary biliary confluence. 4 is it extends to both sides. Next, what is Saint's triad? Now, Saint's triad, it has 3 components. Usually I remember it by the mnemonic GHD. So where G stands for gallstones, H stands for hiatus hernia, and D stands for diverticuli of the colon. So these 3 together are called Saint's triad. Next is Mirizzi syndrome. So what is Mirizzi syndrome? So Mirizzi syndrome is because of a gallstone. I'm sorry. Whenever the gallbladder stone, it compresses the common hepatic duct, it is called Mirizzi syndrome. So Mirizzi syndrome, you understand from this diagram. So here there is a large stone in the neck of the gallbladder. It is in the infundibulum or neck of the gallbladder, and this is compressing. You can see over here that this portion is getting narrowed, right? This portion is getting narrowed. So it is causing some obstruction. This is Mirizzi syndrome. Now, so the stone can either be in the gallbladder, the stone can also be in the cystic duct. So, see, there is an impacted gallstone which comes from the gallbladder, it enters into the cystic duct. So, if there is an impacted stone in the cystic duct, this will then cause compression of the common hepatic duct, or maybe directly because of the stone, or maybe because of inflammation, because of edema. So, then that will cause obstruction over this of this common hepatic duct. So basically, whenever the common hepatic duct is getting obstructed secondary to a stone, then that is called Mirizzi syndrome. So usually these patients, they have some predisposing anatomical abnormality. So in these patients, the cystic duct is parallel to the common hepatic duct. So if you remember in all the diagrams, whenever I draw this diagram, I always draw the cystic duct separately. I draw it like this. right? But in these patients, what happens is, in these patients, this is the common hepatic duct. The cystic duct is almost parallel to the common hepatic duct. Okay, and because of the inflammation, there can also be a cholecystocholedochal fistula. That is, there is a fistula between the cholecystis, that is gallbladder, and choledochal, that is a CBD. So treatment of Medici syndrome is you remove the gallbladder, because the gallbladder is what contains the stones, and that is a place where stones can form. And after you remove the gallbladder, depending on whether the common bile duct, what is the damage in the common bile duct and the common hepatic duct, you might have to do a repair. Sometimes if you just place a stent, it allows the duct to expand and it returns to its normalcy. But supposing if there's a large fistula, then you might have to do a choredochojejinostomy. Or you might have to do a Roux-en-Y hepatico-jejinostomy. Okay. Which of the following is not a cause of acute pancreatitis? So hypercalcemia is a cause, TTP is a cause, cystic fibrosis is a cause. MRCP is obviously not a cause. Even if you do not know this, even if you do not know the cause of acute pancreatitis, this is still not a cause of acute pancreatitis, because MRCP is a non-invasive procedure, right? So even if you do not know the causes of acute pancreatitis, you can still guess the answer. Now, what is the etiology of acute pancreatitis? So gallstones or biliary calculi is the most common cause of acute pancreatitis, and alcoholism is the second most common cause of acute pancreatitis. But for chronic pancreatitis, alcohol is the most common cause. Then acute pancreatitis can also happen post ERCP. That means when you're doing an ERCP, you have to cannulate the common bile duct and the main pancreatic duct, right? So you have to cannulate the CBD, and the dye has to go into the biliary apparatus. Sometimes the dye might enter into the main pancreatic duct. When it does so, it will cause ERCP can cause pancreatitis. One moment. Next is blunt abdominal trauma. Blunt abdominal trauma being a cause of pancreatitis, it is the most common cause, especially in children. So supposing a child is riding a bicycle and there is a sudden break, the handle of the bicycle hits the the epigastrium on the upper part of the abdomen, and then there is injury to the pancreas. So that can also predispose to pancreatitis. Then following biliary, upper gastrointestinal or cardiothoracic surgery, ampullary tumors. So certain drugs can cause steroids, azathioprine, asparaginase, valproic acid, thiazides, estrogens. There is hyperparathyroidism or hypercalcemia. Both are basically the same thing. So you need to remember that hypercalcemia is a cause of acute pancreatitis. And once there is pancreatitis, then you will get hypocalcemia. You have to notice the difference between these two things. So once there is pancreatitis, hypocalcemia, it is also a component of Ranson score. So then you will get to know the prognosis of those patients. Then hypertriglyceridemia, pancreas divisum, diverticulum, sphincter of Oddi, Sjögren's syndrome, hereditary pancreatitis, cystic fibrosis, viral infections, malnutrition, Skopin by TTP, CA pancreas, idiopathic. These are all causes of acute pancreatitis. Now, what is the meaning of acute pancreatitis? Acute pancreatitis is defined as an acute condition which presents with abdominal pain, epigastric pain which radiates to the back, a threefold or greater rise in the serum levels of pancreatic enzymes, amylase or lipase, and characteristic findings of pancreatic inflammation on CECT. So, there is pain abdomen, there is a threefold or greater rise in the serum levels of amylase or lipase. Lipase is more sensitive, but if either amylase or lipase is raised 3 times, it is along with abdominal pain and inflammatory findings on CT scan, it is acute pancreatitis. So which of the following is the most diagnostic investigation for pancreatitis? Here you have both options, amylase and as well as lipase. But so your answer will always be serum lipase. Why is that? This is because serum lipase, it has a longer half-life. So the way I remember it is L for lipase, L for longer half-life. So it has a longer half-life. So that is why it is a better diagnostic tool. Along with this, what will you do? Supposing if you take an X-ray of the chest and abdomen, this is not diagnostic of acute pancreatitis, but you can get certain non-specific findings. What are those? One, you can get a sentinel loop. Sentinel loop means what? Sentinel means guard. So near the because there is, see, the pancreas, it is associated, you have to look at the relations of the pancreas. So anterior to the pancreas, this is the pancreas. Anterior to it, you have the stomach and the duodenum. And anterior to that, you have the transverse colon. So what happens is, because there is inflammation in the pancreas, it affects the adjoining organs, right? So supposing if there is dilatation of a bowel loop close to it, so you can get, so then there is ileus over there. So if it is generalized or local ileus, that is also called sentinel loop, because basically there what happens is a part of the bowel gets dilated and it looks like as though it is guarding the pancreas. Next, you have colon cutoff sign. Colon cutoff sign, because the pancreas is related to the transverse colon. So there is ileus in that part of the transverse colon. So it looks as though there is that part, I mean, since there is ileus at that portion of the transverse colon, it looks as though there is nothing traveling from the proximal to the distal part, as though the colon has been cut off from its distal part. Then you can also get renal halo sign. Occasionally you can see calcified gallstones or pancreatic calcifications. The chest X-ray may show a pleural effusion and it might suggest ARDS. USG does not establish a diagnosis of pancreatitis because it is user limited, but it can detect gallstone as a potential cause. That is why USG is always done. Second thing is, it will rule out acute cholecystitis. It will also tell you whether CBD is dilated or not. It should be performed within 24 hours in all patients. Then CCT abdomen. CCT is obviously the investigation of choice, and it is indicated even though, since it is the pancreas is a retroperitoneal organ, but specifically it is indicated in diagnostic uncertainty. In patients, if you want to differentiate severe acute pancreatitis with necrotizing pancreatitis, then the severity of the pancreatitis detected on CT, it may be staged according to Balthazar criteria. It is indicated in patients with organ failure, signs of sepsis or progressive clinical deterioration. And when you suspect a localized complication, for example, there might be a pseudocyst, there might, so see, whenever there is, wherever there is inflammation, there is edema, right? So when there is inflammation of the pancreas, fluid collects around the pancreas. And if you want to look at how much fluid has collected and what is the nature of that fluid, that is best seen on a CCT of the abdomen. You can also notice a pseudoaneurysm. So similarly, you will do an MRI scan, you will do MRCP and ERCP. The advantage of an ERCP is, supposing say the pancreatitis is because of a gallstone in the CBD, you can remove that stone. So once the stone is removed, so it therefore becomes therapeutic. So which of the following does not cause an increase in serum amylase? Now, we just discussed that amylase is used to diagnose pancreatitis, but what are the other conditions in which serum amylase is raised? So let us look at those conditions. Upper GI perforation. So whenever when you were doing your internship, you might have noticed that whenever you get a patient of air in the diaphragm, supposing if you send an amylase lipase also, amylase comes raised. Mesenteric infarction, torsion of intra-abdominal viscus, retroperitoneal hematoma, ectopic pregnancy, macroamylasemia, renal failure, salivary gland inflammation. In all these conditions, serum amylase will be raised. So the correct option here is, correct option here is cardiac failure. In cardiac failure, it is not raised. Next, let us look at the scores which are used in acute pancreatitis. So, all of the following can be used to predict severe acute pancreatitis except. So, what are those scores and their values? So, a Glasgow score of 3 or more is used. Apache 2 score of 8 or more is used. CT severity score of more than 6 is used. C-reactive protein of less than 100, this is obviously wrong. The correct answer is CRP more than 130. Now, supposing if you do not know anything about this question, you can still guess it, because see, CRP is an inflammatory marker, right? So if whenever there is any inflammation, the CRP should be raised. So here they're telling the option is CRP less than 100. So by default, then that becomes the answer. Now, there are some other scores which are used in pancreatitis. So that is, one is Ranson score, one is a Glasgow score. So Glasgow score of 3 or more indicates severe pancreatitis. Okay. Now, what are the other scoring systems that are used? So usually whenever you are working in your ICUs, you might have noticed that there are scores like SOFA score or Apache 2 score, which are usually used in all patients in ICUs. So that score can also tell you the severity. So one among that is an Apache score. Apache score of 8 or more is indicative of severe pancreatitis. Other scores are SAPS, SOFA, MODS, Modified Marshall score. So regardless of the scoring system that is used, a persisting organ failure indicates a severe attack. So let us look at the Ranson score in detail. Now, Ranson score is a scoring system which is it is specific for acute pancreatitis. So unlike SOFA score or SAPS score or Marshall score, it is specific for acute pancreatitis, and a score of 3 or more at 48 hours is indicative of a severe attack. Now, the score is different for an alcoholic cause and for a biliary cause. Right? The score is different for an alcoholic cause and for a biliary cause. Now, what is the drawback of this score? Drawback of this score is that when the patient comes to an admission, if you want to know the prognosis of the disease or the severity, you can't use Ranson score, because you need two parts. One is on admission and the other is at 48 hours. Right? So that is the reason that this is one of the drawbacks of Ranson score. Now, the parameters of this score, it is different for alcoholic cause and biliary cause. So now I always used to remember this using the mnemonic B. The mnemonic that I used was BAWAL or Bawal. So blood glucose, age, WBCs, AST and L. So please note that amylase is not a part of Ranson score. Even though amylase is used to diagnose acute pancreatitis, serum amylase is not a part of Ranson score. Okay. So blood glucose of more than 200. So whatever is seen in alcoholics, a slightly higher values in biliary cause. So 200 over here, 220 over here. Age 55, slightly higher, 70. White blood cells 16,000, here it is 18,000. But this AST is similar. So AST of more than 250 units per liter. This is similar. And lastly, you have LDH of 340 over here and 240 over here. So at 48 hours, what other parameters will you want to see? So you will note that there is a drop in hematocrit of more than 10%. Here it is the same, more than 10%. If there is a blood urea nitrogen increase of more than 5, here it is increase of more than 2. Calcium less than 8, which is the same in both. The partial pressure of oxygen in arteries is less than 60, it is the same in both. Base deficit of more than 4, of more than 5. Fluid loss of more than 6, fluid loss of more than 4 liters. So you have to, there's no shortcut, you have to memorize too many values over here. So for the parameters, then one mnemonic that I used is Bawal over here. Here the mnemonic that I remember from my PG days is C. My mnemonic is okay. So C is for calcium, H is for drop in hematocrit, A is for partial pressure of oxygen in the arteries, U is for blood urea nitrogen, B is for base deficit, and E is for extracellular fluid loss. So Bawal and Chaube were the mnemonics that I used during my NEET-PG days, and strangely I still remember it. So if these mnemonics are helpful to you, you can use these mnemonics. Okay, now all are true about chronic pancreatitis except. So it is characterized by irregularities of the pancreatic ducts duct strictures and areas of dilatation, this is true. 60 to 80% will give you a history of acute episode, this is true. CT scan showing pancreatic calcification is diagnostic of chronic pancreatitis, this is also true. Amylase is always raised, this is false. Now, I think I told you in a previous session that whenever in the options, if you get the word always, always is always incorrect and never is never correct. So let us look at the pathology. At the onset of the disease, when symptoms have developed, the pancreas may appear normal. Later, as the pancreas enlarges and becomes hard, because after inflammation there will be scarring, right? There will be fibrosis. So the pancreas enlarges and it becomes hard. So as the pancreas enlarges, the ducts become distorted and dilated with stricture formation as well as ectasia. That is, there's abnormal dilatation as well as strictures in the ducts. Then some stones might form in the main pancreatic duct. These stones might be either very small, where it weighs a few milligrams, to maybe 200 milligrams. Then the ducts become occluded with a gelatinous proteinaceous fluid, and debris and inflammatory cysts may form. That is, a pseudopancreatic cyst may form. Do I have a diagram of this? Let me just check. Yes. So I have a diagram over here. Here you can see that the pancreatic duct, it is dilated over here. It is dilated, and there is a stone formation inside. You can notice the stones formation. Initially the pancreas enlarges, and later, as there is fibrosis, the pancreas shrinks and the pancreas atrophies. So because the pancreas atrophies, the exocrine as well as the endocrine function of the pancreas becomes compromised. So how will you investigate a patient of chronic pancreatitis? Serum amylase is used, but it is not always raised, and it is used only in the early stages of the disease. Then you can use pancreatic function tests, because these will confirm the presence of pancreatic insufficiency, that more than 70% of the gland has been destroyed. That means more than 70% of the gland needs to be destroyed before you get a pancreatic function test to be positive. And MRCP, obviously. Now, when you use MRCP, you can also use a provocative test. That is, you can give the patient secretin intravenously. So secretin, what happens is, secretin, it will promote the secretion of pancreatic juice. So when you give secretin, and supposing there is a pancreatic duct stricture, so you can see that there will be dilatation beyond the stricture, proximal to the stricture. So this is not apparent on standard MRCP, but whenever you give the patient a provocation in the form of an IV secretin, this will be seen. Next, ERCP is the most accurate way of elucidating the anatomy of the duct. Fine. Now, along with the morphology, it can also tell you what type of operation is required, and if at all operative intervention is indicated. Now, supposing if you do a USG, there are certain sonographic findings which are characteristic of chronic pancreatitis. Now, this USG, it can be done in an endoscopic form, endoscopic ultrasound, and there is certain criteria called Rosemont criteria. So what are some of those? You don't need to know the details of Rosemont criteria for your level, but you need to what findings are characteristic of pancreatitis. You will see stones, you will see visible side branches. So see, normally this is the pancreatic duct and there are small branches on either side, right? But usually you're not able to see these. Usually you're not able to see these small branches because they are very small. But if there is a stricture in the main pancreatic duct, then these small things, they become big. So when they become big, that is when they become dilated, you will see it is then that it becomes visible. You can see cysts, lobularity, you can see an irregular main pancreatic duct, hyperechoic foci and strands, dilatation of the main pancreatic duct, and hyperechoic margins of the main pancreatic duct. So if there are 4 or more features of this, it is highly suggestive of chronic pancreatitis. Now, pseudocyst of pancreas. So whenever there is pancreatitis, there is collection of fluid around the pancreas, right? So if that fluid persists for more than 4 weeks, it can form a pseudocyst. So pseudocyst is for 4 or more weeks. This fluid which accumulates, it is usually amylase rich fluid. And why is it called pseudocyst and why is it not a true cyst? Because a true cyst is lined by epithelium, whereas a pseudopancreatic cyst, it has a fibrous wall or a granulation tissue. Okay, so how do you investigate such patients? If you do a barium meal, you can, so one problem with pseudopancreatic cyst, it will, since the stomach is present anterior to the pancreas, the cyst is big enough in size, it will cause early satiety. So if the cyst projects into the stomach, that is seen on barium meal. Next, CT scan will be seen, you can do it. MRCP, you will be doing it. MRCP will tell you the finer details, right? So whether the cyst is communicating with the pancreatic duct or not, that you will get to know. You can also do an endoscopic ultrasound. Along with doing an endoscopic ultrasound, you can also aspirate the cyst fluid and then do a fine needle, you do a cytology of that fluid. Then you can also do a CEA. Supposing if the level of CEA is more than 400, then that means it is a mucinous neoplasm. In a pseudocyst, it has low CEA levels. And a pseudocyst, because it is because of inflammation, it usually has high amylase levels. So how do you treat? Now, pseudocysts of pancreas, they usually resolve spontaneously. Okay, but some do not resolve spontaneously. So which are those pseudocysts which resolve, which are less likely to resolve spontaneously? So the answer is they are thick-walled. If they are large, by large you mean more than 6 centimeters in diameter, if they are present for more than 12 weeks, and they have arisen in the context of chronic pancreatitis. Now there are three approaches. You just basically need to drain the pseudocyst, right? So there are three approaches. You can either use an endoscopic, a percutaneous approach, an endoscopic approach, or a surgical approach. So percutaneous approach, you're going to do a transgastric cystogastrostomy because pancreas is present behind the stomach, right? So you're going to do a transgastric. You're going to go via the stomach, across the stomach into the pseudocyst. That is why it is called a cystogastrostomy. When you do it, you can put a double pigtail catheter so the catheter stays in place. That acts as a percutaneous drainage. You can also do it endoscopically. Endoscopically means you pass an endoscope via the mouth, it goes via the esophagus into the stomach. Once it goes into the stomach, you can then visualize the cyst and then you can puncture the cyst. When you puncture the cyst, then also you might have to puncture either the stomach or the duodenal wall. Then surgical. So the treatment of choice is usually a cystogastrostomy. That is, you establish a connection between the stomach and the cyst. That is called a cystogastrostomy. Now, supposing say the cyst is huge and it is not, you're not able to establish a communication between the cyst and the stomach. Then you can do something called a cystogeginostomy. Okay, what is not true about mucinous cyst adenoma pancreas? So let us look at the differentiating characteristics of the different cysts. So you have you have a pseudocyst of pancreas, you have serous cyst adenoma, you have mucinous cyst adenoma, and you have an intraductal papillary mucinous neoplasm. Okay. So this is the table. This table is taken from Sabiston. So a pseudocyst is more common. A pseudocyst it is equal in both females and males. That is, there is no gender predilection. Serous and mucinous are both common in females. But in mucinous, it is more common compared to a serous because here the ratio is 10:1. Here the ratio is only 4:1. In pseudocyst and in IPMN is nothing but an intraductal papillary mucinous neoplasm. So in pseudocyst and IPMN, it is equal, the gender predilection. The age, pseudocyst, it is 40 to 60 years. This is 60 to 70, 50 to 60. Age is not so important. Now, what is the location of these cysts? So pseudocyst is more common. Pseudocyst is evenly distributed. Serous cyst adenoma, it is this is wrong. It is in the head actually. So the mnemonic that is used is sir or sira means head, right? So serous cyst adenoma, serous, the word serous contains the word sir, so it is head. Mucinous. Now mucinous is more common in females. Now, when you are, what you want to look for, this is a very vulgar mnemonic again, but this is the way I remember it. When you look at a female, you want to look at her body and her tail, right? So, a mucinous cystadenal neoplasm, that means you're looking at her hips and her body, right? So, MCN is more common in the body and the tail. So since it is more common in females, it has more common in the body and tail of the pancreas. Along with that, okay, I'll come back to it later. Okay, wait. Along with this body and tail, there is mucinous. It also contains the focus of ovarian stroma. So this is how you remember it. Females, ovarian stroma, more common in body and tail. It is, it goes, you can remember it in that way. IPMN, on the other hand, is more common in the head. Okay. So what is the appearance of a pseudocyst? It is round. It is a thick-walled, large cyst. Okay. And there might be gland atrophy plus or minus calcification. In a serous cystadenoma, S for serous, S for small. So you will see multiple small cysts. Along with that, you will see septations, again SS. And you will see star burst or a central stellate scar or a central stellate calcification. So again, you will see SSS. Now MCN, mucinous, like I told you, it is more common in females. And in females, bigger the better. Again, you look at a vulgar mnemonic. The bigger the better. So these cysts, they are macrocyst. Macro means they are bigger. They have a smooth contour. Again, if you think dirty, it becomes easy to remember. Along with that, it is thick-walled. So again, if you have a dirty mind like me, it is easy to remember this. Then it is a plus or minus a solid component, and you will also see eggshell calcifications. So females, ovaries, eggs, eggshell calcification. IPM, on the other hand, is poorly demarcated. It is lobulated, polycystic mass with dilatation of main or branch ducts. Next, if you look at the communication with ducts, pseudocyst, it communicates with ducts. Serous does not communicate. Mucinous also does not. It is very rare. IPMN does. So, see, it is intraductal papillary mucinous neoplasm. So the name itself suggests it is communicating with the ducts. Pseudocyst, on the other hand, because there is the cyst, it is rich in amylase, right? So it is going to communicate with the pancreatic duct. So when you do a cytology, when you aspirate that fluid and you send it for cytology, pseudocyst, what do you see? You will see inflammatory cells. In SCN, S for sugar. So you will see glycogen-rich cells which have positive PAS stain. PAS stands for periodic acid skiff stain. So again, SSS is seen. Mucinous, you will see columnar mucin containing cells. IPMN also, you will see columnar mucin containing cells. Then coming to mucin stain. Mucin stain is positive in MCN and IPN. As the name itself suggests, mucinous cystic neoplasm and intraductal papillary mucinous neoplasm. Then if you look at the amylase, amylase is very high in pseudocyst because it is an inflammatory condition, and it is high in IPMN. Last is CEA. CEA. So it is, since the MCN has ovarian stroma, so the CA content is high. It is also high in IPMN. Okay. So what are the sites of pancreatic lesions? Pseudopancreatic cyst is more common in the body and tail. It is evenly distributed, but if a question comes in the exam, you will say lesser sac. Insulinoma is equal, vipoma is tail, leukogonoma is body and tail, somatostatinoma is head, PDAC is, that is pancreatic ductal adenocarcinoma. CA pancreas more common in the head, and this I've already discussed with you. Now, what do you mean by an annular pancreas? So now this is the stomach, this is the C loop of the duodenum, and you have the pancreas over here. Right, this is the pancreas. So now sometimes what happens is the pancreas, it encircles the duodenum. When the pancreas encircles the duodenum, it is called an annular pancreas. So it is a congenital anomaly. It is because of failure of complete rotation of the ventral pancreatic bud during development. So there is a ventral bud, it has to completely rotate and come back. It does not rotate completely, that is why it forms a ring. So what is important is it is associated with Down syndrome, and it will seen in duodenal atresia. So you will also see double bubble sign. The treatment is a duodenostomy. So you can see over here the pancreas is encircling the duodenum. Okay. Next, coming to spleen. So what is the most common infection after a splenectomy? The most common infection after a splenectomy is pneumococcal infections. So after a splenectomy, the infection with capsulated organisms become more common. These are Streptococcus pneumonia. Then there is meningococcus, and then there is also Haemophilus influenza. Haemophilus influenza B. So I'm sorry, the answer I mentioned over here is wrong. That is why I was stammering. The most common infection is Streptococcus pneumonia. That is Streptococcus. Have I mentioned it? Yes, Streptococcus pneumonia. There's a mistake in this in the answer. So the answer is Streptococcus pneumonia. So OPC, what is okay? So after a splenectomy, bacteria which contain capsules in their wall, right? These are more common. The infections caused by these bacteria are more common. So what are these? So these are Streptococcus pneumoniae, Neisseria meningitis, and Haemophilus influenza type B. These are more common, and these can cause fatal infections, which are called OPSI, or opportunistic post-splenectomy infections. This is the most common fatal late complication of splenectomy. Now, E. coli can also cause post-splenectomy septicemia, but supposing if an option, if a MCQ is given which has 4 options, and these are Streptococcus, Neisseria, Haemophilus, and Escherichia coli, you tick E. coli, because these 3 are the most common and the most important ones. Now, who are the patients who are at risk of OPSI? So, young patients, and splenectomy is patients who have undergone chemoradiotherapy. That means they've undergone splenectomy for a malignancy, or patients who have undergone splenectomy for these various other causes, patients who are immunosuppressed. How do you prevent this OPSI? So you have to give vaccines. So when do you give the vaccine? In an elective splenectomy, you will give the vaccine. Ideally, you will give it 10 to 12 weeks before the surgery, or at least 14 days before the surgery. In an emergency surgery, you give it before the patient is discharged. Supposing if the patient is being discharged in say 5 days after surgery, you give the patient the vaccine and then send the patient home. Supposing the patient stays in the hospital for say 2 weeks, then you give it after 14 days. So 14 days after splenectomy or upon discharge, whichever comes first. The idea is that if the patient goes home without taking the vaccine, he may not come back to take the vaccine, right? That is why. And you can also use antibiotic prophylaxis, but this is kind of controversial. So for less than 5 years age of the patient, you give a daily dose till the age of 10, more than 5 till the age of 16. Adults, it is, there is no proper regime. So what antibiotics will you give? You will give penicillin, erythromycin, amoxicillin, or coamoxiclav. Now, what is the most common set of accessory spleen? Accessory spleen is also known as splenunculi. So splenunculi, don't go by the name and think it is a stone in the spleen. Splenunculi basically means an accessory spleen. So let us look at this diagram. So in this diagram, wherever you can see these black dots, right? Wherever you can see these black dots, that is as accessory spleen. So the most common location is in the hilum of the spleen. This is the most common location. Hilum of the spleen is the most common location. Now, what is the importance of this accessory spleen? Basically, supposing the patient has hereditary spherocytosis or some other disease such as ITP, you are going to remove the spleen, you are going to do a splenectomy, right? But after splenectomy also the patient is not improving. Why? That is because the patient has too many spleens. So he has accessory spleens. Okay, food can commonly get obstructed in the esophagus at all of the following locations except. Basically, they are trying to ask you which are the physiological regions of narrowing of the esophagus. So, there are three narrowings of the esophagus. One is the cricopharyngeus or the upper esophageal sphincter. This is the narrowest part of the GIT. Second part is the site of bronchoaortic constriction. Third is the diaphragmatic constriction. So the importance of these constrictions is that foreign bodies such as a food bolus might lodge here. So again, this diagram tells you the same thing. Cricopharyngeal constriction, aortic and bronchial constriction, and diaphragmatic and sphincter constriction. But among all these three constrictions, the narrowest is the first part, that is the cricopharyngeus or the upper esophageal sphincter. Okay, so we'll take a technical break here and we shall resume in 5 minutes. So moving ahead, what is the most common type of tracheoesophageal fistula? The most common type, let me look at it. I'll show it to you from this diagram. So the most common type is type C. So you have you have 5 types. The most common type is type C. This is 86%. So what is tracheoesophageal fistula? So basically, there might be esophageal atresia along with a communication between the esophagus and the trachea. So in type A, what happens is the proximal end of the esophagus and the lower end both are blind. In type B, there is a connection between the proximal end and the trachea. The distal end is blind. In type C, proximal end is blind, but the distal end there is a connection. So you start with both the proximal and distal being blind, and from above to below there is a connection. After that, so in type B there is a connection on top. Type C there is a connection below. In type D there is a connection of both. So D for double, a mnemonic to remember it. So there is a connection between the upper part as well as the lower part. In type E, an H-shaped structure is seen. Basically, the esophagus is in continuity and there is a fistula between the esophagus and the trachea. So type C type C is the most common type. In type C, what happens is the proximal end is blind, but the distal end is communicating with the trachea. Okay, so moving ahead. So why is this condition important? Because you have to recognize it within 48 hours of birth. If you do not recognize it within 48 hours of birth and do immediate surgical correction, there might be the child might lose its life. So types I've already discussed. It is more common in males, and you can detect it antenatally or before birth. Antenatally, what happens is when the esophagus ends blindly, the amniotic fluid cannot be swallowed, and therefore there is polyhydramnios. So where does this amniotic fluid comes from? Basically, the child is urinating. The child swallows that urine and urinates it. So here the child is urinating. It swallows that amniotic fluid, but it cannot be swallowed. I'm sorry, it tries to swallow it, but it cannot be swallowed because the proximal pouch is blind. So because of that, there is polyhydramnios. Now in type A, what is the treatment? In type A, the stomach may be small or difficult to detect antenatally. So the radiologist might tell that the stomach is absent. So if you get an MCQ where they tell you that USG was done, but the stomach was not seen antenatally, the answer can be a tracheoesophageal fistula type A. After birth, how does the patient present? The baby will regurgitate all its feeds. Then there is continuous drooling of saliva, and there might be coughing, there might be cyanosis. If there is type E, the patient will be able to swallow normally, but there is recurrent chest infections. So how do you diagnose it? With either the help of a coiled nasogastric tube in the upper esophageal pouch, or you can do a contrast swallow. So how do you treat such patients? First, you can place a nasal or an oral sump repoggle tube. Memorize this, no need to go into details. A nasal or an oral sump repoggle tube is placed because then that will drain the saliva. If the saliva accumulates, there is a risk of aspiration. Why is there a risk of aspiration? Because see, till the pharynx, pharynx is a common channel between the pharynx is a common channel before it branches into the esophagus and the trachea, right? So there might be, if there is too much of fluid collecting in the proximal blind pouch, that might then track up, go via the pharynx into the trachea. So you have to prevent that, and that is done by a repoggle tube. Second thing, in type A and type B, there is a long gap. Therefore, it might require esophageal replacement. So you can use an esophageal replacement either with colon or jejunum or stomach. That can be used. So usually esophagogastrostomy is used most commonly, and that can be done. In type C and D, the fistula is divided. So how do you gain access to the fistula? You can either do a thoracotomy or you can do a VATS. That is a minimally invasive procedure. Now, if the neonate is stable and the gap is favorable, then you can fashion an anastomosis over a transanastomotic tube. If you place a tube, then it facilitates feeding. Type E is repaired in the neck itself. So if you're getting a question which says that a fistula which is repaired in the neck itself, the answer is type E, because if you see over here, the esophagus is in continuity. So you just need to ligate that fistula. Next, what is the most common type of hiatal hernia? Now, hiatal hernia is of 4 types. You have sliding, that is type 1, rolling, that is type 2, mixed, which is type 3, and type 4, where there is an organ also which is herniating. So I remember this by the mnemonic SRM. There is a medical college with the name SRM. So sliding, rolling, and mixed. So sliding hernia is a condition in which so this is the diagram which I wanted to show you. So in sliding hernia, what happens is the lower esophageal sphincter, that is the cardia of the stomach, it will herniate into the thoracic cavity. In type B, the fundus of the stomach herniates, but the GEJ is intact. Wait, let me rephrase this. In type A, one moment. In type A, what happens is the GEJ migrates cephalad. That is the correct way of expressing this. In type A, the gastroesophageal junction, it migrates cephalad. In type B, the junction is present in the abdomen, but the fundus of the stomach, it herniates. Type C, it contains both. And in type D, there is another organ. So here there is colon, which is present in the thorax. So among these types, sliding type or the type 1, this is the most common type. Now, hiatus hernia, it is most commonly associated with GERD, that is GRD. And type 1, so all herniations actually, they are because of a weakening in the fascia or membrane which contains the organ. So type 1 is because of laxity of the phrenoesophageal membrane. This phrenoesophageal membrane, it is derived from the endo-abdominal peritoneum. So yes, there is one more term which you should know, a giant paraesophageal hernia. A giant paraesophageal hernia means more than half of the stomach has herniated into the thoracic cavity. Now, a sliding hernia predisposes to GERD, therefore you will get reflux symptoms. Whereas a paraesophageal hernia will cause obstructive symptoms. So, you need to, how do I tell it to you? Wait. So, see, in type 1, this is a sliding hernia, right? Type 2, type 3 and type 4, in all these 3 types, 2, 3 and 4, there is some structure which is present next to the esophagus. That is why these are called paraesophageal hernias. So type 1 is not a paraesophageal hernia, type 1 is a sliding hernia. Type 2, 3 and 4 are paraesophageal hernias. So type 1 is predisposing to GERD, and type 2, 3 and 4, that is the paraesophageal hernias, they can cause obstruction. Okay. Now, if there is a giant paraesophageal hernia, that might present as a surgical emergency, because if too much of the stomach is herniated into the thorax, there might be a gastric volvulus which happens. What is the best test to diagnose GERD and quantify acid output? Now, the best test to diagnose GERD is a 24-hour pH monitoring. How do you do a 24-hour pH monitoring? 24-hour pH monitoring is done by it is done ambulatory. That means that there is no need for the patient to get admitted. A catheter is inserted into the lower end of the esophagus, just like a Ryle's tube. So that catheter, it has pressure sensors which will then measure the pH. So ambulatory 24-hour pH monitoring is the gold standard test to diagnose GERD. There is a score which is used, which is called Demister score. If the Demister score is more than 14.7, then that means the patient has GERD. Then a high resolution manometry is used. You might also have to do a high resolution manometry to exclude other disorders. Sorry, I'll take a technical break. Vinil. Vinil. Please pause it once. Okay, I'm sorry, there was a technical problem. Anyways, an ambulatory 24-hour pH monitoring is the gold standard test to diagnose GERD. There is a score which is used. This is called the D-Meester score. If the D-Meester score is more than 14.7, it means that the patient has GERD. Along with doing 24-hour pH monitoring, you will also need to do an HRM in GERD. Why do you do an HRM? Because an HRM is used to exclude other disorders. So disorders like acalcea which is a motility disorder, it might mimic with the same symptoms as GERD. So you will do an HRM to exclude those disorders. Then you will do an endoscopy. When you do an endoscopy, there is a grading system which is used, which is called the Los Angeles grading system. This Los Angeles grading system is used to grade the severity of the esophagitis which is happening. So this has 4 grades, A, B, C and D. The details are not required for your level. Just remember that C and D. If it is Los Angeles grade C and D, that means the patient is an indication for fundoplication. Then a barium esophagogram will be used, because whenever there is reflux, there might be some injury to the esophagus and the esophagus might get dilated. So now how do you treat GERD? So the treatment, medical management is, the drug of choice is always a proton pump inhibitor, that is pantoprazole, omeprazole, lansoprazole. The other drugs used are antagonists, antacids, H2 receptor antagonists such as ranitidine, prokinetics such as metoclopramide and domperidone. This is a new drug which is mentioned in the newer editions of Bailey and Love. Please memorize it. This is important. This is PCAB. PCAB stands for a potassium competitive acid blocker. This group of drugs are also used in treatment of GERD. Then other treatment modulators are tricyclic antidepressants and SSRIs. Then surgical management. The indications for surgery are, there is incomplete symptom control with medical management. If there is intolerance to drugs or unwillingness to comply with long-term medical therapy. If there is regurgitation despite medication, presence of a large hiatus hernia, complications because of GERD, and extraesophageal symptoms. Extraesophageal symptoms means, so whenever there is GERD, sometimes there might be micro aspiration of these acid contents which might go into the lungs, and it might cause idiopathic pulmonary fibrosis. It might even cause asthma. That is an extraesophageal symptom. So what surgery will you do? You can do you'll do a fundoplication. Fundoplication basically, it means fundoplication. Fundo means, it refers to the fundus of the stomach, and plicate means to reduce the diameter of something. So fundoplication, like for example in hydrocele, you'll do something called Lord's plication. So fundoplication basically means, say if this is the esophagus, you have the stomach over here. So part of the stomach is used to decrease the diameter of this. So when this diameter is decreased, it theoretically decreases the reflux of contents. So you take the fundus, you wrap it around the lower end of the esophagus, that this becomes narrowed. So it is called a fundoplication. Now fundoplication can be of various types. If it is a complete fundoplication, that means you're going to wrap the fundus 360 degrees around the esophagus. That is called Nissen's fundoplication. It can also be a partial fundoplication. That means you're going to fundoplicate it, but less than 360 degrees. So it can be either anterior or it can be posterior. Anterior door fundoplication is 180 degrees. Toupet is usually 270 degrees. Okay, the way I remember it is, door in Hindi, it means thread, and a thread can be straight. So that is how I remember it to be 180 degrees. Second thing is, in the term toupet, there is P, which is also present is in posterior. So this is how I remember that toupet is a posterior fundoplication. Now, what is the basic pathology of Barrett's esophagus? So now, what is this Barrett's esophagus? So, as there is reflux of acid from the stomach into the esophagus, see, the esophagus is usually lined by stratified squamous epithelium. This stratified squamous epithelium, naturally it is not exposed to gastric acid, right? But if there is reflux happening, that is, if there is abnormal, reflux is abnormal. So if reflux is happening, then that stratified squamous epithelium is not built to tolerate that acid. So what happens is, there is a change of that epithelium from a stratified squamous type to a type which can actually tolerate that acid. So which is the epithelium which can tolerate the acid? So acid is usually present in the stomach and the duodenum, right? So the stomach and the duodenum are lined by columnar epithelium. So whenever there is a change or a transition of the lower end of the esophagus from the squamous type to a columnar type, then that is called metaplasia, and that is seen in Barrett's esophagus. So in Barrett's esophagus, there is a metaplasia of squamous cells to columnar cells. So Barrett's esophagus is defined as proximal migration of columnar epithelium. That is, when you do an endoscopy, you will see salmon colored mucosa. Salmon is a type of fish which is slightly pinkish in color. So this is seen in the lower esophagus, which extends more than 1 centimeter above the GEJ. So pathology is long-standing acid and alkaline reflux can result in histologic change. Fine. It was earlier called intestinal metaplasia, also called Barrett's esophagus. Now, so patients who have Barrett's esophagus, that patients who have metaplasia, there is an increased risk of dysplasia. Dysplasia means disordered growth. Metaplasia means one kind of epithelium is replaced by another kind of epithelium. Dysplasia means disordered growth. So a different kind of growth is happening. And when dysplasia is present, there is an increased risk for the development of adenocarcinoma of the esophagus. So what are the investigations? When you do an endoscopy, you will see velvety red tongues of mucosa, so which extend cephalad from the GEJ. That means when you're looking at the esophagus via an endoscope, normally you will just see the esophageal mucosa, but here you can see tongues of mucosa. So you can see something like this coming. This is usually salmon pink in color, it is velvety red in color. So this is in conventional endoscopy. You can also use a high definition white light endoscopy, including narrow band imaging, because this will give you more detail about this. You can also use something called a chromoendoscopy. Now, if you want to take a biopsy from this, you can take a biopsy. The biopsy is taken via something called the Seattle protocol. So two places in USA which are associated with Barrett's, which you need to remember. One is Los Angeles, which is the classification, and one is Seattle protocol, which is a protocol for taking biopsy. Now, what is the treatment of how do you treat Barrett's? You treat the underlying GERD and you do a fundoplication. So along with that, supposing there is some epithelial change which is happening, that there is metaplasia, you need to destroy that metaplastic change or that dysplastic change. So what do? You destroy the intestinal metaplasia by photodynamic therapy, radiofrequency ablation, cryotherapy. There are also two other techniques which are called EMR and ESD, that is an endoscopic mucosal resection or an endoscopic submucosal dissection. These can also be used if the lesion is small enough. You can remove it endoscopically itself. Now, supposing if you remove it endoscopically via an EMR or an ESD and you have the tissue present, now you send that tissue for a histopathological examination, that is biopsy. If that says that the the tissue contains adenocarcinoma, which is T1B or higher, then you have to go for an esophagectomy. Okay. Next, what is Plummer-Vinson syndrome, also known as Patterson-Brown-Kelly syndrome, also known as sideropenic dysphagia. This is a very rare disorder. It has a few specific clinical features. It affects middle-aged women. There are cervical esophageal webs. So imagine that you're looking at the esophagus from a tube, okay, and you can see certain webs over here. So this, if you're looking from on top, this is a cross section esophagus. You can see webs over here. Fine. Now this web, it is usually in the post-cricoid region. This is also a MCQ point. So this will cause dysphagia. If the patient is eating slightly bigger particles of food, then that can get stuck over there. It can cause dysphagia. Second thing is this esophageal web, it is both the proximal as well as the distal surface of the web are lined by squamous mucosa. Then this predisposes to cervical esophageal cancer. So along with cervical esophageal webs, you will also get iron deficiency anemia. Because of anemia, you will get koilonychia, that is spoon-shaped nails. You will also get angular cheilitis or stomatitis. How you treat such patients? You will give iron therapy, you will modify the diet, and you can also use endoscopic dilatation of the cervical web. Okay. Now, what is the treatment of achalasia cardia? So acalcardia is a motility disorder, and it is a hypomotility disorder. It is the most common motility disorder of the esophagus. It is also the most common hypo, that is HYPO, most common hypomotility disorder of the esophagus. So what is the treatment of acalcardia? Now, okay, so what is acalcardia first of all? Basically, in acalcardia, there is a failure of the lower esophageal sphincter to relax. So normally when you eat, when you swallow, an impulse is sent to the lower esophageal sphincter, which relaxes in anticipation of food coming down. But in acalcardia, what happens is the lower end of esophageal sphincter, it fails to relax. So that is called acalcardia. Now, the treatment of acalcardia, it is symptom palliation only, right? Because it is due to an underlying neuronal degeneration, and there is no drug which can reverse the neuronal degeneration. So your idea is to palliate the symptoms such that the patient does not have dysphagia. So usually what is done is all treatment modalities, they aim at the lower esophageal sphincter. So since it is not relaxing, they destroy it. Once they destroy the muscles of the lower esophageal sphincter, there is passage of food which is easy. So how do you do it? So you can use drugs, but they have a limited role. These drugs are calcium channel blockers and nitrates. It is usually given, say, half an hour or 45 minutes before food. Once the patient swallows the tablet, the LES relaxes. It gives temporary symptomatic relief. So drugs are, it does not work that well, but if a patient cannot undergo a surgery, you have to give some treatment. So in those patients, you will give drugs. Next, there is something called Botox. Now, Botox, it is a presynaptic inhibitor of acetylcholine release from nerve endings. So just like you will use Botox to remove wrinkles from the face, because it is destroying those, it is inhibiting those nerve endings, it is destroying those nerves in the face. Similarly, in acalcardia, it is inhibiting acetylcholine release from the nerve endings. So how do you inject this Botox? Botox is injected endoscopically into the LES. Now, it has a high failure rate. That is why you have to do repeated injections. It is indicated in elderly patients with comorbidities. Then there is pneumatic dilatation. So pneumatic dilatation, basically in Botox, you're going to inject the toxin, and that is going to destroy the nerve endings over there. But sometimes you can also use a pneumatic dilatation. Basically, you insert a balloon, you inflate the balloon. That destroys the muscle fiber. That is called pneumatic dilatation. The problem with pneumatic dilatation is it has a high risk of perforation. Next, you can do something called a Heller's myotomy. So a Heller's myotomy is basically, it is an either open surgery or a laparoscopic surgery. So what you do is, you cut the muscles, that is, after you make a laparotomy, you will make an incision in the lower end of the esophagus and in the gastric cardia, right? So when you make an incision, you are also cutting the muscle fibers. So once you cut the muscle fibers, it relaxes. So usually you will do an anterior myotomy, because logically, I mean, obviously when you're going to open the abdomen, it is easier to make an incision on the surface that you're able to see. Since you can see the anterior surface, you will be doing an anterior myotomy. Now, what happens is, after you do a myotomy, there is a high chance of GERD. So you combine the myotomy with a fundoplication. Now there's a new treatment, not new, it is 10-15 years old, that is called POEM. POEM is per oral endoscopic myotomy. Actually, for almost all esophageal diseases, I mean, these cases are now being done by medical gastro guys and not by surgeons, because they have become very good at endoscopy. Even there has been a lot of developments in the endoscopic technique. So what is POEM? In POEM, what happens is, you create a long, so in Heller's myotomy, you're creating an opening in the esophagus from outside, right? In endoscopy, you're inside the lumen of the esophagus. So when you're inside you make an incision over there. So you make an incision in the, so it is per oral endoscopic. So you insert the endoscope per orally. It is going to go into the intended area, wherever you want to make the incision. You make an incision in the mucosa. Then you will divide the circular muscle. So there are two muscle coats, right? Outer longitudinal, inner circular. Your idea is to divide the circular muscles. So the circular muscles are divided. Once the circular muscles are divided, then whatever incision you've made, you close that incision with clips. And esophagectomy. Esophagectomy is done when the patient has sigmoid or mega eso. That is, the esophagus has become very big and that is not responding to other methods. In such patients, you will do an esophagectomy. Okay, moving ahead. What is the most characteristic feature of congenital hypertrophic pyloric stenosis? So CHPS, it is more common in males. Then the pyloric tumor, so this is not seen. The pyloric tumor is best felt during feeding. Yes. So the pylorus is the distal end of the stomach, and there is a hypertrophy. So basically you can palpate it. It feels like an olive. That's why they refer to it as the olive. So you can best palpate the olive in the child because the child's abdominal wall muscle is also very, very thin. Now, the best time to palpate that olive, that is when the child will allow you to palpate, is during feeding. So, so this is the most common characteristic feature, that is the pyloric tumor is best felt during feeding. The patient is commonly marasmic. No, this is not a characteristic feature. Loss of appetite occurs early? No. This is also wrong. So what happens is, infants, when they feed, because there is an obstruction in the pylorus, they vomit that. But in between feeds, they're very, very hungry. So loss of appetite is not seen. So even though it is called congenital hypertrophic pyloric stenosis, it usually affects infants between the age of 2 to 6 weeks. It is more common in boys. Firstborn male infants are at a higher risk. Hypertrophy of circular muscles. So if it is asked in the exam whether it is which muscle layer, it is the circular muscle layer. So because of the circular muscle layer, because of hypertrophy, it causes obstruction of the gastric outlet. This will cause a non-bilious projectile vomiting because the obstruction is proximal to the opening of the CBD, right? That is why. And there is a family history. So immediately after vomiting, the baby is often very hungry. These are, so the patient, there is failure to thrive. Failure to thrive is a better word and not. So if you look at the options over here in the question, marasmic is due to, marasmic is a protein energy malnutrition disease. So instead of, the patient will obviously have failure to thrive, but this option is incorrect. The proper words would have been failure to thrive. Examination findings I've already discussed. So what metabolic abnormalities you will see? Now, because the gastric acid is being vomited out, right? And that it contains hydrogen and chlorine. So there is hypokalemia. You just memorize this. There is no need to go into the logic behind it. It will take a long time. And there is no way that it will be asked the logic of it in the exam. So it is a hypokalemic, hypochloremic, metabolic alkalosis. So because acid is being lost, it is compensated for by a metabolic alkalosis. Now, even though there is metabolic alkalosis, there is acid which is being secreted in the urine. That is why it is called paradoxical aciduria. Now, how do you investigate such patients? Obviously, in a small child, you cannot do an endoscopy, so you will do an USG. When you do a USG, you will see the pyloric muscle thickness, which is more than 3 to 4 mm, and the length of the pylorus is more than 15 to 18 mm. So when these patients come to you, like all intestinal obstruction patients, when these patients come to you, you first correct the metabolic and electrolyte abnormalities. You will give 0.9% NS with 0.15% KCl in 5% dextrose, which is given at 6 to 7.5 ml per kg per hour. And if you want to do a surgery, you will do a Ramsted's pyloromyotomy. So AKL's cardio, you will be doing a Heller's cardiomyotomy. In hypertrophic pyloric stenosis, you will be doing a Ramsted's pyloromyotomy. Now, double bubble appearance on ultrasound is seen in duodenal atresia. So what happens is, so usually this is the stomach, esophagus, stomach, this is the duodenum. So usually when you take an X-ray, normally you will see there's an air bubble over here, that is the gastric air bubble, and you might see up to 3 to 5 airflow levels in the intestine. So sometimes you will see a bubble over here and you will see a bubble in the duodenum. That is called duodenal atresia. So because there is an atresia of the duodenum over here, proximally there is a dilatation, right? So double bubble appearance is seen in duodenal atresia. Single bubble is seen in CHPS, double bubble in duodenal, and triple bubble in jejunal atresia. Now, what is the treatment of this duodenal atresia? Treatment is a open chimera, however you pronounce it, duodenostomy. So you make a connection between any two parts of the duodenum, and the anastomosis that you make, it bypasses the atresia segment. So yes, I have a diagram. So basically, so you make an opening in the proximal part, you make an opening in the distal part, and you get a diamond shaped anastomosis. So this is called chimera duodenostomy. So you can see two bubbles over here. You can see the gastric bubble and you can see the duodenal bubble. What is the most important blood supply to the stomach? Now the stomach gets the most common bloods, the main blood supply or the most important blood supply is from the left gastric artery. So I have mentioned the details of the blood supply in detail, but for our discussion sake, if question comes in the exam, the answer will be left gastric artery. So there are four main arteries: left gastric, right gastroepiploic, and the left gastroepiploic. But among these, the main artery is the left gastric artery. Okay. So a patient of peptic ulcer disease, when investigated endoscopically, he showed chronic antral gastritis. Which of the following dye will be able to stain the specimen? So chronic antral gastritis is due to H. pylori, and the stain which is used for H. pylori is your Warden starry stain, also a silver stain. So most cases of chronic gastritis are of two types. One is type A for autoimmune, type B for bacteria. So the type B is associated with H. pylori. It typically affects the antrum. Type A, on the other hand, it involves the body and the fundus. Type A is also associated with pernicious anemia. So this patient has a chronic antral gastritis, that is, it is bacteria, so it is type B. So we'll use a stain for H. pylori, that is either a Warden starry stain or a GMSA stain or a Genta silver stain. The conditions associated with H. pylori are chronic gastritis, that is type B, peptic ulcer disease, gastric cancer, that is gastric adenocarcinoma, gastric malt lymphoma, MALD stands for mucosa associated lymphoid tissue, or also a gastric diffuse large B cell lymphoma. Now, how else do you diagnose H. pylori? Now, if you want to stain the bacteria with stain, that means you require a biopsy specimen, right? The biopsy specimen is taken only via an endoscopy. That is an invasive test. So they came up with certain other test, which is called a, you use an isotope of carbon. So you'll use carbon 13 or carbon 14 breath tests. Basically, you blow into that instrument, and that will detect the presence of carbon 13 and carbon 14. Actually, you have to inhale it, you have to again exhale it. Now, there is another test for H. pylori, which is a rapid urease test, which you will see in these endoscopy reports. They abbreviate as RUT. So RUT is performed on gastric biopsies, which are taken so this is an invasive procedure. Culture media can be used. The culture media which is typically used is called a Skirrow medium, SKIRROW. Then previous or current infections with the organism may also be detected serologically. You can measure the antibodies. You can also do fecal antigen tests. Now, what are these nerves of Latarjet and where is nerve of Latarjet spared? So the nerve of Latarjet is spared in a highly selective vagotomy. So let us look at duodenal ulcer. Now, the surgical treatment of duodenal ulcer, your goal is because acid is causing damage in the duodenum, your idea is to exclude acid from the duodenum. That is, you do not want acid to enter the duodenum anymore. So how do you do this? You do it by two ways. One is you divert the acid away from the duodenum. So you will have to form a connection between the stomach and the jejunum. That is one way. Second thing is you want to reduce the secretory potential of the stomach. So how do you reduce the secretory potential? So for the stomach to secrete acid, it needs to it is dependent on the parasympathetic blood supply from the parasympathetic nerve supply, from the vagus nerve. So if you make a transaction in the vagus nerve or its branches, it is called a vagotomy. So what are those? Gastrectomy based procedures. That is, how do you divert the acid? So gastrectomy can be done either in the form of a Billroth 1 or a Billroth 2 gastrectomy. So in this, what happens is the lower half of the stomach is removed, and whatever is the cut into the stomach is remaining, that is anastomosed to the first part of the duodenum. All right. A Billroth 2 or a gastrectomy, in this 2/3 of the, so in Billroth 2 you're going to remove more part of the stomach and stomach. So the main difference is, in Billroth 1 you're going to anastomose the stomach to the duodenum, right? But in Billroth 2 you are going to let the duodenum stay, and that duodenum, see, after you make a transaction, the duodenum the stump remains, and you close that stump. So 2/3 of the stomach is removed. More stomach is removed in Billroth 2 than Billroth 1. The stump is closed, and whatever remnant of the stomach is remaining, that is anastomosed to the jejunum. So once you do a GJ, this will divert the gastric secretion away from the duodenum. Also, when you remove the gastric antrum is responsible both directly and indirectly for gastric acid secretion. So when you remove the antrum, the gastric acid secretion automatically reduces. Now, there is no elective role for these procedures in the treatment of duodenal ulcer, but the Polya procedure is occasionally needed in the management of complex ulcer disease which presents as an emergency. Actually, the use of all these surgeries has decreased considerably because that is PPI is so effective. Then you can also do a vagotomy. So now, what is a vagotomy? Vagotomy basically means you section, that is, you cut the vagus nerve, because if you do that, it decreases the acid output. Now, supposing if you only section the vagus nerve, it reduces the peak acid output by 50%. But if you do a vagotomy plus an antrectomy, that will decrease the peak acid output by 85%. So let us look at the types of vagotomy. So now the vagus is not only giving parasympathetic supply to the stomach for secreting the HCl, it is also helping in the mobility of the stomach, right, for peristalsis. So supposing if you do a vagotomy, then there is a chance of the content of the stomach staying. So that is, there is a chance of gastric stasis. So whenever you do a vagotomy, you have to combine it with a drainage procedure, because that drainage procedure, it allows the evacuation of contents from the stomach to distally. So truncal vagotomy, as the name suggests, you are going to be sectioning the trunk of the vagus. So either you divide the left and the right vagus nerves above the hepatic and celiac branches. This is just above the GEJ. Okay, and you will combine it with some form of drainage procedure to avoid gastric stasis. This is because pyloric relaxation is mediated by vagal stimulation, and a vagotomy without a drainage procedure can cause delayed gastric emptying. So you can use some form of drainage procedure, like for example, you can use a Heineck Mikulicz pyloroplasty. Supposing if the duodenal bulb is scarred because of ulcer and fibrosis and healing, you will use a Finney pyloroplasty, or you can also use a Jabouret gastroduodenostomy. But if there is too much scarring, which is not allowing you to make anastomosis between the stomach and the duodenum, you might have to do a GJ. And PV can be combined with an antrectomy. So what is a selective vagotomy? Selective vagotomy, it divides the main right and left vagus nerves just distal to the celiac and hepatic branches. This is key. So if you go back to truncal vagotomy, in truncal vagotomy, after it, it is divided above the, supposing say this is the vagus nerve, hepatic branch, vagus nerve, celiac branch. So here you are making the division above it, right? But in selective vagotomy, you're going to make the division below it. So let it give the celiac and hepatic branch, and then you, so that is why it is called a selective vagotomy. A highly selective vagotomy, on the other hand, is you will want to transect only those vagus nerves which supply the acid producing portion of the stomach within the corpus, that is the body and the fundus. Okay, this is also called parietal cell vagotomy or proximal gastric vagotomy. Now, along with this, you will be doing a GJ, because GJ is a drainage procedure and it is an alternative procedure to pyloroplasty. So when you do a GJ, it is usually a posterior GJ is done. You will usually do a posterior GJ. Posterior GJ means the jejunum is anastomosed to the posterior part of the stomach and to the most dependent wall of the stomach. So this is a diagram of Billroth 1 gastrectomy. You're going to remove the distal two-thirds of this, half of the stomach, and the lower half of the stomach is then, after you remove half of the stomach, you will anastomose the stomach to the first part of the duodenum. That is what is happening. This is the first part of the duodenum. This is the stomach. So in Billroth 2, you're going to remove two-thirds of the stomach, and the duodenum is over here. This is actually closed. The duodenal stump is closed. And the stomach is then anastomosed to the jejunum. So you'll be doing a GJ. Next here is again the jejunum is being anastomosed to the posterior part of the stomach. So for that you have to make an opening. Okay, that is not required for your level actually. Just remember that it is a posterior GJ which is being done. Then what is dumping syndrome? And so we'll look at dumping syndrome, then we'll come to this question. Now there are two kinds of dumping syndrome. One is early dumping syndrome and the other is late dumping syndrome. Fine. So what happens is in early dumping syndrome, it happens almost immediately after meals, whereas late dumping syndrome happens around a few hours after meals. So what is the duration of the attack? Okay, basically what is this dumping syndrome? So there is something called gastric emptying time, right? That means the food has to be present in the stomach for certain duration. Some part of digestion happens in the stomach, and only then the food proceeds to the intestine. Now, if the food is going directly from the stomach to the intestine, then the stomach is basically dumping all its contents into the intestine. That is why it is called dumping syndrome. So what is this dumping syndrome and when does it occur? So it occurs usually early. It is called because it is occurring almost immediately after a meal. Late it is occurring 1 or 2 hours after meals. The duration of attack is the same in both. It is 30 to 40 minutes. So in early dumping syndrome, what happens is so once the food enters into the stomach, that food is hyperosmolar, right? So what it does is it starts to attract since it is hyperosmolar, there is movement of fluid from the blood vessels into the lumen of the bowel. Because there is movement of fluid from the blood vessels into the lumen of the bowel, so the patient will complain of epigastric fullness. There will be sweating, there will be lightheadedness, there will be tachycardia, there will be colic, and even sometimes diarrhea. So this is usually seen in, the food should be carbohydrate rich and it should be wet food. And late dumping syndrome is precipitate. It is so. How do you treat this? Early dumping syndrome? So whenever there is hyperosmolar content in the intestine and the patient is feeling lightheaded, you tell the patient to lie down. Once the patient lies down, the contents again get reabsorbed slowly and the patient feels better. Late dumping syndrome, what happens is the food, the glucose is absorbed it is absorbed from the food. Once the glucose is absorbed, we will have to take a technical break. One moment. So sorry for the interruption. So we were discussing early and late dumping. Now the basic difference between early and late dumping is this. So now supposing a patient after a pylori through gastrectomy is eating food. So in early dumping, what happens is the food is dumped from the stomach into the intestine. If that food is rich in, if it is hyperosmolar, it will draw all the fluid from the blood vessels. So the patient feels lightheaded, the patient might get sweating, the patient might have diarrhea. So when you tell the patient to rest for some time, what happens is the fluid is gradually reabsorbed into the circulation and the patient feels better. Then there is something called late dumping syndrome. In late dumping syndrome, what happens is basically supposing the food is rich in carbohydrates. So as soon as, when the carbo-rich food, it enters the intestines, there is a response by the pancreas and a lot of insulin is being secreted because the glucose, the carbohydrate content, that is the glucose in the stomach, is being absorbed rapidly. So there's a lot of insulin being secreted. This causes a hypoglycemia. And because of the hypoglycemia, the patient might have tremors, he might have fainting episodes, basically hypoglycemic symptoms. And so in late dumping syndrome, if you tell the patient to eat more food, then the patient feels better. So it is relieved by eating more food. And one of the other aggravating factors is exercise. Why exercise? Because even in exercise, the glucose is being utilized, right? So already the glucose is being utilized because of hypersecretion of insulin. Second thing is, if you exercise, there is more, there is a shortage, there's going to be a shortage of glucose. So it is going to contribute to hypoglycemia. So what is the question? So which is not true about dumping syndrome? Starch is beneficial? No, obviously not. This is not true. So this is the answer. Then small frequent meals is beneficial. This is true. It is seen post gastrectomy. This is true. Clinical features include diarrhea and bloating. This is true. So why small frequent meals is beneficial is, if the patient eats smaller quantities of food, then this complication of hyperosmolar content coming or of too much of insulin being secreted, this is not going to happen. So I've given the details of dumping syndrome, but it is I've discussed a brief overview. Next, which of the following is not true regarding GIST, that is gastrointestinal stromal tumor? Now, in GIST, you need to know that GISTs are the most common mesenchymal neoplasms of the GIT. That is the first thing. Where do they arise from? So these are distinct tumors which are derived from the interstitial cells of Kajal. These interstitial cells of Kajal, they are GI pacemaker cells. All right. Now they may arise in any part of the GIT. That is, GISTs can arise in any part of the GIT, but the most common part from which it arises is the stomach. Now, what are the mutations which are involved? So the mutation which are involved almost universally is a mutation in the tyrosine kinase gene, that is the c-KIT. So c-KIT, T in this KIT stands for tyrosine, Ki stands for kinase. So mutation in the tyrosine kinase gene. This tyrosine kinase oncogene, it expresses a CD factor, that is a cluster differentiation factor, which is CD117. So along with mutation in c-KIT, you will also get a PDGFRA mutation. This PDGFRA stands for a mutation in platelet-derived growth factor receptor alpha. So they express CD117 and CD34. The prognostic factors for METs are size and mitotic index. So the size of the tumor as well as mitotic index, both are important and both predict metastasis. So now almost all tumors in the GIT, the blood supply is first to the liver, right? Therefore, liver mets is very, very common in GIST tumors, and spread to lymph nodes is extremely rare. What are the clinical features of GIST? So it occurs with same predilection in males and females. There is no gender predilection. If it is a small GIST, it remains unnoticed. But if there is a large tumor, you can get symptoms because of the size of the tumor itself. So those are early satiety, bloating, weak abdominal pain. Fine. Now next is you can also get bleeding. That is, bleeding can occur, and this bleeding is usually in the form of melena. Melena is, that is, lower GI bleeding is more common than hematemesis. Now supposing if now there is this bleeding is occurring in the lumen of the GIT. Now can bleeding occur in the that is in the peritoneum? That also can happen. That is called tumor rupture, but it is very, very uncommon. Now most patients remain asymptomatic, and the tumors are generally discovered incidentally during the time of another surgery, or maybe because of imaging, or because of endoscopy performed for other indications. So now what investigations do you do? You will do an endoscopy. When you do an endoscopy, advantage is obviously you can take a biopsy also. Now the problem with this is the overlying mucosa can be normal. So when you do an endoscopy, you may not be able to know where to take the biopsy from, right? So unless the tumor ulcerates and you're not going to take a deep enough biopsy, it will come negative. So endoscopic biopsy can be uninformative unless the tumor has ulcerated. Supposing if you want to take a targeted biopsy, if you want to specifically know that this is where the tumor is, the best way, like I told you in an earlier session, was if you use a luminal ultrasound. That is, if you use endoscopic ultrasonography. To assess METs, CT of the abdomen and pelvis is used. This is used with both oral as well as IV contrast. Now, if a patient cannot receive an IV contrast, maybe because he's allergic to the dye, maybe because the patient has deranged renal function test, patient is in acute kidney injury. So in those patients, you will have to do an MRI. MRI is also preferred in rectal cysts. Actually, in all rectal cancers, because the rectum is present in the pelvis, and because it is a inaccessible place with a lot of soft tissue, an MRI is preferred for imaging in the pelvis. You can also do a immunohistochemistry for CD117, CD34 and PDGFRA. So what is the treatment? Now the mainstay of treatment is surgical excision. So either you do a wedge excision if the tumor is small. If the tumor is large, you might have to do a gastrectomy or a duodenectomy. Now, like I told you, the cyst usually spreads to the liver. It does not spread via the lymph node. So there is no need to do a lymph node dissection. So lymphadenectomy is not required. Suppose if tumors are very large and they have affected other organs, then you might have to do a multivisceral resection. Now, what are the drugs which are used in GIST? So they are sensitive to a drug called, which is a tyrosine kinase antagonist, which is imatinib. This imatinib, you can either use it in the neoadjuvant or in the adjuvant setting. So let us go back to the question again. So tumor size is the most important prognostic factor. This is true. Arise from medullary this is also true. It is the most common mesenchymal tumor. Yes. No, it is not associated with ALK mutation. It is associated with c-KIT or PTGFRA mutations. Next, moving on to the topic of mesenteric cyst. Now in mesenteric cyst, in the PDF I have given it in some amount of detail, but you need to know it, you need to know very few important points. Now the most common presentation, the most common type of mesenteric cyst is a chylolymphatic cyst. That is the first thing. Second thing is I want you to see this image. So in a chylolymphatic cyst, as you can see, it is away from the bowel wall, right? So if you want to treat this patient, you will just have to do you will just have to excise the cyst, because there is no need to touch the bowel, because the blood supply of the cyst and the bowel is different. Now you also have an enterogenous cyst. In an enterogenous cyst, what happens is the cyst and the adjoining bowel, they get blood supply from the same vessels. So because of that, you will have to do, along with removing the cyst, you will have to do a resection anastomosis. Okay. Now the mesentery, it usually extends from the to the left of the duodenojejunal flexure towards somewhere in the right iliac fossa. Now that is the line of attachment of the mesentery, right? Now all these mesenteric cysts, they usually move at right angles. They move at right angles to this attachment of mesentery. So if this is the cyst, you can see the direction of the movement of the arrow. It is moving at right angles. This, when the cyst moves at right angles, it is called Tilloch's sign. Now, what is the commonest site from where pseudomyxoma peritonei arise? Pseudomyxoma peritonei arise most commonly from the appendix. They can also arise from the ovary, but the most common site is the appendix. So what are the pseudomyxoma peritonei? They are a rare condition where there is progressive peritoneal tumor deposits, mucinous ascites, omental caking, and ovarian involvement in females. So it is usually due to a rupture of mucinous appendiceal tumor. So when the mucinal appendiceal tumor ruptures, that is, then there is deposition of that tumor in different parts of the peritoneum. You will also get mucinous ascites. So the risk is highest with mucinous adenocarcinoma of the appendix. It can also be seen with a rupture of pseudomucinous cyst of ovary. Now, what is the pathology? The abdomen is filled with yellow jelly, and this yellow jelly, it also appears to be cysted. That is, it is encysted. It feels as though it is covered by an epithelium layer. Now, what are the clinical features? So, because the pseudomyxoma peritonei, it is because of an underlying tumor in the appendix or the ovary, you will get symptoms of that as well. So, but when it ruptures, you will get progressive and massive abdominal distension because of the mucinous ascites. You will get symptoms of bowel dysfunction, and it is usually fatal. So, how do you diagnose such patients? So, because the colonoscopy is, because the appendix is the most common structure which is involved, you will usually do a full-length colonoscopy. One more idea of doing a full-length colonoscopy is, because these symptoms are similar to a colorectal cancer, you want to exclude a colorectal cancer. Next, you can do something called a diagnostic laparoscopy. So what is the idea of doing a diagnostic laparoscopy is, you can see where all the mucinous ascites is, you can see where all the deposits are, you can see wherever there is mental caking. Also, supposing if you decide that the tumor is inoperable, that is, you do a diagnostic laparoscopy and you feel that there is no point in opening the abdomen completely, you can just take a piece of tissue for biopsy, which will allow for later chemotherapy, and then you can give the patient adjuvant chemotherapy. Now, ideally, a diagnostic laparoscopy, it should be performed at a center where cytoreductive surgery can be undertaken. This is because, see, cytoreductive surgery is a huge surgery. A lot of organs are removed in cytoreductive surgery. So, not all surgeons, not all centers are well equipped to handle this. So, that is why you usually refer the patient to a specialist center. Now, there is something else which you should know, which is called HIPEC. So, HIPEC means hyperthermic intraperitoneal chemotherapy. So HIPEC is usually combined with cytoreductive surgery, and this is the treatment of choice. So what you do in a cytoreductive surgery is, you do a laparotomy, you resect whatever you want to do. It takes a lot of time. It can take up to 10 hours. And after you resect all that, what you will do is, you will then instill a fluid into the peritoneal cavity. That fluid, it is hyperthermic. I mean, the temperature is higher than the body temperature, and that fluid, it contains chemotherapy. So once you instill that chemotherapy, that is called HIPEC, and that HIPEC along with CRS is the treatment of choice of pseudomyxoma peritonei. Now, you can also use systemic chemotherapy. So, systemic chemotherapy is indicated in patients with high-grade or invasive unresectable disease, obviously, and you can also use it in adjuvant chemotherapy. Okay. A post-op patient presents with peritonitis and massive contamination because of duodenal leak. What is the management of choice? So now, when there is a leak happening from the duodenum, that is called a duodenal blowout. And duodenal blowout, it is most commonly seen. So if you remember the types of gastrectomy, there was The type 2 gastrectomy, type 1 is where we anastomose the stomach and the duodenum together, right? If that site of anastomosis leaks, or supposing say if in type 2 we are going to close the stump. So once the stump ruptures and the contents come out, then that is called duodenal blowout. And this duodenal leakage, it occurs through the stump that is left after operations for duodenal ulcer and gastric ulcer. So what is the treatment of this? So the first thing that you need to remember is that, see, these patients have already undergone a major procedure, right? So the tissues are already friable, the tissues are already inflamed. Second thing is the physiology of the patient will not permit you to do an extensive repair. So your first idea is to adequately drain it. That means whatever is coming out of the duodenum, whatever is going to be leaked, your idea is to remove all of it. So how do you remove? Because if it stays in the peritoneum, then that will cause irritation of the that contains bile and pancreatic juice, right? That is very, very irritative to the peritoneal cavity. So your idea is you want to drain those secretions as fast as possible and as much as possible. So you do this by inserting a large catheter through a subcostal incision. You make the incision, you insert the drain, and you leave it. And you apply constant suction to the drain. Now, because the duodenum is perforated and the patient cannot eat, so you have to obviously give nutrition to the patient, right? So how do you give the nutrition? Can you give a rice tube feeding? Obviously no, because the GIT is compromised. So in these patients, you will be giving total parenteral nutrition. So total parenteral nutrition, it is usually given for 2 to 3 weeks. Because in 2 to 3 weeks, that fistula, it either heals or it decreases to such an extent that you can do a second surgery. So coming back to the question, a post-op patient presents with peritonitis and massive contamination because of duodenal leak. That is, there is a duodenal blowout. What is the management of choice? 4-quadrant peritoneal lavage, it will not really help you because it is not going to, lavage is just for one time, but you want the contents to come out continuously. Then duodenostomy, feeding jejunostomy, peritoneal lavage, no, because the patient will not be able to withstand such a massive procedure. TPN is the treatment of choice. DJ again will not be used because the patient does not have the physiological reserve permitting him to undergo a major procedure. Okay. Which of the following statements is incorrect regarding Meckel's diverticulum? Now the Meckel's diverticulum, a few important points. It is a true diverticulum. So say if this is the intestine, here you have the mesentery. So here you have the mesentery. Right. So sometimes what happens is in the anti-mesenteric border, there is an outpouching of bowel wall. This is called a diverticulum, and it is called a Meckel's diverticulum if there is the rule of 2. So what is this rule of 2? It is present in 2% of the population. It is 2 inches long. The location is 2 feet proximal to the ileocecal valve, and it usually contains 2 types of mucosa. So it can contain either gastric mucosa or pancreatic mucosa. Now, because supposing it contains gastric mucosa, it is going to secrete HCl, right? This HCl will then act on the adjacent mucosa that will perforate because that is not equipped to handle gastric acid, right? And then there will be a perforation over there. Fine. So let us look at the question. So which is not correct, which is incorrect. So found on the anti-mesenteric border, this is true. Consists of mucosa without a muscle coat, this is false. See, a Meckel's diverticulum is a true diverticulum. True diverticulum means it contains all the it contains all the coats of the normal bowel. So it contains mucosa, submucosa, muscularis, as well as a serosa. So heterotopic gastric mucosa can ulcerate and cause a brisk GI bleed. This is true. A fibrous band between the apex and umbilicus can cause intestinal obstruction. This is also true. So whenever there is a Meckel's diverticulum, the tip of the diverticulum, right? So this tip over here, there can be some connection between this tip to maybe the umbilicus or maybe the anterabdominal wall or maybe even the lateral abdominal wall. So I myself have operated a case where the tip of the Meckel's diverticulum, it was attached to the lateral abdominal wall. So there was a gap. So there was a gap somewhere over here, and the remaining bowel had herniated. There was an internal herniation, and that hernia loop had become gangrenous. Okay. So we'll take a technical break here, and after break we'll continue. So let us continue. A child swallowed a watch battery containing alkaline content. What do you do next? So now whenever a child swallows something, any foreign body, you need to know whether it can pass through the bowel spontaneously or not. Supposing if there is a chance of the foreign body passing spontaneously, then you need to wait for the foreign body to pass. Supposing if the foreign body is big, and if it will not pass through the intestine, that is when you have to do an intervention. That intervention might be in the form of an endoscopy, it might be in the form of a laparotomy. Now, there are a few general rules. So whenever a child swallows a foreign body, there are two places where it can get lodged. Now, there are two valves in the GIT. One is in the pyloric valve, so it can get stuck just proximal to the stomach. Second thing is it can get stuck somewhere near the ileocecal valve, because there's one more valve over there. Second reason of it getting stuck over there is that the peristaltic movements are kind of weak in the ileocecal valve. So now if the foreign body has crossed the ileocecal valve, then that means it will usually pass off spontaneously. So before doing an intervention, our goal in any foreign body is to watch for the progress of the foreign body, right? That is the first thing. But sometimes there are a few foreign bodies which are special, because the foreign body itself, see, there are two ways in which a foreign body can cause damage. One is via the mechanical effect, and the second thing is the foreign body itself is dangerous, that it causes some problems. So now, in this question, a child swallowed a watch battery containing alkaline content. What do you do next? So now an alkaline battery is one such foreign body where, apart from the mechanical damage, it can also cause damage because of the foreign body itself, right? So if it contains alkaline content, that alkali might leak out from the body, from the battery. If it leaks, that will cause damage. So what do you do in this patient? Immediate X-ray measurement, that is obviously required, because you want to know where the battery is. Remove surgically immediately. Yes, you can. I mean, this is a valid option, but here when you are given two options, that is immediate X-ray measurements and remove surgically immediately, you will want to know the position of the battery, right? Supposing, say, if the battery is still in the stomach, there is no point of doing a laparotomy where you can do an endoscopy. So here the answer will be an immediate X-ray measurement. You will not do a surgery immediately. Will you do a CT abdomen? No, there is no role for a CT abdomen. There is no role for laxatives either. So how do you manage the injection of alkaline batteries? So first, you localize the battery. Localization of battery is done via immediate X-rays to make sure the battery is not stuck in the esophagus or the stomach, because in that case you just do an endoscopy and you can remove it. Now, most swallowed batteries that pass through the esophagus will pass in the stool without complication, right? But supposing if a battery gets stuck in the esophagus, it can cause injury or perforation esophagus very quickly. So batteries should be located with prompt imaging investigations. Supposing if it is lodged in the esophagus, button batteries that are lodged in the esophagus should be emergently removed with direct endoscopy. If it is distal to the esophagus, then what do you do? Supposing if it is distal to the esophagus, it usually passes uneventfully. So what you do is, you repeat the radiograph 4 days after injection in a child under 6 years of age. So why do you repeat this radiograph? Is because you want to know how the battery is passing or not. Supposing, say, if the diameter of the battery is small, then it can easily pass. If the diameter is big, then it may not pass. So that is why you want to take serial radiographs. What are the signs of GI injury? Signs of GI injury are hematochezia, melena, or acute abdomen. Now, supposing, say, the battery is big and the battery is stuck, then it is problematic, because if it is big and stuck and the battery starts to leak out its alkaline contents, it can cause more problems. So in that scenario, you will want to do a immediate surgery. So arrested transit of a large diameter of more than 15 mm in the stomach or intestines for more than 4 days, or injection of a magnet along with it, that is also an indication for endoscopic or a surgical removal. Fine. Now all are associated with non-healing of a fistula, except here it refers to an enterocutaneous fistula. So an enterocutaneous fistula, why does it happen? Supposing you've done a laparotomy, you've done an anastomosis, but the anastomosis does not heal, right? So there is some leak of contents from the bowel, and that bowel wall contents, it tries to come out of the abdomen wall. So if it comes out of the abdomen, it is, in a way, it is good because it is not causing peritonitis, right? Now, so when there's an enterocutaneous fistula, usually the fistula might heal on its own. Sometimes it does not heal. So what are those factors which will cause non-healing of the fistula? So one is high output. If it is more than 500 ml per day, it is considered to be a high output fistula, and this will not heal on its own. If there is severe disruption of intestinal continuity, that is, it is more than 50% of the bowel circumference. The patient has an active inflammatory bowel disease, cancer, radiation enteritis, distal obstruction, undrained abscess cavity, foreign body in the fistular tract, epithelialization of the fistular tract, and fistular tract less than 2.5 centimeters. Now so these are all factors which will impair fistula healing. Now, you will notice that here I have told it is high output is more than 500 ml per day. Even the bowel circumference, if it is more than 50%, then that will cause problems. But for fistular tract, it says less than 2.5 centimeters. So please be careful. Here is a area where you can go wrong. Now, how do you remember it in the exam? Now, supposing, see, if the fistular tract is small, right, then there is not enough space for it to heal. But if it is long, it can heal better. At least a part of the fistula can get occluded in a better manner. That is why. So let us look at the question again. Contained abscess, yes, it does not. It is non-healing. Distal obstruction, yes, non-healing. Non-epithelialization, no. Non-epithelialization is actually good. Once the epithelial tract matures, once it epithelializes, that means it is matured. Once it has matured, it is difficult to heal it. Now, what is the definition of a fistula and a sinus? An ulcer, as all of you know, it is a break in the continuity of the epithelial tissue. Now, a blind ending tract is called a sinus. A fistula, on the other hand, is a communication between two epithelial lined surfaces. So there is one epithelial surface over here, there is another epithelial surface over here. Fistula is a tract which communicates, which connects these two surfaces. So obviously, if this tract, if this also epithelializes, that means it is a sign that it has matured. It is not going to heal easily. Fine. Next question. Hyperextension of hip producing pain in acute appendicitis is due to which muscle? It is due to psoas major. Let us look at some of the signs in acute appendicitis. So usually you will get muscle guarding over McBurney's point. What is McBurney's point? So if this is the abdomen, this is the umbilicus, this is the ASIS, that is the anterior superior iliac spine. If you draw a line and there is a junction of the medial 2/3 and lateral 1/3, if there is a junction over here, this junction is called the McBurney's point. So all incisions of appendicectomy, whether it is a gridiron incision or your Lanz incision, it centers at the McBurney's point. So muscle guarding over the McBurney's point, that is at the junction of lateral 1/3 and medial 2/3 of a line joining ASIS with umbilicus. If there is muscle guarding over there, then that is called that is a sign of acute appendicitis. Next is finger pointing sign. Finger pointing sign means you ask the patient to point via a finger. You ask the patient where does it pain maximum, and the patient points a finger to that place and says that this is where it is paining maximum. The patient points to the McBurney's point. Then what is Rovsing sign? Rovsing sign is when you do deep palpation of the left iliac fossa. See, the appendix is usually present in the right iliac fossa, right? But when you do deep palpation of the left iliac fossa, there is displacement of bowels, and some of the bowel loops on the right hand side might touch the appendix on the right hand side, it might touch the parietal peritoneum, and that causes pain. That is called Rovsing sign. What is psoas sign? Psoas sign says if the inflamed appendix lies on the psoas muscle, then that psoas muscle will go into spasm and the patient will lie with the right hip flexed for pain relief. So this is what the question was. So the patient is flexing the hip for pain relief. So if you extend the hip, that means the patient is going to get pain. So when you hyperextend the hip and the patient complains of pain, that pain is due to spasm of a muscle, and that muscle is the psoas major. So what is obturator sign? If an inflamed appendix is in contact with the obturator internus, flexion and internal rotation of hip will cause pain in the hypogastrium. So if you flex the hip and you internally rotate the hip, the patient complains of pain. Pain where? Pain is in the hypogastrium. So that is called obturator sign. Next, cutaneous hyperesthesia may be demonstrable in the right iliac fossa. There is another sign called a 10-horn sign. In 10-horn sign, what happens is when you pull the testes, the patient complains of pain in the right iliac fossa. This is not that important from your NEET-PG point of view. Anyways, let us continue with the Mandible score. So now there is a score which is used for diagnosing acute appendicitis, and this score is known as the Mandible or the Alvarado score. So Mandible is the mnemonic. M for migratory right iliac fossa pain, A for anorexia, N for nausea and vomiting, T for tenderness in the right iliac fossa, R for rebound tenderness in the right iliac fossa, E for elevated temperature, that is fever, L for leukocytosis, and S for shift to left. Now, all these parameters are given a score of 1 except for two things. One is tenderness in the right iliac fossa. Second is leukocytosis. So T and L in mandrills are given a score of 2. Remaining are given a score of 1. So a total score of 10 is achieved. How do you interpret this Alvarado score? If the score is 9 or 10, it is very probable that the patient has acute appendicitis. If it is 7 to 8, then appendicitis is quite probable. If it is 5 to 6, it means it is equivocal. If it is up to 4, it is normal. So what this means is, if the patient has a score of 9 or 10, you can take the patient to OT and you can operate. If the patient has a score of 7 to 8, then you might want to do an imaging investigation to confirm your diagnosis. Okay, we'll take a technical break here. We'll just resume. So let us continue. A 35-year-old female is receiving conservative management for an appendicular mass since 3 days. The patient now presents with tachycardia, dyspnea, and fever. What is the correct statement? So Oshner-Sharon regimen should be continued. This is wrong. Continue conservative management, wrong. Proceed to laparotomy and appendices, true. IV antibiotics, false. So now what is an appendicular mass and what is this Oshner-Sharon regimen? So sometimes after an appendicitis, a mass might form. So usually the treatment of appendicitis is you do an appendicectomy, either open or laparoscopically, right? But sometimes an appendicular mass is formed. Now whenever an appendicular mass is formed, it means it is nature's way of taking care of the infection. Now, because nature is trying to take care of the infection, the reasoning is that you should not interfere in such a patient and let nature take its course. But if the patient on Oshner-Sharon regimen, that is on conservative management, if the patient gets tachycardia, patient has increasing pain abdomen, the patient has fever, or the counts are getting, or the counts are still increasing, that is an indication for doing laparotomy. So in this patient, the patient has been receiving conservative management for 3 days, but the patient still has tachycardia, dyspnea, fever. So this is an indication for doing a laparotomy and an appendicectomy. So what are the components of this Oshner-Sharon regimen? First thing is, so when you go to palpate the abdomen, yes, I have place over here. So when you palpate the abdomen, supposing you feel a mass over here, right? So what you do is you mark the circumference of the mass with a pencil and you keep palpating regularly. If the mass is increasing in size, that means that the conservative management is not working. If the mass is decreasing in size, that is good. So the components are, one is the limits of the mass should be marked with a skin marker. Second, the temperature and the pulse rate should be recorded every 4th hourly. So every 4 hours, you record the temperature and the pulse rate, because then that will give you an indication whether there is tachycardia or not, whether the patient has fever or not. You give IV antibiotics and you keep the patient NPO and you maintain an input and output chart. So now what is the criteria for stopping conservative treatment? It is criteria for stopping conservative treatment are rising pulse rate, an increasing or a spreading abdominal pain, and an increasing size of the mass. So in this patient, the patient had tachycardia, so the pulse rate was increasing. That is why you will want to stop the conservative management and do a laparotomy. Also, supposing if you do a counts and the counts keep increasing, that also is an indication for doing laparotomy. Okay, next. A 25-year-old patient presented with mass in the right iliac fossa, which after laparotomy was found to be a carcinoid of 2.5 centimeters in diameter. What will be the next step in management? Okay, so for a carcinoid tumor, you need to know two things. What is the treatment of carcinoid tumor, and second is what is carcinoid syndrome. Both are very interesting. Okay, so first, what is carcinoid tumor? Carcinoid tumor is also known as appendiceal neuroendocrine neoplasms, that is ANNs, or neuroendocrine tumors. They are the most common primary tumors of the appendix. They occur throughout the GIT, most commonly in the appendix, ileum, and rectum, in decreasing order of frequency. So the most common site in the GIT is in the appendix. Now, the most common site of carcinoid tumor, it is in the so it is GIT more than bronchus. Okay, that is, if you take the entire GIT together, it is more common in the GIT than in the bronchus. Now, supposing if you split the GIT and if you look at each part specifically, then bronchus becomes more common. So bronchus is more common than the appendix. Appendix is the most common site in the GIT. Now, what is the cells of origin? These carcinoid tumors, they arise from subepithelial neuroendocrine cells of appendix in the bowel. It arises from the Kulczycki scales at the base of the crypts of Lieberkühn. So remember these two names, Kulczycki scales and crypts of Lieberkühn. So these are usually small, well circumscribed lesions. They are usually present in the tip of the appendix. If you do an IHC, it will show you synaptophysin and chromogranin A. So now these can either be benign or malignant, and now whether it is going to behave in a malignant manner or not, that depends on the size. So size is the best predictor not only of malignant behavior but also of metastatic potential. That is why in this question, when you look at it, they told you the size of the carcinoid tumor. Okay. So now what is the treatment? If the size is less than 1 centimeter, you will just do an appendicectomy with excision of the mesoappendix. If it is 1 to 2 centimeter, you will next want to do a proliferative index, that is the Ki67 index. If this Ki67 index is low, that is if it is less than 30%, then you will just do an appendicectomy and excise the mesoappendix. Now supposing if the Ki67 index is high, if it is more than 30%, then you will do a right hemicolectomy. So for a lesion of less than up to 1 centimeter, just appendicectomy with excision of mesoappendix. 1 to 2 centimeters, you will then want to look at the proliferative index. If it is more than 2 centimeters, then you will do a right hemicolectomy. In our question, the patient had a tumor size of 2.5 centimeters. So you will do a right hemicolectomy and you will do a regional lymphadenectomy. Now, what is this carcinoid syndrome? So carcinoid syndrome is seen with tumors of the midgut and patients who have liver mets. So now what happens is, usually these carcinoid tumors, they secrete certain substances such as serotonin. This substance such as serotonin, along with it also secretes histamine, bradykinin, neuropeptides, prostaglandins. These substances usually, they enter the circulation from the appendix, they go into the liver and they are metabolized in the liver, they do not cause any harm. But supposing if there are liver mets, then if those mets secrete these peptides, that is vasoactive peptides and serotonin, it bypasses the hepatic metabolism. So then that enters the systemic circulation and then you will get certain changes in the body. That is called carcinoid syndrome. So it is because of excessive serotonin seen in tumors of small intestine with liver mets, in the presence of liver mets. Okay. Other vasoactive peptides are histamine, prostaglandins and kallikrein. So what are the clinical features of this carcinoid syndrome? You will get sweating, flushing, which is characteristically induced by alcohol. Another disease where the symptoms are induced by alcohol is Hodgkin's lymphoma. You will also get reddish blue cyanosis, bronchospasm. This bronchospasm can be so severe that it can cause asthmatic attacks. There is an interesting syndrome here which is called Hedinger syndrome. Hedinger syndrome is restrictive cardiomyopathy secondary to fibrotic right heart valvular disease. So in the right heart, you have the tricuspid and the pulmonary valves. If there is a disease of those valves, maybe there is a pulmonary or tricuspid stenosis or tricuspid regurgitation. So that might cause restrictive cardiomyopathy. That is called Hedinger syndrome. This is typically seen in carcinoid syndrome. You might also get diarrhea and borborygmi. Now, what is not true about Hirschsprung's disease? So Hirschsprung disease, it is not an autosomal dominant disorder. Hirschsprung disease basically means, now there are the layers of the intestine are, you have mucosa, submucosa, muscularis propria, which has outer longitudinal, inner circular and serosa. Now there are two nerve plexuses, all right. One is the submucosal plexus of Meissner and one you have myenteric plexus, right. Now in Hirschsprung disease, what happens is these nerve plexuses, that is in the submucosa and in the muscularis propria, these plexuses, they are not formed completely. That is, there are absent ganglionic cells. So because of this, there is a problem in the peristalsis and the patients complain of constipation. These ganglions can be absent in both the plexuses, in the Meissner submucosal plexus or even in the myenteric plexus. So the investigation of choice is you do a rectal biopsy. The rectal biopsy is usually diagnostic. So what is the etiology? So it is not autosomal dominant, but it has a family history. It is associated with Down syndrome, and there are a few genes which are associated with it. These genes are RET, EDNRB and EDN3 gene. So now what is the pathogenesis? So usually there is migration of neural crest derived intestinal neurosis affected. That is, the neurons do not migrate from the neural crest into the intestine. That is called neurocrestopathy. So because of neurocrestopathy, what happens is there is aganglionosis. Because of aganglionosis, the nerve trunks become thickened. So where does this aganglionosis extend from? So the most common is from the anus to the sigmoid colon. That means from the anus to the sigmoid colon, there is no ganglion cells, or there is very few ganglion cells. So there is no further movement of bowel. It can also be up to the proximal colon or the terminal ileum, but most commonly it is from the anus to the sigmoid colon. Now this aganglionic bowel, it fails to relax. Because it does not relax, there is a functional obstruction. So because of this, what happens is, so you have a transitional zone. So supposing, say, this is the zone where there is no ganglionic cells. This is the transitional zone. Okay. Here you have proximal to it, you have dilated bowel. This bowel is normal, but it is dilated. And distal to it, dilated proximal, distal to it, you have an aganglionic segment. So both the, the proximal bowel is definitely narrow. The transition zone onwards is where the problem happens. So these children, these patients, they can affect in the neonatal age group. If it is present in the neonatal age group, these patients will have delayed passage of meconium. Because of that, they might have abdominal distension and bilious vomiting. Supposing, say, if these patients present later in life, then there is usually a history of chronic history of abdominal distension along with constipation. Now, supposing if you do not treat these patients, what is the most common complication that happens which can cause death? So enterocolitis is the most common cause of death in patients with uncorrected Hirschsprung's disease. How do you investigate? You will take a rectal biopsy, which is the gold standard investigation, because biopsy is giving you proof that there is an aganglionic segment. After that, you might also do a contrast enema. This contrast enema might show you the narrow aganglionic segment. It might also show you the dilated proximal bowel. Now, the only curative treatment of Hirschsprung's disease is you have to remove the entire aganglionic segment, and whatever bowel was present proximal to it, you bring it down to the anus. So there are various definitive procedures which are used. The details are not really required. You just know the names. Names are enough. So there is Swenson, Duhamel, Sove, and transanal pull-through operations. Okay. Now, this is the definitive procedure for treating it. But initially, when the patient comes to you, your idea is to establish a fecal passage. So how do you establish a fecal passage? Initially, you will try to give a rectal or a bowel washout. That is tried initially. Supposing this washout fails, then you might have to, then what you do is, you take a biopsy, you send it for frozen section, and you look at whether that contains neurons or not. So the idea of doing that is you want to come to the site where where you can see ganglionic cells, so because that is normal. So you keep sending, wherever you think is supposing, say, this is the proximal dilated bowel, all right. This is the transition zone, and this is the distal aganglionic bowel. Now, supposing if you've taken tissue from here, it might show absent, ganglion cells are absent. So you cannot do a stoma over here. You need to do a stoma proximal to it. So you use your clinical judgment and your experience to take biopsy from a place where you're certain that there are ganglionic cells, and you send that for frozen section. Supposing if that frozen section comes as negative, that means that in that frozen section specimen there are no ganglionic cells. So you have to go slightly proximal, take one more biopsy specimen and send that again for frozen section. So once you do that, and once you identify which is the ganglionic segment, you might have to do a stoma. Okay. So this is Hirschsprung's disease. So this is the first image shows a normal colon and rectum. In the second image, you can see that the portion which is shaded in red, right? That is this portion. In this portion, the ganglion cells are absent. So distal to it, the rectum is shrunken, but proximal to it, the bowel is dilated. So the colon is enlarged. This is Hirschsprung's disease. Now, when you want to give this rectal washout, what fluid do you use? The fluid of choice is normal saline. Even if a child comes to you with intersusception and you want to give if you want to do a hydrostatic reduction of the intersusception, there too the fluid of choice is normal saline. Next question. Colonic diverticulosis is best diagnosed by which modality of investigation? Now, there are two, this question, the reason they ask it is because there are two different conditions. One is diverticulosis and one is diverticulitis. Diverticulosis, the answer is barium enema, and diverticulitis, the answer is a CT scan. So what are the investigations of diverticulosis? You will do a CT scan. Now see, a CT scan, it can identify both a diverticular as well as its complications of diverticulitis. A barium enema will not tell you that diverticulitis is there. It will only tell you that there is an outpouching of the bowel wall. So CT scan will give you both pieces of information. Supposing if CT scan is not available, then you will go for barium enema. But in today's world where CT scan is easily available and if the patient can afford it, you will do a CT scan. Now, you can do a colonoscopy because a colonoscopy will also identify a diverticula. But supposing if say the patient has an acute attack of pain or something, then you will avoid a colonoscopy for at least 6 weeks because then you are scared that it might cause perforation. So, if there is diverticulitis, then the tissue over there becomes friable. It is very easily, it can get perforated. So, to allow the inflammation to subside, you need 6 weeks. Now, this 6 weeks is the same for acute appendicitis. Supposing there is a mass which is formed and you want to call the patient for an interval appendicectomy, you again need 6 weeks. Similarly, for acute calculus cholecystitis, supposing if you want to do an interval cholecystectomy, there too, you will ask the patient to come after 6 weeks. So, 6 weeks is the time which is required for an inflammation to subside. Then barium enema was used earlier, and barium enema you will see signs which are called sawtooth sign or accordion sign. So now this is the barium enema which shows the presence of diverticuli. So if you see over here, in this portion there are multiple diverticuli. Here too there is diverticuli, and here also there is diverticuli. So this is called accordion sign. So what is this accordion sign? So accordion is a musical instrument. See, this is the musical instrument, and you can see that it looks similar to an accordion, right? What is the treatment of diverticulosis? So treatment of, if there is, see, diverticulosis is usually because of chronic constipation. That is, the patient has to strain during defecation. So, not straining during defecation per se, but because there is an altered colonic motility. Because there is a problem in the colonic motility, there are outpouchings which are happening. So you need to give certain dietary modifications so that the colonic motility becomes easier. If the patient strains during defecation, then the problems will happen in the perineal region. That is, the patient will get hemorrhoids. So the treatment for this is medical. So you will give a high fiber diet, laxative. You can also give antispasmodics and bowel rest in the case of diverticulitis. That is, keep the patient NPU, bowel rest as well as IV antibiotics. Now, what surgery do you do? So surgical treatment is very rarely necessary for diverticulosis, especially if there are no complications. It usually manages with conservative treatment. But supposing, say, there is an emergency and you have to operate, then a Hartmann's procedure is the safest option in an emergency setting. That is, in an emergency for any emergency procedure, a Hartmann's stoma is the safest and the easiest procedure which you can do. Now, you can do a primary. So what is this Hartmann's procedure? So this is the ascending colon, transverse colon, descending colon, sigmoid colon, right? Supposing you have a disease over here. So the idea for you is to resect this part of the bowel. Now once you resect it, this is the proximal end and this is the distal end. So then in the emergency you are thinking, should I anastomose the proximal and the distal ends together? But the problem is, since that bowel is diseased, right, the anastomosis that you do might not heal. It might cause anastomotic leak. So in the emergency setting, what is usually done is we excise this part of the bowel, which is the diseased portion, and we create so this part is excised. And there is some amount of, so the disease segment is excised. Once the disease segment is excised, this is the distal portion. This distal portion is sutured closed. Okay. And this proximal portion, it is brought out in the form of a stoma. So this is called a Hartmann's procedure. Now sometimes you might also attempt to do a primary anastomosis. So a primary anastomosis with or without proximal diversion can be considered. So if you are doing a primary anastomosis, why do you need to do a proximal diversion? So even if you do a primary anastomosis, you are not sure whether the stoma will heal or not, whether the anastomosis will heal or not. So what you do is you create a loop stoma proximal to it. When you create a loop stoma proximal to it, the contents of the bowel come out, right? So since the contents are not going distally, it allows that site of anastomosis to heal. And elective resection might be considered for recurrent attacks or complications. Okay, I forgot to tell you one point. So supposing if you do a loop stoma and you allow the distal anastomosis to heal, so maybe after 2 weeks or after 4 weeks, when the anastomosis you are sure that it is not going to leak anymore, you can close the loop stoma. Closing a loop stoma is always easier than closing a Hartmann's stoma. Now, what is the most common site of bleeding diverticula? Now, this is a very interesting question. Now, diverticula are more common on the left, but complications of diverticula, especially bleeding, is more common on the right. So, the most common site of bleeding diverticula is the ascending colon. So, what are the complications of diverticular disease? You can have diverticulitis, that is recurrent periodic inflammation and pain. You can have perforation. This perforation can lead to generalized peritonitis. You can have intestinal obstruction because of, if there is repeated inflammation that is happening, inflammation heals with fibrosis, it leaves behind a scar that can cause progressive fibrosis, that can cause stenosis, which can cause intestinal obstruction. There might be hemorrhage and there might be a fistula formation. This fistula formation, the most common site of fistula is vesicocolic. That is, it is between the urinary bladder and the colon. Even in Crohn's disease, the most common fistula that is seen is vesicocolic. That is, it is between the urinary bladder and the sigmoid colon. So diverticula are more common on the left hand side and bleeding is more common, but bleeding is more common on the right hand side. Next, what is this Hinchey classification? Hinchey classification is used for a perforated diverticulitis. So what is this Hinchey classification? There's a very nice diagram which will illustrate the Hinchey classification. So in type 1, there is a small abscess, but that abscess is confined to the mesentery. Then in type 2, there is the abscess has become big, it might extend to the pelvis. In type 3, what happens is there is rupture of the whatever there is collection is happening in the mesentery, that ruptures. But in type 3, it contains liquid. In type 4, it contains feces. So this is the Hinchey's classification. This is given in the form of a box in Bailey and Love, and so it is important because earlier it was not. This is a trending topic basically, so I think the question might come from Hinchey's classification. So type 1 is, it is a localized abscess, it is a paracolonic abscess, it is near the colon. Type 2 is pelvic abscess. Type 3 is purulent peritonitis, there is presence of pus in the abdominal cavity. And type 4 is feculent peritonitis. Next, let us look at the colonic polyps. So which polyp has maximum malignant potential? So adenomatous polyps are the most common polyps with malignant potential. Now, adenomatous polyps again are divided into various types. So, the most common adenomatous polyps are tubular adenomas, and these tubular adenomas, the most common is pedunculated type. So, how do you divide this adenomatous polyps? It is on the basis of histology. It can be tubular, villus, or tubulovillus. Actually, tubulovillus should come as number 2. So, it is tubular, tubulovillus, and villus. Now, villus sounds like villain. So, villus polyps have the maximum chance of being malignant. Tubular polyps are usually benign. Tubular villus can go either way. So, villus polyps are the polyps which have the maximum malignant potential on the basis of histology. Now, on the basis of morphology, that means on endoscopy, how the polyp looks like. Depending on that, it can be of two types. It can be either sessile or it can be pedunculated. So, what is this sessile and pedunculated? So, now if this is, if this is the bowel, and there's a small peduncle and then there is a polyp. This is pedunculated. Whereas if it is sessile, it is usually like this. So again, sessile polyps have the maximum risk of malignancy. So coming back to our question, which polyp has maximum malignant potential? The answer is sessile. So what is the risk of malignancy? The risk of malignancy is dependent on histology, morphology, and size. Tubular adenomas have the lowest risk. Villus adenomas have the maximum risk of malignancy. And villus adenomas are generally sessile. So sessile polyps have the maximum risk. Villus adenomas have the maximum. So basically, see, it is coming back to it. Tubular and villus is depending on the histology, and based on the morphology, it is sessile or pedunculated. That is whether you're seeing it on endoscopy or not. Depending on that, it is either sessile or pedunculated. So sessile and particularly depressed lesions have more malignant potential than pedunculated lesions. That means when you put a scope inside the bowel, so you put a scope, actually you have this diagram, it looks like it is in the outside of the bowel. That is wrong. I don't know why I drew it like this. This is what it should look like. So this is pedunculated and this is sessile. I mean, the polyp is projecting into the lumen of the bowel. It is not projecting from the serosa. So the risk of malignant change increases with size. Almost 1/3 of large colonic adenomas will have an area of invasive malignancy. So now what do you mean by high risk polyp? High risk polyp is 2 or more pre-malignant polyps which include at least, so out of these 2, at least one is an advanced colorectal polyp. Okay, and what is the meaning of this advanced colorectal polyp? It means it is a serrated polyp of more than 10 mm in size, or it contains any grade of dysplasia, or it is an adenoma more than 10 mm in size, or it contains high grade dysplasia. So if it contains 2 or more pre-malignant polyps, out of which one is an advanced polyp. Advanced polyp has a few certain criteria. What are those criteria? We'll just look at it again. So first is serrated polyp more than 10 mm in size. Second is containing any grade of dysplasia. Third is adenoma more than 10 mm in size, or if the adenoma contains high grade dysplasia. So any grade of dysplasia or adenoma containing high grade of dysplasia, or if the patient has more than 5 or more pre-malignant polyps, then that is also considered to be a high risk polyp. Now let us look at some of the syndromes which are associated with these colonic polyps. So a 25-year-old man has pigmented macules over the palms, soles and oral mucosa. He also has anemia and abdominal pain. Which one of the following is the most likely diagnosis? Now the moment that the question says macules over the palm, or pigmentation near the palms, soles and oral mucosa, your answer should be Peutz-Jeghers syndrome. So P for Peutz-Jeghers and P for pigmentation. So I have a image. You can see that there is perioral pigmentation. I think I have one more. Yes, there is pigmentation in the oral mucosa as well as in the sole. So Peutz-Jeghers syndrome, it is an autosomal dominant hereditary cancer syndrome. It is because of a mutation of the serine threonine kinase, that is STK11 or LKB1 gene. This is located on 19p. P is the short arm of chromosome 19. Clinical features, you will get this small brown or black spots. You will get multiple hematomatous polyps. The most common site of polyps in Peutz-Jeghers syndrome is the jejunum. So J is in Jeghers, J for jejunum. Most common symptom of these polyps is recurrent colicky abdominal pain, which is usually the result of intermittent intersusception. So because these polyps, they can form a lead point, and that lead point can result in intersusception. So these patients, they complain of lower abdominal pain plus palpable mass. Next, hemorrhage as a result of auto amputation of the polyps might also occur. Supposing if say these polyps, they auto ampute, then from the base of the polyp you can get hemorrhage. So this is most commonly manifested by anemia, and acute life-threatening hemorrhage is rare. Now, along with polyps in the jejunum, ileum, rectum and colon, you can also have malignancy in the pancreas, ovary, lungs, uterus, breast. Okay, moving on. Desmoid tumor is associated with which kind of cancer? With the colonic. So the answer is colonic polyps. Now, if there is a desmoid tumor along with the colonic polyp, then that means that this patient has familial adenomatous polyposis. So let us look at the extra-intestinal manifestations of familial adenomatous polyposis. So these manifestations can happen in the endoderm, ectoderm as well as in the mesoderm. So in the endoderm, you will get adenomas and carcinomas, particularly around the duodenal ampulla, but also in the stomach, small intestine, thyroid and biliary tree. You will also get gastric fundic gland polyps. You can also get a hepatoblastoma. There are also a few ectodermal derivatives. So in these patients, you can also get epidermoid cysts, you can get pilomatrixoma, you can get chirpy. Chirpy stands for congenital hypertrophy of the retinal pigment epithelium. It's a very important point. It's seen in FAP, that is familial adenomatous polyposis. You'll also see brain tumors. And mesodermal derivatives, you will see desmoid tumors, osteomas, and dental problems. So three things. I mean, in this, from this table, what is most likely to be asked in exam is, one is your desmoid tumor, one is osteomas, usually in the face, that is in the maxilla, in the mandible, can cause dental problems, and there is chirpy. So these are important points from this table. Now, for it to be called familial adenomatous polyposis, that is the number of polyps that should be present, it should be more than 100. So you can see over here, now this is a pic taken from Bailey and lab. There are so many polyps. So if it is more than 100, then it can be considered to be FAP. Yes, so the number of curated polyps for clinical diagnosis of familial adenomatous polyps is 100, more than 100. Now all these syndromes of colon cancer, right? That is FAP, Peutz-Jeghers syndrome, Lynch syndrome, Cowden syndrome. These are all autosomal dominant. You need to, this is easy way of remembering it. So a little memory trick, all these syndromes are autosomal dominant. Now, what are the dietary factors associated with colon carcinoma? Okay. Now, colorectal cancer is one of the most common causes of cancer death in the West. Among colorectal cancers, the rectum is the most, the cancers in the rectum are most common. See, rectum cancers consist of 1/3 of the cancers, and colon cancers are 2/3. But the colon is ascending colon, transverse colon, descending, sigmoid colon. So when you split all of this, the most common site is the rectum. Now, most of these colon cancers, you see something called an adenoma carcinoma sequence. Most colorectal cancers are thought to develop from an adenomatous polyp. That is why whenever there is familial adenomatous polyposis, there's almost 100% chance of these tumors turning into malignancies. That is why you can advise for a prophylactic colectomy. Because most colorectal cancers, they are thought to develop from adenomatous polyps through a sequence of genetic mutations which are influenced by environmental factors. The genes which are involved are the APC gene, KRAS gene and P53. This is associated with high intake of red meat, processed meat. Processed meat means meat which contains nitrosamines, nitroso compounds or nitrosamines. Dietary fiber has a protective effect on colorectal cancer. So supposing if the patient is eating increased roughage, so increased roughage is associated with reduced colonic transit times. That is, there is no constipation, the contents are evacuated fast. So this reduces the exposure time of the colonic mucosa to dietary carcinogens. Smoking and alcohol, they will increase the risk. High magnesium and calcium intake are protective. Antioxidants such as vitamin E and selenium are protective. Inflammatory bowel disease increases the risk because there is more inflammation. Cholecystectomy marginally increases the risk of right-sided colon cancer. So this is an MCQ question over here. If you do a lap cholecystectomy, there is a very small, there's a theoretical but a small risk of the patient getting ascending colon cancer. Now, surprisingly, aspirin, which is a prostaglandin inhibitor, that is supposed to be protective. Now, there are 4 molecular subtypes. These subtypes are called consensus molecular subtypes or CMS. So, CMS1, CMS2, CMS3 and CMS4. CMS1 is microsatellite instability, that is MSI. This is sporadic and it is present in the right-sided tumor. So easy to remember, the right side is where the colon starts, that is why it is CMS type 1. CMS2 is WNT and MYC. CMS3 is metabolic dysregulation. 4 is transforming growth factor beta activation. So the way I usually remember this is CMS1, there is an I over here, microsatellite instability. CMS2, you will get, there's no trick for this, WNT and MYC. 4, there is F4 and F4 factor. So what was the question again? Dietary factors associated with colon cancer are all except high fiber. High fiber is protective actually. It is protective. Low fiber is causative. Smoked fish is causative. There is no link with high fat intake. Here the question asked is what is associated. So the reason we are adding this question was you might think that you have to choose between either high fiber or low fiber, but they've not asked you what is causing colon cancer. They're just asking you what is associated, and fiber intake is associated with colon cancer. Okay, next, what is virtual colonoscopy? Virtual colonoscopy is also known as CT colography. So some patients, they do not want to undergo a colonoscopy for whatever reason. They might feel uncomfortable or for whatever reason, they do not want to undergo a colonoscopy. So in these patients, you can take a series of images. That is called a virtual colonoscopy. So in a virtual colonoscopy, what is true about virtual colonoscopy? Let us look at the theory first. Now, see, double contrast in barium enema, it has been largely replaced by CT colonography or virtual colonoscopy. So there is no role of a double contrast barium enema. Double contrast means you use barium as well as air. So instead of that, you can just use a CT colonography or a virtual colonoscopy. CT colonography is also used whenever the patient does not want to undergo a conventional endoscopy, right? Because you're going to take a series of images, it is extremely sensitive in picking up polyps even up to a size of 6 mm. So the advantage is it is not invasive like a colonoscopy, but again the problem is Since it is a virtual colonoscopy, you're not going to insert the scope, you cannot take a biopsy. Second thing is, if you decide to do a therapeutic intervention, you cannot do it. So it is used as a diagnostic tool in patients with a palpable abdominal mass. So the advantage of doing a CT colonography, that is a virtual colonoscopy, is you'll get a picture of the entire abdomen, right? So you can stage the cancer. You can stage, that is, you can see whether there is any extra colonic disease. So even though CT colonography can see whether there is any extra colonic disease, if you want to stage a patient with rectal cancer, you still have to do MRI. So this is an image of CT colonography. So this is the CT scan. Here the arrow, it shows you where the lesion is. And this image, this is a reconstruction of that image. This is a virtual image and it shows what the polyp looks like. So true about virtual colonoscopy, better image than conventional colonoscopy? No, obviously no. It can give you an image, but see, if you look at this image, you can see that it is not better than a conventional colonoscopy, right? It is performed by CT MRI. This is also false. It is performed only by CT. It takes more time than conventional colonoscopy. This is false. It takes less time. CT scan obviously takes lesser time. It is helpful in pathology outside the colon. This is true. Okay. In case of elective surgery of CS sigmoid colon, which of the following should be done? Now, now currently we are in the 28th edition of Bailey and Love. When I was in my MBBS, we were in the 25th edition. So in every edition, these guys keep changing as to what bowel preparation is required before surgery. I'm sure in the next edition, they will change this also. So you need to know what is given in this edition. So in this edition, it says, you have to memorize this. This edition, it says that if you want to do a colon surgery, you have to do a pre-op mechanical bowel preparation. So what do you mean by pre-op mechanical bowel preparation? You might give the patient a peg-leg enema, a proctoclysis enema. You might give the patient a proctoclysis enema, or you might ask the patient to drink peg-leg. So when he drinks peg-leg, it basically flushes out whatever is present in the colon. Along with the pre-op mechanical bowel preparation, you also have to give pre-op oral antibiotics. All right. The advantage of using the mechanical bowel preparation as well as the pre-op oral antibiotics is it reduces the surgical site infections, it reduces the anastomotic leaks, it reduces post-op ileus, it reduces reoperation, and it reduces mortality. Along with this, if you want to decrease the site of the chance of infection, you should tell the patient to bathe prior to the OT. That is, in the morning before he shifted to OT, he should bathe. And like in all surgeries, you have to give IV prophylactic antibiotics. IV prophylactic antibiotics are always given at the time of induction. Basically, what it means is when you make an incision, when you're handling that tissue, at that moment, the antibiotic should already be circulating in the blood. So it should be given before the surgery, right? Now, so when do you give it before the surgery? Do you give it in the pre-op room or do you give it on the table? It is always given in the operating room on the table just before you induce anesthesia or at the time of induction. So in case of elective surgery of the sigmoid colon, you have to do a mechanical bowel wash, plus you have to give the patient an oral broad spectrum antibiotic. This is pre-operatively. But on table, you have to give the patient IV antibiotics. Okay, we'll take a technical break here, then we shall continue.
Okay, they do not have any particular shape.
Okay. Is called the deciduum capsule.
So 600 grams would give
completely opposite to the pressure abrasion. Here
The wall of the forehead.
Ethyl alcohol 95% or the more.
Okay, they do not have any particular shape.
Okay. Is called the deciduum capsule.
so 600 grams would give
completely opposite to the pressure abrasion. Here
The wall of the forehead.
Okay, let's continue. I'm sorry about the very long break. There were some technical issues which caused this delay. Okay, a 65-year-old male complained of episodes of restlessness, chest discomfort and syncope. He said he felt dizzy while passing stools and noticed fresh blood filling the entire pan. His previous stool Qbanks test was negative and screening tests for colon cancer were also negative. There is no history of recent weight loss. What could be the most likely cause of the bleed? Now they've already told you that the patient does not have CA colon. So early CA colon is ruled out. Now the key to answering this question is in the fact that this patient has chest discomfort. So whenever there is bleeding in the stools along with chest discomfort, you have to think of Hyde's syndrome. Now, Hyde syndrome, there are three components. It is a triad of aortic stenosis, an acquired coagulopathy, and anemia due to bleeding from intestinal angiodysplasia. So, intestinal angiodysplasia is nothing but dilated submucosal veins and venules in the colon. So, this is the answer. Now, Hyde syndrome is due to induction of von Willebrand disease type 2A by the valvular stenosis. You will get GA hemorrhage. And the aortic stenosis might cause heart failure, syncope, chest pain. And if you do colonoscopy, you will get angiodysplasia. That is, you will get dilated mucosal and submucosal veins. And the colonoscopy is both diagnostic as well as therapeutic. Next, transmural inflammation with skip lesions in the colon are characteristic of what? So if it is transmural, that means it involves the entire wall of the bowel. So that is Crohn's disease. Skip lesions also is in favor of Crohn's disease. So now let us look at the differences between Crohn's disease and ulcerative colitis. Now in Crohn's disease and ulcerative colitis in both, this table is taken from Savage-Tin, by the way. The diarrhea is common in both, right? Rectal bleeding is less common in Crohn's colitis. Rectal bleeding is almost always seen in ulcerative colitis. Okay, before that, what is the basic difference between ulcerative colitis? Ulcerative colitis, it almost always involves the rectum. That is the first thing. And usually the colon is involved. So it is involved from the ascending colon, transverse colon, etc., till the rectum. Crohn's colitis, usually it involves skip lesions. So there might be a portion of the GIT which is involved. And then there is a area which is not involved. That is, you get skip lesions. Second most important factor is in ulcerative colitis, it involves only the mucosa. But so it does not involve the entire wall of the colon, whereas in Crohn's colitis it involves the entire wall. So abdominal pain or cramps. So cramps are more severe in Crohn's colitis and mild to moderate in ulcerative colitis. You can get a palpable mass at times. Sometimes you will get a palpable mass in Crohn's, but you will never get a mass in ulcerative colitis. You can get a mass in ulcerative colitis if the ulcerative colitis has caused a carcinoma and the carcinoma is causing a mass. So anal complaints are frequent in Crohn's colitis. You can get fissures, fistula in Crohn's colitis, but in ulcerative colitis, they are not that common. So etiological findings. Ileal disease is common in Crohn's colitis. It is rare in ulcerative colitis unless until there is backwash ileitis. Next, nodularity and fuzziness is not seen on radiological investigations in Crohn's, but it is seen in ulcerative colitis. So you have skip lesions. This is there are no skip lesions. It is a continuous lesion. So it involves a rectum always, which can extend proximally and continuously. So what kind of ulcers do you get? In Crohn's colitis, you will get linear or cobblestone ulcers or fissures. But in ulcerative colitis, you will get collar button ulcers. So toxic dilatation is not seen, that is, it is rare in Crohn's, but it is uncommon in colitis. But you can still get toxic colitis in ulcerative colitis. So on proctoscopy, so anal fissures, fistula abscess are common in Crohn's. Rectal sparing is common in Crohn's, but rectum is invariably involved in ulcerative colitis. There is no granular mucosa in Crohn's. It is present in ulcerative colitis. The ulceration is linear, it is deep, it is scattered. Here it is superficial, it is universal. Okay, so now let us look at the some of the findings of. Let us look at some of the imaging findings. So you can see over here that, so this looks like so you can see the string over here, this very, very small line, right? So this is the string sign of Cantor. String sign of Cantor it is seen usually in Crohn's. Then you have a cobblestone mucosa. This cobblestone mucosa is more common in Crohn's disease rather than ulcerative colitis. Okay, before that, let me show you some other images. So this is a pipe stem colon. What do you mean by a pipe stem colon? So you can see in some areas, so you can see over here, you can see these hostrations, right? You can see hostrations over here as well. But in the affected portion, it is smooth. The hostrations are lost. So this is called pipe stem colon, and it means the absence of hostrations. It is seen in ulcerative colitis. In ulcerative colitis, you get what is called as a collar button ulcer. So sometimes when you have a button in the collar, the button protrudes out. Similarly, you can get an ulcer which is protruding out. This is a collar button ulcer. Then in Crohn's disease, you get something called a rose thorn appearance. So this is a rose thorn bush. You can see these thorns coming out. Similarly, when you look at this image over here, you can see the small things coming out. This is the rose thorn appearance. This is more common in Crohn's disease. So let us look at the extra intestinal manifestations of ulcerative colitis. So you can get arthritis, sacroiliitis, ankylosing spondylitis, sclerosing cholangitis. This sclerosing cholangitis can progress to cirrhosis and hepatocellular failure. You can get cholangiocarcinoma, erythema nodosum, pyedema gangrenosum, uveitis, and episcleritis. Okay, let us discuss the known complications of stoma. That is, for example, a colostomy. What are the complications? So prolapse can happen, stenosis can happen, retraction can happen. So what are these? Let us look at these complications. Early complications, which are because of the stoma. So you can have poor location. This means where the stoma is not, the bowel is not exteriorized at the intended location. It is localized, it is exteriorized at the wrong location. Next is retraction. So supposing, say, this is the bowel, this is the anti-abdominal wall, and this is your stoma. Your stoma should be like this, something like this, but it should protrude slightly. But here it is not protruding, it is retracting. Then, because of inappropriate sutures, the stoma gets necrosed. That is, there is ischemic necrosis. There is detachment, so it has not been anchored properly. Abscess formation, or if it is opening in the wrong end. So you have two ends. You were supposed to take out the proximal end, always in the stoma, but you take out the distal end. So in the peristomal skin, you will see excoriation or dermatitis, and a systemic complication is a high output complication. That is a high output fistula. The high output fistula can also be a late complication. So what are the late complications? Late complications are stomal prolapse, stomal stenosis, parastomal hernia, a fistula formation, gas, odor, and parastomal varices, dermatosis, cancer. It can cause obstruction, it can be non-closure. Now let us look at some of the stoma formations. So here you can see that the loop of the bowel has come out. So this is continuous, right? So this is called a loop colostomy. There are two openings over here. This is the first opening and this is the second opening. The first opening is the actual stoma where the contents come out. The second is nothing but a mucous fistula. No contents are going to come out of that part. Now a Hartmann's stoma, I had discussed this in one of the previous sessions. Basically the distal part has been sutured closed. Proximal part is brought out in the form of a stoma. Now, what is a double barrel stoma? A double barrel stoma is, instead of bringing the entire loop out or instead of closing the distal part, both the ends are brought out. It's like the double barrel of a gun. So you have two openings here. Now, the patient must be explained the procedure of stoma properly. He has to be well motivated because he has to take care of the stoma, right? Also, the stoma should be through the rectus abdominis, because if it is through the muscle, this is what I meant by proper location. If it is through the rectus through a muscle, it will prevent prolapse and parastomal hernias. It should be through the flat surface of the abdomen because then it facilitates the placing of the bag. You should avoid skin creases. You should avoid bony prominences again for the bag. And it should be away from previous scars. Supposing if you do it in the site of a scar, because of fibrosis, because of healing, because of cicatrization, the stoma gets distorted. So let us look at some of these images. This is a stomal prolapse. So in a stomal prolapse, you can see that the stoma, it comes out. This is a prolapse. So parastomal hernia. So you can see this nice bulge all around the stoma, right? This bulge. This is nothing but the hernia. So this is a schematic diagram. So when you see the opening over here, the opening in this muscle, this opening should ideally admit only this portion, that is the stoma. But if some other loops of bowel are coming out next to it, then that is called a parastomal hernia. Then skin excoriation. This is especially seen in proximal stomas, that is in ileostomies. So that content, it irritates the skin around. So this is the actual stoma, but around it you can see skin excoriation. Then you have stomal necrosis. So you can see it has become black. Stoma retraction, that is the stoma is actually going inside. Now, the next question, supposing if you are doing an emergency laparotomy, during an emergency laparotomy for intestinal obstruction, which organ should be checked first to know whether it is small bowel or large bowel obstruction? The answer to that is, cecum. So, the cecum is used to distinguish between smaller or large bowel obstruction. If the cecum is distended, that means the large bowel, it is large bowel obstruction. If the cecum is collapsed, it means it is small bowel obstruction. Now, why is the cecum so special? It is because of the presence of the ileocecal valve. So there is there's already a valve or a natural obstruction, if you may call it, just proximal to the cecum. Okay, now gasless abdomen is seen in which of the following conditions? Gasless abdomen is seen in intersusception. So let us look at the other causes of gasless abdomen. The common causes of gasless abdomen are small bowel obstruction, bowel ischemia, congenital atresias. So, I mean, all three are basically nothing but obstruction. Ascites, pancreatitis, again pancreatitis, it will cause spasm of the adjoining colon, gastroenteritis, large abdominal mass due to displacement, and post-surgery following total colectomy, esophageal. Basically, a lot of the GIT is removed so that it appears it is gasless. Now, a paucity of small bowel gas, it may be a normal finding in some adults. Okay, so next, acute intestinal obstruction is characterized by which of the following? So, vomiting is common in duodenal obstruction. This is true. Pain after each attack of vomiting is characteristic of ileal obstruction. This is not true. In colonic obstruction, the distension is common than vomiting. This is true. So, so whenever there is a proximal obstruction, so supposing there is an obstruction in the duodenum, whatever is proximal to it, I mean the GIT dilates proximal to it, right? But since it is a proximal obstruction, you can vomit it out. But if it is a distal obstruction, say supposing if the obstruction is in the colon, so the portion of the large intestine that is distal to the ileocecal valve, it gets distended, right? The contents in that, it gets trapped. It can either go proximally because of the ileocecal valve, nor it can go distally because of the obstruction. So the abdomen progressively distends. Now the abdomen will keep distending as long as the ileocecal valve is functioning. Supposing the ileocecal valve stops functioning, that is it gives way, then the contents will enter into the ileum and then you can also get vomiting. So X-ray erect posture is diagnostic. This is true. And colicky pain to steady pain indicates strangulation. This is false. Supposing the pain increases, then that is characteristic of strangulation. Now, in the earlier editions of Bailey and Love, there were two X-rays. One is X-ray erect and one is X-ray supine. Both were used to diagnose small bowel obstruction. In the new edition, it says that an X-ray in the erect posture is not really necessary. It is only the supine X-ray which will give you a proper idea of obstruction. So now, why do you get this distension? So what causes this distension? So this distension because of two things. One is it is because of gas and it is because of fluid. Among the gas, there are many reasons of the gas being there. One, the most common source of gas is swallowed air. So as I'm talking right now, I'm swallowing air, and this is responsible for the huge amount of gas in the colon. Now, majority of the gas is also it is because of bacterial overgrowth, whereas fermentation. Now, what is the most common content of the gas? Majority is made up of nitrogen and hydrogen sulfide. Now, the fluid that is present in the bowel, it consists of various digestive juices. So you have saliva, bile, pancreatic secretions, gastric secretions. Now, over a period of 24 hours, I have the values. Why is this pen not working? Okay, over a period of 24 hours, the values have been mentioned. Now, what are the clinical features of obstruction? So, it is usually there are four symptoms. There is abdominal pain. There is absolute constipation, that is neither stools nor fetus is being passed. Then there is vomiting, and then there is distension of the abdomen. Now, pain is the first symptom. Pain occurs suddenly. It is usually severe. The pain is colicky in nature. I'm sorry, my pencil, it has lost charge, so I'm not able to mark. So the pain is usually colicky. Why is it colicky? Because the bowel is trying to get rid of the obstruction. So it is colicky in nature. The pain is usually centered on the umbilicus. So now there is foregut, midgut and hindgut. Foregut structures will cause pain in the epigastrium. Midgut will cause pain in the umbilical region. Hindgut will cause pain in the hypogastrium. Supposing if the pain becomes severe, then that suggests that it is strangulation. Now, vomiting. The more proximal the site of obstruction, the faster you get vomiting. The more distal the obstruction, the longer the interval between the onset of symptoms of obstruction and the appearance of vomiting. Now, in small bowel obstruction, the vomitus contains digested food. In large bowel obstruction, the vomitus contains fecal material. Now, distension is because of the gas which is present. There is absolute constipation. Okay, along with distensions, you might also see visible peristalsis. This is usually seen in thin patients, and if you want to provoke it, you can flick the abdominal wall, or you can even pour ether. Absolute constipation or obstipation, that is neither feces nor flatus is passed. And what about the bowel sounds? So initially the bowel sounds are high pitched, but that is because the bowel is trying to get rid of the obstruction, right? But as time passes and the bowel becomes fatigued or the bowel becomes tired, the bowel sounds stop. So it becomes a silent abdomen. Now, X-ray abdomen, erect X-rays are no longer routinely obtained. So even though in this question I have said that erect X-ray abdomen is diagnostic, that is according to the older editions of Bailey and Love. But in the newer editions, the radiological diagnosis of obstruction is based on a supine abdominal film. Supposing after doing a supine X-ray, you still have doubt as to whether the patient has obstruction or not, it is then that you will use an erect X-ray. So obstructed small bowel is characterized by straight segments. There is no or minimal gas which is seen in the colon. That is, usually you get a rectal gas shadow, that is normal. But here the rectal gas shadow might be absent. Now, you need to know something called the concertina or the valvulae conniventis. So when you look at, now I have adequate charge in my pencil. So this is the jejunum. You have these things which pass the entire width of the bowel. These are called valvulae conniventis. So these are regular paste. So when you look at this on the X-ray, it gives a concertina or a ladder effect. The distal ileum is featureless. A distended cecum will appear as a rounded gas shadow in the right iliac fossa. The large bowel will show hostile folds. What are these hostile folds? So this is the colon. You have markings like this. These are hostrations. They do not cross the whole diameter of the bowel, and they do not have any indentations placed opposite one another. So it is not opposite each other, right? It is not the entire width of the bowel. Now, what are the features of an X-ray? So there are two inconstant fluid levels. So one is at the duodenal cap and the other is in the terminal ileum. This is regarded as normal. So 2 fluid levels is normal. Up to 5 it is said to be equivocal, but more than 5 is diagnostic of intestinal obstruction. Now on an erect X-ray you will see air fluid levels, because when a person stands, because of gravity, this is all theoretical. Because of gravity, when the person stands, the fluid is below and the gas is on top in the bowel, right? And when the patient is in supine position, you can see that there is dilatation of bowels. Okay, so you can use a CT scan as well. A CT scan is highly accurate because it will also tell you as to what could be the possible cause of the obstruction. So you can see in this X-ray, you can see fluid levels like this. So this is a step ladder pattern. Now, what is the most common cause of small bowel obstruction? The most common cause of a small bowel obstruction is iatrogenic adhesions. Iatrogenic adhesions are the most common cause of small bowel obstruction. So let us look at the other cause of intestinal obstruction. So they are divided into two types. One is dynamic and the other is adynamic. Now in dynamic obstruction, that means the bowel is contracting, it is trying to overcome the distal obstruction. So this can be of 3 types. It can be intraluminal, it can be intramural, or it can be extramural. Intraluminal means the cause is present within the lumen. So it can be because of feces, foreign bodies, bezoar, or a gallstone. Intramural is it is in the wall of the bowel. So it can be because stricture, malignancy, intersusception, volvulus. Extramural is outside it. So that can be because of bands or adhesions. It can also be because of a hernia. And the second type of obstruction is an adynamic. In adynamic, the bowel is not trying to get rid of the obstruction. So these are 2 types. One is paralytic ileus and the other is pseudo obstruction, which is also known as Ogilvie's syndrome. So with this, we conclude today's session. We will resume tomorrow. So I wanted to cover around 200 questions. I finished around 100 questions today. The remaining 100 questions we'll be discussing tomorrow.